Today, almost the entire day is dedicated to the kidney. All right. So, to start off today's proceedings, we have two very senior people from the nephrology department who are going to deliver talks. One is kidney failure in adults. So today we would see how kidney failure affects people, and then what are the choices they have, how do they proceed actually for treatment. So first I would like to invite my colleague Dr. Anna for the first talk, which is kidney failure in adults. And Anna is a very academic, very enthusiastic, and very, very hard-working nephrologist we have. So she takes care of a lot of kidney failure in adults. So she is going to start off the topic and tell you what exactly is kidney failure and how do we go about it. Dr. Anna, please.
Good morning, all. First of all, thank you, sir, for such a nice introduction. Yeah, as sir already introduced, myself, Dr. Anna, consultant in the Fortis Hospital, Mohali. So I'll be covering about the kidney failure in adults. So my the overview of the presentation would be basics of CKD, that is chronic kidney disease, incidence, causes, and the treatment. So what is the chronic kidney disease? So we will get to know about from my presentation that it is a silent killer. So please listen it very carefully. I'll be asking few questions at the end. Very simple one though. So now we know why the Titanic sank. So as I already said, that the chronic kidney disease is the silent killer. So what we see is only the tip of the iceberg, that is less than 0.5%. And what is hidden is quite a lot, that is 5 to 10%. So why we should focus on CKD, that is the chronic kidney disease. It is a major global pandemic like diabetes mellitus. So diabetes mellitus and hypertension make CKD burden very high. So CKD predicts CVD, that is the chronic vascular disease, like heart diseases, so which is a major threat. Testing and therapy are inadequately used. Knowledge on CKD is at best sketchy. So testing and early therapy are economical, and most of the progression is preventable. And definitely this is not what we want. That is the ankle edema, facial puffiness, breathlessness, decreased appetite, urine output is decreased. So like my dear friends and colleagues, so what is commonly mistaken is, like any patient who is having a good urinary output, we assume that the patient is having normal. It's normal. He's not having any chronic kidney disease. So, but this is decreased urine output is not the only symptom the patient can have. So patient might be just not feel like eating anything, he must be having just nausea, he's just losing weight. There are different manifestations. So it can be the patient coming up to you, suppose in the emergency or in the ED department, and they'll be like, so we tell them that the patient is having a chronic kidney disease or a kidney failure, and we have to give the dialysis or the transplant. So the attendants, they look shocked. They were like, ma'am, the patient was absolutely better a day before. But so don't be mistaken that urine output decrease is the only symptom. At best, what can be done as a general practitioner? We can just order a simple blood urea, creatinine. To add on, I would also add urine analysis, which will tell us, I don't know whether you will able to get it or not, but urine analysis is a very simple and a cheap test which will tell us that the patient is having some kidney problem. So if we cannot handle it, we can immediately refer the patient to the nephrologist. And do we care about CKD? Do not realize that CKD is hidden in patients of diabetes and hypertension and in elderly people. So we see that in India, in fact, all over it's global, the diabetes and hypertension, they are one of the major comorbidities what the patient has. And the CKD is hidden in this set of population. So most doctors screen less than 10% of their clinic patients for CKD in its early stages. So patients are referred very late to the nephrologist, especially after the CKD is irreversible and we are left with no option rather than telling them to go for the dialysis and the transplant, which I'll be coming on, that which would be a better option. So only 1/4 of people with identified CKD get an ACE inhibitor. So I would just skip this point. So as we all know, what are the main functions for the kidney? There is a filtration which occurs, then reabsorption and secretion. So in a day, about 210 liters of water is filtered, and out of which only 2 liters of urine is excreted. And normal GFR, that is the glomerular filtration rate, is about 120 ml per minute per 1.73 meter body surface area. And at a time, only 20% of nephrons work at a time. So what is kidney failure? So now, or the end-stage kidney disease. Earlier we used to label it as end-stage kidney failure, but because of the general population, they were not able to understand the terminology of renal, it was changed to end-stage kidney disease or kidney failure. So if we go by the definition, so there is a difference between the chronic kidney disease, kidney failure, or end-stage kidney disease. So what is a chronic kidney disease? So chronic kidney disease, that is a kidney damage for 3 or more months based on findings of abnormal structure, abnormal function, blood test, or the urine analysis. As I already mentioned, suppose we get an ultrasound or the radio imaging done, and what we see, the kidney size are small. In the adults, we take it about 9 centimeters or this thing. If the kidney size are shrunken, it means the patient is having a chronic kidney disease. Then about the blood test, which I already made a mention of, blood urea and creatinine and urine analysis, in which we get to know whether there are WBCs, RBCs, or protein. Or the glomerular filtration rate, which normal is about 120 ml per minute of body surface area, that is below 60 ml per minute per body surface area for 3 or more months. To make a mention, to label it as a chronic, we need a GFR below 60 for 3 or more months. So anything less than that, that would be acute or acute kidney disease. And what is end-stage kidney disease or the kidney failure? That the GFR below 15 ml per minute per body surface area. Or there is a need for the kidney replacement therapy, which would include both the dialysis and the transplant. So these are the various clinical stages according to which it has been divided to 1, 2, 3, 4, and 5. So what is it like? So in kidney damage, what do you call? In the kidney failure, that is the ESKD, the GFR is less than 50. So basically, we should start screening at the stage 3 itself. So having kidney failure means that 85 to 90% of your kidney function is gone and they don't work well. So there is no cure for the kidney failure. Definitely, the prevention is better than cure, but once it has been reached, there is no cure for it. But it is possible to live a long life with the treatment. So having kidney failure is not a death sentence, and people with kidney failure live active lives. So, and CKD, or the kidney that is emerged as one of the most prominent causes of death and suffering in the 21st century, and it is a progressive condition that affects more than 10% of the general population worldwide, accounting to more 800 million individuals. And so this is briefly an epidemiology which was published in Kidney International, which says globally, all over world, it's about 843.6 million people are affected with the chronic kidney disease, and this is the figure of 2017. If you could see, there is approximately 1 in 10 individual is having a CKD. And if we see that it is a leading cause for the death, so the death rate has significantly increased to 41.5% to 2013 to 2017. And it will be the fifth leading cause of death in the upcoming by 2040. So this was another article which was published in Journal of Clinical Nephrology and Renal Care, which says that the CKD belongs to the category of non-communicable diseases, and according to WHO, it kills about 47 million people each year, equivalent to 7% of the deaths globally. And there is a limited information available about the state of kidney health in India. In Western countries, diabetes and hypertension account for 2/3 of the cases of CKD. I mean 2/3. If we would be very serious and screening about the patients with diabetes and hypertension, we would be covering a major chunk of it. So this was a study which was done in South in India as well. In India too, the diabetes and hypertension account for 40 to 60% cases of CKD. So the age-adjusted incidence rate of ESKD in India was 150 per million population, and more than 1 lakh new patients enter kidney replacement programs annually in India. So, and a recent multi-center study in India, the prevalence of CKD was about to be 17.2%, out of which 6% were having CKD stage 3 and above. So these reports suggest that needs to be focused on kidney diseases in India. And there could be effective screening and preventive strategies for non-communicable diseases, especially diabetes and hypertension, along with screening for asymptomatic kidney disease. So this is a brief data about the prevalence of CKD in India. There are different studies which quotes about different prevalence, percentage, but this is only because of the difference in the cutoff they have used as a criteria for CKD. So what are the causes and the risk factors? So these are briefly the risk factors that are diabetes, hypertension, any coronary artery disease or heart disease or stroke, obesity, family history. To make a mention, tobacco use is one of the great risk factor for the chronic kidney disease, and elderly as always a risk. So the other, just to enumerate, the loss of renal mass. Now you would be wondering that why have I put it in bold, loss of renal mass? Does any one of you can make a mention of it? Why I specifically made a mention of it? As we are already dealing with you're all transplant coordinators. So what happens when we tell there is a donor and is going to give a kidney? So one kidney is gone. So that is a loss of renal mass. So do you think so that the donor would be increased risk? So definitely that patient has to be in the constant follow-up, as these patients are more prone for having some proteinuria and hypertension. It's not a threat, but definitely they are among normal. If we consider about the general population, they have to be under proper screening. The other would be the drugs, the painkillers. We commonly see we have been prescribed. This is one of the risk factor, and the systemic infections. So again, to make a mention, 2 most common causes of CKD, that is the diabetes, they account to 50% of the cases, hypertension 27%, then miscellaneous would be 10%, and the glomerular diseases would be 13%. This is again the bar graph showing the same. So what I am just discussing about the treatment for the end-stage kidney disease or the kidney failure, not the other stages of the CKD. So there would be a palliative care and the definitive treatment. So dialysis or the transplant. So according to you, which one do you suggest? I mean, dialysis or transplant? Definitely this is a transplant program. Everyone would say the transplant. But any one of you, any one thing which you could think of, the transplant is better as compared to dialysis? Or dialysis is better as compared to transplant? Any one of you? Among the coordinators? All right, let's see. So this is just the palliative care, so in which the patients, we just manage the pain, symptoms, and other complications, explain the disease, treatment options, and manage expectations, help the patient and family make critical decisions, support the family and patient in coping with the mental burden, and guide you to advanced care planning. So these are the treatment options for the kidney failure: dialysis or the kidney transplant. So the dialysis would be the hemodialysis or the peritoneal dialysis, and the kidney transplant, in which a diseased kidney, it's not basically to replace, but yes, we put another kidney. So again, now we'll be saying the transplant or the dialysis. So simply, this is the pathway to the kidney transplantation. So the patient can either, whenever the patient comes to the emergency, it's not fit for the transplant straight away. So you prescribe the patient the dialysis therapy, and then you can just counsel for you can start the workup for the transplant. So the transplant can be deceased donor or the live transplant. So in the deceased donor as well, they can be the expanded criteria or the standard criteria. Or simply, if the patient is having a kidney stage, end-stage kidney disease, is asymptomatic, so we can go for the preemptive transplant. So compared with the dialysis, the kidney transplant is associated with better life expectancy, that the life expectancy is increased, and this has been seen with various studies. We always say that the dialysis vintage, the more the dialysis, better, it's less that the patient would be having a good transplant outcome. But they studied that there were the patients, they had the dialysis duration of more than 10 years, and what they could see was the transplantation is associated with better survival in patients who were actively waitlisted with dialysis exposure of more than 10 years. So this again, so having a transplant can add more years to your life. This was a data from the US in 2013, in which you say the bar graphs. The red one is the dialysis, which can clearly see that the patients, definitely the deceased donor as well as the live donor has a better outcome as compared to the deceased donor. So patient survival after kidney transplantation versus hemodialysis. So there is an annual mortality rate for patients under dialysis range from 21 to 25%, with less than 8% with the deceased ones and less than 4% with the live ones. And the benefit of transplantation is most notable in the young people and in those with the diabetes. As we can clearly see in the diabetes, the duration of life is increased by 25 years. So again, the graft survival after leaving donor versus deceased donor. Again, the live donor is better as compared to the cadaveric donor. But however, because of if there is no live donor, we can go for the deceased donor rather than to be on the dialysis, as I already showed in my previous slides. So again, the patients would have better quality of life with the transplant. So numerous studies have detailed there is an improved quality of life satisfaction, physical and emotional well-being, and ability to return to work higher in transplant recipients. Uremic complications are almost fully reversed, and fertility returns. So there are fewer dietary restrictions, and there is a lower treatment cost. And if you see the mean cumulative cost for dialysis and transplant are equal for first year, and then it's lower for the transplant, and the less cardiovascular complications. So this we see is about the cardiovascular risk. What we see that the patients, as compared to the general population, the patients with chronic kidney disease have higher chances of mortality with the functioning graft because of the heart diseases. So what we see that the transplant patients have lower mortality with chronic heart disease as compared to the ones who are continue to be on dialysis. So this is briefly regarding, as I already made a mention, that we have a long waiting list, and there is about, in India, if you see that India has a diseased organ donation, the rate of 0.05 to 0.08 per million population, compared to more than 20 per million in countries like the United States and the Spain. So what you see in this graph is, so if you see from 1999 to 2017, there is an increasing number of patients or the active waitlisting for the kidney transplant. However, the pool, the live as well as the diseased one always remained same. So the transplantation looks good, but through painful pathway. An Indian study by Panwar et al. Identified that only 1.4% of subjects willing to donate organs actually registered their names for the organ donation. So it's a lack of motivation, lack of faith in the healthcare system, figure of disfigurement, lack of incentives, fear of procedural delays, and inappropriate counseling accounted for this attrition. So this, just a last slide, this is supply and demand. So not every death is equal to organ donation. Not every organ finds a donor. Not every patient finds an organ. So that leads to desperation. So in a summary, the chronic kidney disease is a debilitating condition. An urgent, appropriate intervention tends to prolong life and prevent a sequelae of complications. Kidney transplantation offers benefits compared to dialysis, and transplant tends to prolong life more compared to dialysis. So before you ask me questions, let me ask how effective my presentation was. So, which patients needs to be screened for chronic kidney disease? On the mic, please. Yeah. Right, absolutely true. So if we focus that these are the two set of population that we should focus on, they would be diabetes and hypertension. So two most common cause for CKD? Exactly, again diabetes and hypertension. So what do you say, transplant versus dialysis?
Transplant.
Any one advantage of transplant?
Better life expectancy. Quality of care.
Right, very true.
Thank you.
Thank you, Anna. Thank you. That was indeed a very, very lucid, wonderful, and very simplified version of what actually CKD is. Can you just go back to one of your slides in which you have showed the survival, living donor kidney survival? I just want them to have a look and take home the actual crux. This is the deceased donor.
This one's?
No, go back. Yes, this one. So how many of you have understood this slide? Actually, so that I want one of you to stand up and interpret this slide and tell me what is the take home for the audience. Anyone who has understood this slide? Where is your mic?
According to me, I think mortality is less in transplant compared to dialysis, and there is a survival rate is high in transplant compared to dialysis.
Excellent. Can you define it further? Can you clarify it more emphatically? That's a very basic statement. Anybody else would like to attempt that answer? What does this slide actually, this is a very beautiful slide, and as a transplant surgeon, I fall in love with this slide. Thank you, Anna, for bringing this slide. So, anybody else would like to interpret it? Yes, please.
Sir, this slide shows that the 10-year survival rate in the transplant patients is about 80%, and in the dialysis patients is about 10%.
Wonderful. So, if we see the corollary, it means we have got 100 patients who have developed chronic kidney disease, and they either require a dialysis or a transplant. This is the time period. We are following these 100 patients for next 10 years. So if these patients are put on dialysis, you see there is a drop in their survival. So after 10 years, if 100 patients had started dialysis at the end of 10 years, how many would be alive? 10. And if they receive a transplant, how many of them would be alive? 80%. So this is what is the difference in the survival, which is very, very much. एक ऐसी treatment modality है जिसमें कि हम मरीज़ का इलाज करते हैं तो मरीज़ के ज़िंदा रहने की संभावना 80% है, और एक ऐसी modality है जिसमें हम मरीज़ का इलाज करते हैं तो उसके ज़िंदा रहने की संभावना less than 10% है, और ये NIH का डेटा है. NIH का डेटा है मतलब कि जहाँ पे सबसे बढ़िया क्वालिटी की डायलिसिस होती है और पेशेंट्स बहुत अच्छी मशीनों पे डायलाइज होते हैं और बहुत रेगुलरली डायलाइज होते हैं, उनको किसी मेडिकेशन की कमी नहीं होती, गवर्नमेंट सारा कुछ पे करती है. दिस इज़ नॉट द इंडियन डेटा. इफ़ वी सी द इंडियन डेटा, इट विल कम, दिस ग्राफ विल फॉल हियर. So hardly any patients are able to survive beyond. You can count on fingertips patients who see 10 years and through. And Anna, I just want to put up one more question. You showed that for labeling a patient to have chronic kidney disease, the GFR should be less than 60. That's what you said. But in the classification, it is said that CKD 1, 2. So how do both the things go together?
Even the earlier stages also, it has been so basically we are focusing about the GFR earlier in 60 to 90. These are basically the category 2. We are mainly including the one with the CKD 3 because there the symptoms and signs develop. Or 0, there would be 0, 1 and 2, in which even the 0, the diabetes, as I already said, the diabetes and hypertension, they would be included under category 0. So but the symptoms and signs, they come, that develops in stage 3.
So any other question? Yes, please.
So thank you, ma'am. Ma'am, my question is that in the CKD and diabetes, both kidneys are equally affected or some variation right and left kidney?
So when we label it as a chronic kidney disease or whenever the symptoms manifest, they are both of the kidneys which happen. There's not a single kidney, they are both of the kidneys.
Equally
so that's
affected.
why equal. So when we do a biopsy, we just do a biopsy of a single kidney.
Okay.
So thinking that it's entirely, whatever manifestations, that's what, a very good question, that's why I mentioned, even if we ask for the donors, we tell them to donate a kidney. So one kidney is gone, they are living perfectly fine with a single kidney. So whenever any manifestation or something happens in your body, they're both the kidneys which occur simultaneously.
Thank you, ma'am.
Just to extend that further, as Anna had showed in one of her slides, that at a time only 20% nephrons are functioning in a kidney. So that means we have an 80% reserve nephrons. So once one kidney is taken out, these reserve nephrons will undergo hypertrophy and they will compensate for the entire body. So if you commonly see donors, once they donate a kidney, the other kidney grows in size. Similarly, liver donors, they donate half of the liver, their liver regenerates. Similarly, in the recipients, if we see the kidney which is put, it was 9 centimeters, after 2 years you do an ultrasound, it is 13 centimeters. So it undergoes hypertrophy. Okay. Any other questions? Yes.
Ma'am, in one of your slides you have written that one of the advantage of transplant is return of fertility. Then how is it concerned with the CKD?
CKD is not just decrease urine output or decrease appetite. So if you study the data, so even if the creatinine of more than 1.5, the fertility decreases. So the patients, if you see the data, that means even in the males as well as the females, so they have to be under the patients, the females who are trying to conceive, so they have to be in a regular follow-up, and we tell, because it has been seen even for the patient as well as for the fetus, the CKD is one of the risk factor, and that leads to more of the.
Thank you, ma'am.
As surgeons, when we define a transplant, so a transplant brings physical, mental, social, professional, sexual, and personal rehabilitation. So once you see a patient of CKD, we are sitting in the OPD, the moment a patient walks into the OPD, you can make out that this patient has CKD. The skin luster is gone. The patient is severely anemic. The hemoglobin is around 4, 5, 6. So you can make out right when the patient is walking that this is a patient of CKD. So once the patient's hemoglobin is less than 6, 7, most of the women are amenorrheic. They don't have their periods. They are not able to conceive. As soon as you transplant them, they will return to their active life. So a transplanted patient in today's date, our aim is that a transplant patient should be as normal as possible. We encourage our patients to adopt a very healthy lifestyle, play transplant games. There's a World Transplant Olympics Federation in which these patients go and participate as a normal patient. So if there are patients sitting inside the audience, you won't be able to know that this patient is a transplanted patient. And once you see a CKD patient, you will not be able to forget how a CKD patient looks like. Okay. Anna is a very accomplished nephrologist. She brings expertise from All India Institute Medical Sciences, New Delhi, as well as PGI Chandigarh. तो इनके जितना लर्नड अभी कोई नहीं बैठा है हॉल में. You can put all your questions to her. We have 10 minutes for questions. You can go ahead with questions.
Thank you, ma'am, for excellent session. So I've seen one patient like he got a transplant, and after that, he was on hemodialysis. So it is possible.
See, so I would start the question. Yes, that is possible. Like suppose when we are born, our kidneys are perfectly functioning. We end up dialysis and we are going to transplant. So that is just the treatment option. But yes, the patient can go on to dialysis and there are multiple factors for it. And there is a huge list. Huge.
Okay.
So, but whatever data, what you have at this point of time, every factor is being considered and then the data is put. Yes, there are the basic disease, whether the patient was compliant to the treatment or not, whether the patient already had infection. There are multiple reasons, whether the patient, whatever the donor was the donor, that's why we talked about the disease versus life, why the life is better, because in the disease there would be less of the delayed graft function, there would be more chances of rejection as compared to life. So even if a patient who has been transplanted previously, suppose, and he's going for the second transplant would be more of the rejection because he's sensitized. So yes, that is possible.
So in this case, dialysis is better than second transplant.
No, I would not say the dialysis is better. See, this data is only about the dialysis so how much percentage of patients do you see is having their transplant failure and going on to dialysis?
So ma'am, this data is only for first transplant, not
Yes,
second.
this is about the first transplant. Actually, there are very few patients. If you see, if it would not have been such a success and we would not have given such an option to the patient.
See, there could be two types of dialysis after a transplant. One is an acute phase. Abhi transplant, this is most commonly seen in a deceased transplant. The kidneys, there are two sources of kidneys. One is a living donor, which is very, very healthy donor. One is a deceased donor. Somebody has died and we have taken out a kidney and then put into somebody. So the deceased kidneys have a phenomena which is called as delayed graft function. Because these kidneys are traveling for 6 hours, 7 hours, coming from somewhere. Once we put these kidneys will not function immediately. So the time period during which this kidney functions, usually of 14 days, 2 weeks, for this period, patient requires hemodialysis. Dialysis is a way of cleansing the body. Actually, if we put a kidney inside a body, the kidney is working 24 hours. Whereas a dialysis is done maybe twice a week or 3 times a week, hardly for 3-4 hours. So
yes.
in the interim period, the abnormalities get accumulated and then we remove it. So what happens is, this is acute dialysis. The other is a patient of transplant who has received a transplant, lived a healthy life for some time, and he returns back to dialysis. The answer to that question is, see, every patient has a different etiology of kidney failure. किसी की kidney diabetes से fail होती है, किसी की hypertension से fail होती है. What happens is, जो मदर नेचर ने, जो ईश्वर ने, प्रकृति ने उसको किडनी बना के दी है, उसकी भी एक लाइफ थी. 30 साल के बंदे को किडनी फेलियर हो गया, 35 साल में हो गया, 20 साल में हो गया, बच्चों में हो गया. This kidney is an artificial kidney which is being helped by individuals like us. So this kidney is also going to have a life. So this is called as a graft life. एक किडनी की अपनी ज़िंदगी होती है. अगर हम उस बंदे का ट्रांसप्लांट नहीं करते तो वो शायद 2-4 साल जिंदा नहीं रहता. जब उसने ट्रांसप्लांट करा लिया, उसने 10-15 साल जिंदा रह गया. अब फिर वो किडनी ख़राब हुई, फिर से वो डायलिसिस पे गया, उसका ट्रांसप्लांट दोबारा हो सकता है. सो इन द इंटरिम पीरियड द पेशेंट एक्चुअली इज़ लिविंग. And if you go to a developed country like US, if you go to UK, if you go to Australia, there are patients who are walking with 5-6 kidneys. हर 10 साल में एक किडनी ट्रांसप्लांट कराया और फिर 10 साल निकाल गए. फिर 4 साल बाद किडनी खराब हुई, फिर चौथी किडनी लगाई, फिर निकाल गए. फिर so there are people who receive multiple transplants also because the organs are available because of deceased donation. So actually the patient is living, and the most important point is that the patient is living. As I told on my first day, a living problem is better than a dead solution.
Yes.
So the entire exercise is to make the patient live at least. So return to dialysis is not a bad sign. A median graft life of a living donor kidney is around 20 years. Median graft life of a deceased kidney is around 10 years. So actually the patient is living. 10 years is a huge time for somebody who is not able to live for 3 years. Okay.
And,
Hello, sir. I just want to share my experience that one of my brother-in-law, he had that kidney transplant. It is now more than 10 years, and he's doing perfectly fine. And actually, he had, I think, due to hypertension or some reasons, he had to undergo that transplantation. But unfortunately, he had to undergo twice because first time, I think, after transplantation, some iatrogenic reasons, kidney biopsy has to be done, and he bleeds so profusely that he had to undergo again. The father, I think father has given the kidney for the second time, and that kidney is doing fine, and it is now almost more than 10 years that he is perfectly okay, but he has to maintain certain dietary precautions and on drugs and all. He went abroad and he got married last year. I think he's expecting a child also
Wonderful.
next year.
This is the
But
best.
the life expectancy, no doubt that it increases with the transplant patients, and there's no doubt in that because I have seen it personally. But I think that after transplantation, the most important thing is the patient needs to be on those drugs, and that drugs are too costly that sometimes the patient, they don't afford those drugs.
So more importantly, just to, because this is a very first statement you have made, the success of actual transplant is in follow-up. Surgery is hardly 2 hours job. Surgery किया तो मरीज निकल गया, लेकिन जो मरीज successfully follow up करते हैं, because there are so many preventable problems in a transplanted kidney. Not only, so we have a protocol by which we go on tapering the medicines in due course of time. अगर उसकी मेडिसिन 15,000 रुपए की पहले महीने में चल रही है तो 10 साल बाद वही दवा 3-4 हज़ार रुपए की हो जाएगी. सो देर इज़ अ, जैसे जैसे वो किडनी बॉडी के अंदर रहती है तो वो अडॉप्ट होती जाती है और इम्यूनोसप्रेशन की नीड कम होती जाती है, बिकॉज दीज इम्यूनोसप्रेसिव मेडिकेशंस हैव साइड इफेक्ट्स, दे आर कॉस्टली. सो clinicians all over the world try to decrease the level of the immunosuppression, prevent the kidney from rejecting, as well as prevent the patient from getting infections because of immunosuppression.
Right.
So the actual success, जो lifestyle changes हैं, जैसे कि exercise है, diet है, ये इतना major role play करते हैं patient की life में कि you can't believe. There are patients who are on very minimal dose of immunosuppression, just 1 tablet in a day. So that this tapering is only possible once the patient is in active follow-up with the clinician. So if somebody is following up, if the transplant history is very decent, there has been no rejection, we try to keep on decreasing the immunosuppression. So that is how it is, but this is only, most of the patients होता क्या है कि जब तक उनका ट्रांसप्लांट नहीं हुआ होता तो वो बिल्कुल जीने मरने में लगे होते हैं, तो डॉक्टर के हाथ पैर पे बिल्कुल गिरे रहते हैं. The moment they are transplanted, they are so happy, they roam around the world, they go everywhere except the doctor.
एक्चुअली हमारे इंडिया में ऐसा कुछ है नहीं ना सर. एक्चुअली व्हेन ही वाज हियर, उसकी ऑलमोस्ट मंथ में 6-7,000 की मेडिकेशन आती थी एवरी मंथ. नाउ ही वेंट अब्रॉड टू कनाडा, वहाँ पे सब कुछ उसका फ्री है, उसको सारे मतलब ड्रग्स वहाँ पे फ्री मिलते हैं. बट यहाँ पे जो लोग ट्रांसप्लांट अफोर्ड भी कर सकते हैं, बट आफ्टर दैट ट्रांसप्लांट जो ड्रग्स की कॉस्ट है या बाकी डाइटरी रिस्ट्रिक्शन, समटाइम्स द पेशेंट दे डोंट मेंटेन दैट.
See, if we are only seeing one part of it, if you compare the cost of treatment of a dialysis versus a transplant, we'll show you in later presentations. जो डायलिसिस की कॉस्ट है, एक बंदा अगर देखो 1,500-2 हज़ार रुपये का तो डायलिसिस होता ही है, और एक महीने में कम से कम 8 से 10 डायलिसिस होते हैं, तो 20,000 रुपये की तो डायलिसिस कॉस्ट हो गई. इसके अलावा 20,000 रुपये की दवाइयाँ, तो 40,000 रुपये एक महीने का खर्चा. इसके बाद वो हर 3 महीने पे एक बार एडमिट होगा, कोई ना कोई कॉम्प्लिकेशन से होना ही होना, 100% एडमिट होगा. देन कभी उसका फिस्टुला खराब हो रहा है, कभी लाइन पड़ रही है. सो दे आर मल्टीपल प्रॉब्लम्स विच आर एसोसिएटेड. दीज पेशेंट्स डेवलप कार्डियोमायोपैथी, देयर हार्ट गोज डाउन, they have fluid filled lungs, so there are multiple complications and the data has clearly showed, very clear, जैसे इन्होंने crisp data दिखाया ना कि जहाँ patient 16 months of dialysis क्रॉस करता है तो वो ट्रांसप्लांट की कॉस्ट को निगेट कर देता है, उसके बाद उसका खर्चा बढ़ता जाता है एक्सपोनेंशियली. सो द मोर द पेशेंट इज ऑन डायलिसिस, उसका एक्सपेंस ऑन डायलिसिस इज मच मोर. सो दिस इज बिकॉज यू हैव टू कंपेयर बोथ. देखो जिंदगी तो जीनी है, देयर इज अ सर्टेन कॉस्ट ऑफ लिविंग विच इज एसोसिएटेड विथ लिविंग. So these medications, If you are into active follow-up, these medications usually 4-5 साल में are less than 5,000, most of the patients, which is almost affordable.
And moreover, the first is the life. Then comes the medicines. If you will be on dialysis and the patient is no more, what would medicines do and what would the dialysis do? And I clearly made a mention I did not put any figures or data for the cost, but yes, it clearly mentioned for the first year, the dialysis and the transplant are equal. But if you see the mean cumulative cost, that would be definitely less with the transplant.
एक्सक्यूज मैम जो CKD स्टेज 1 एंड 2 है दोनों में मेडिकल मैनेजमेंट से काम चल जाता है या
1, 2, 3, 1, 2, 3, 4, all with the medical management. So kidney failure, end stage kidney disease, it's only the 5 when your GFR is less than 15 and or you are needing a dialysis or the renal replacement, renal transplant.
Thank you.
So that's what, all this is the medical management.
More important than the medical management is the lifestyle change. Suppose somebody is developing kidney failure because of diabetes. So once he controls his diabetes, his sugar levels are controlled, his weight is controlled, his diet is controlled, maybe he is in CKD1 for next 10 years. He doesn't go into CKD2. So lifestyle change is one of the most important tenets of management apart from medications. See, medications will help only control the symptoms which are arising because of CKD. But if you change your lifestyle, there could be cases where CKD does not progress at all. हाँ महेंद्र, आपका क्वेश्चन क्या है?
सर एक्चुअली क्वेश्चन ही मैं थोड़े टाइम के लिए मैंने PSRI में जॉब किया है विद डॉक्टर के अग्रवाल दिल्ली में. देन ही यूज्ड टू से कि डायलिसिस डज नॉट किल द पेशेंट, द डिप्रेशन किल द पेशेंट, विद द नेगेटिविटी कि वो पेशेंट अब शायद हमेशा डायलिसिस पे रहेगा. और जो ट्रांसप्लांट है, ट्रांसप्लांट इज ए पॉजिटिव कि अब उसका ट्रांसप्लांट हो गया, नाउ ही कैन लिव द नॉर्मल लाइफ. और जो डिप्रेशन है जो डायलिसिस पेशेंट्स में, that is going to further with the other clinical disease also. So what is the role with the ESRD or the CKD and the patient's mental status?
See, what you see, like if the patient is on dialysis, so what we say is adequate dialysis is about thrice per week, 4 hours a day. So if you see every other day you are visiting a hospital and your attendant is coming and sitting, sitting with you 4 hours to be in the hospital, and after that when the fluid has been, it has been drained off, so again you feel weak, you come back home, you're like, no, पानी नहीं पीना है, नमक नहीं खाना है, weight ज़्यादा बढ़ जाएगा. So just, so this is, you can see the patient can go to work, he cannot go, no, I cannot go because I have to go to the hospital and get my dialysis done, otherwise I would not survive. So you can well imagine the depression. If suppose we are bound to live a day, at home, even for Sundays, if we always say, let's go for an outing. We cannot even stay at our home for just a day. So how can you expect these dialysis patients to be on lifelong dialysis? And the dialysis, especially the hemodialysis, you are puncturing it, even you have a fistula, but the pain of that puncture, it hurts.
Thank you.
Yes, this should be the last question. Mic उधर pass कर दो.
Good morning, sir. Good morning, ma'am. My question is it possible that if a female is pregnant and had cesarean section, after that she suffers from kidney failure?
See, the patient, yes, that can have it, but not always. So there are multiple factors which are, playing a role when it happens. So if you see, if the patient, the urine analysis, I would say a urine analysis which would be just, except a nephrologist, everybody would say, what is the simple urine test? That would give you a clue. So whether the patient is having a kidney problem, that would be just a protein leakage in that. That will give you one of the things that the patient might develop a failure. Second, the hypertension, the increased blood pressure readings. So what happens in hypertension during pregnancy? Usually what is it like? Normally there is a decrease in the blood pressure. So what happens is, even during the second trimester, whenever what we call is eclampsia or preeclampsia, So these are one of the factors which can also lead to this thing. And many of the basic disease of the kidneys, what like we commonly say is that hemolytic uremic syndrome or TMAs, they are very common in the pregnancy, and pregnancy is something genetic thing. You know, sometimes you just need one more trigger, and pregnancy is just a trigger. So that will manifest.
Ma'am, actually, I had a personal experience for this.
Yeah, I got that.
That's why I was asking, because I had a family relative, and she suffered because she was not having any kind of problem. No, ऐसा कुछ भी diagnosed नहीं हुआ था when she conceived. But after the pregnancy and after that cesarean section, we all got to know that all of a sudden, she suffered from kidney failure.
So the other thing, the genetic plays a very important role in that. And the second thing, when you go, like there is a massive blood loss during the pregnancy, the PPH ho gaya, APH, or like, so the patient tends to have a lower blood pressure readings, and what we commonly see that the kidney is a very vascular organ. So right, so the kidney blood perfusion is decreased, blood pressures are low, the kidney, they develop the cortical necrosis. So why this in pregnancy we get the kidney failure, even when our sick patients are having hypotension, decreased blood pressures, but they never have, end up having a kidney failure. This is just again because that time we have to go with the genetic workup. So these are the
So many a times there are certain drugs. So in patients who don't have any history of pre-existing chronic kidney disease, drug-induced interstitial nephritis is one of the commonest causes of kidney failure, which we are not able to know. There are so many medicines, even paracetamol, diclofenac, painkillers, antibiotics, which are used over the counter. So these can cause drug-induced interstitial nephritis, which all of a sudden leads to permanent irreversible kidney failure. You never know what kind of painkillers, what she given. So even there are cases in which a single dose of an antibiotic leads to a severe interstitial nephritis, and the creatinine shoots up from 1 to 3. So there could be multifactorial reasons, and yes, pregnancy, we have seen, we have operated, we have transplanted patients who have developed kidney failure during or immediately after pregnancy. It is quite common. Anyway, so that brings us to the end of this session, and I would like to personally felicitate Anna for a wonderful talk, and simultaneously extend my gratitude and welcome her to our department once again. So, as Dr. Anna rightly pointed out, there are so many signs and symptoms for kidney failure in adults. But have you seen children? How many of you have been posted in neonatology or pediatric wards? How many of you have seen children as patients? So, what is the difference between an adult and a child patient? What is the main difference? A child doesn't tell anything. There is no symptom. So the doctor has to be 10 times more vigilant, more experienced, and more catchy to catch up whatever is the problem. The children don't bring any symptom. They will just cry, keep on crying. And it is very difficult to diagnose children, especially with a silent disease, which is chronic kidney disease. The other thing is it is equally difficult to treat. There is no vascular access. There are so small vessels. You can't put a vein flow. You can't put a dialysis catheter. You can't put a CAPD. So these are very, very difficult. The pediatric population is very, very difficult to manage with chronic kidney disease. And it is equally difficult to transplant them. You have to have the expertise of anastomosing into very, very small, minute vessels. The children do not tolerate blood loss. All of a sudden, they will go down. All of a sudden, they will crash. So there are multiple issues with the children. And for today's talk, we have a very experienced and a very good friend from PGI. Dr. Kara is an associate professor of pediatric nephrology at the Advanced Pediatric Center in PGI. And she carries rich experience of managing kidney failure in children. So with that, I would like to invite Kara on the dais. Are you comfortable here?
Yeah. So I always have to stand on. Can you put the slides? At the outset, I would like to thank the organizers for giving me this chance. So I'll start with a story of how actually people I come across think about kidney failure in children. So whenever I go to any market and I say ki I'm a doctor in PGI, they'll be like, oh wow. And then what are you dealing with? Kidney failure in children. Are there actually children who have kidney failure? This is the first question that everyone will ask. So even if I tell at home that I'm working as a pediatric nephrologist, they'll think, how many patients do you see in a day? Because everyone feels that actually this is a disease of the adults. And the second thing is that it is not actually only the general population who thinks that maybe children do not, their kidneys do not fail. Even the doctors per se, the doctors, the nurses, they'll see that the patient is having kidney failure, any child having kidney failure, and they'll just think, okay, this patient will die. But why? We are here to save mankind, to save people. So it involves even children. A child cannot say that, no, I want a dialysis or I want a transplant. But maybe if that child can actually speak, like what Dr. Ranjan had said, maybe that child would be telling so many other things. And it is our responsibility as doctors, as caregivers, as transplant coordinators to also look at this, because you're going to give life to a small child who's going to change society as a whole. So I'm very happy that the organizers have actually created a niche and invited me to speak on kidney failure in children. And I'm also very happy because Dr. Anna has made my life so much easier. So when we're talking about kidney failure in children, I'll be dealing about two things more. One is the challenges that we face, and the other thing is that what are actually the outcomes of kidney transplant? Can you actually give your life, work as a profession to save these kids? Or is it like, okay, we'll leave it? So the challenges that we face is that most of, from the definition to the classification, it's always taken from the adults. So there are certain things that we have to twist and turn when we look at a child whose kidneys are failing. Secondly, like you've seen in the West, you have the incidence which is quite robust. And so you can tell the government, we have this many kidney failure patients, and so we need help, we need funding. But in India, even in adults, we don't have that robust thing to say that this many per million has this disease. And this is even worse in children, because everybody just agrees that, okay, this child has renal failure, okay, will die. But this is what we are here to change this thing. So we'll look into the incidence and prevalence, whatever data that we have. And very rightly, Dr. Anna said, diabetes, hypertension. Even from the audience also, they said diabetes, hypertension. In children, the problem is that it's a spectrum of diseases. You can't have just one or two. That we will be seeing. And the other challenge is, even in adults, they come late, but in children, they come even later. So we'll see what we're trying to do with that. And finally, the management, which Dr. Ranjan had said, it's very difficult then to put a cannula or to do a PD on a small child. So these are the few challenges that actually we come across, but these are the challenges that makes the adrenaline rush, that makes that even if you get a little bit less paid than the adults, it's fine, because you're giving life to society. You're making a change to the life of a child. So let's see at the definition. the definition of chronic kidney disease, I'm taking chronic kidney disease as a whole, it is abnormalities of the kidney structure or function, and it is present for 3 months with implications. That means any person who has any abnormality in the kidney structure, which you can see by an ultrasound or any other imaging, or has some problems in the function, that means there's some protein leak, or there's some blood leak from the kidneys, or there are some electrolytes, the sodium potassium is not right, or if, like Dr. Anna said, the EGFR is less, that means the glomerular filtration rate, the function of the kidney is less than 60, is considered to be chronic kidney disease. And like she has already said, when it comes to stage G5, that means this is actually kidney failure. That means the EGFR is less than 15. So this classification is according to the KDIGO guidelines of 2012, where they have classified according to the glomerular filtration rate. They have also classified according to how much protein an individual and the cause of the kidneys. Now look at what we have. What if the child is just born with a kidney, the structure of which is abnormal? Do we call that CKD? So these KDIGO guidelines have specific pediatric considerations. It may not apply to less than 3 months. You may not wait till 3 months to actually label any child a CKD, especially if they're in their infancy and less than 3 months. The other thing is that if you see, I don't know whether you can see this, when a child is born, the normal EGFR is only 20. So that definition of less than 60 then stands nowhere here. And it is only when you reach 2 years of age, that you actually, 2 to 3 years of age, that you will actually reach 120, the normal EGFR, because the small nephrons will actually develop over time and then attain the maturity. So whenever you're seeing a child, or especially an infant or a neonate with a kidney disease, you have to keep this in mind. And also, there are age normative values for everything, from the urine excretion to the electrolyte abnormalities. So whenever you're dealing with such children, you should remember that you have to go age-wise. So this is one of the biggest challenges that we face. Challenge number 2, like I said, epidemiology. There's less evidence. Actually, there's no registries. Registries are there in the West. Like if you see, there is the registry from the US, the Australian registry, and the European registry. And what they have done also, they have not registered all CKD patients. What they have registered is only those patients who go for renal replacement therapy, whether it is dialysis or whether it is transplant. Then they have put them into the registries. And mind you, it is not so less, because even if you see there also, in their, even in their less populous nations also, you have at least 9 to 13 per million age group. That so you'll see here, it is 9 to 10 per million, 9 to 13, and this is for everyone. The first graph is for less than 18 years, and the next graph is from 0 to 5 years of age. So you have quite a number of children actually requiring renal replacement therapy. Then if you look at the prevalence, that means what the people, the children who are going dialysis, it is almost 55 to 77 per million population for that age group. So some of you may just say, ki, okay, 50 to 70 per million, but it is so important because they have a 30 to 60-fold mortality rate. That means they have so much more chance of dying. So unless and until we take care of them, a lot of them will just go like that. So this is the challenge number 2, which most of the studies, whenever you see the publications in pediatric journals or in Kidney International, you'll say that we really need more evidence from Asia, the Middle and South America, and Africa. So this is what actually we all have to be pushed to actually try to find out how much do we actually have in our population. And the other important thing is that I've just heard one participant asking that in Canada, the medicines are free, there is insurance, but over here you'll have to pay. More so, while I sit in the emergency of PGI, if there are 10 patients coming, I think around 8 will just go because they don't have finances. There are lots of NGOs, there are lots of people who will give, but the first thing that they'll ask is that, will he get care in a short duration? Any donor would ask that. And the moment you say that the therapy is most likely lifelong, so they would choose another patient. So this is actually what drills me every day to come and again walk, talk, practice pediatric nephrology, because these are the sections of children where, they're really neglected. So we really need more people in this area. Then the third challenge. So we have found that the definition may not be fixed according to what the adult definition is. We have to twist and turn a bit. We have to have a knowledge of the disease. The second thing is that the epidemiology is not well documented, so we don't actually know how many are there. And then the third challenge that we face is that, like I said, in adults it's diabetes and hypertension. So you screen everybody for diabetes and you screen everybody for hypertension, that's it. But in children, if you see, the major chunk of CKD is because of structural abnormalities. That means when the kidneys were formed, they were not formed properly. And this is not one disease. Somebody will have a small kidney, somebody will have a block in the kidney, somebody will have a reflux kidney, somebody will have recurrent infection of the kidneys. So there are different diseases, and so then you can't, meaning there are so many diseases that, you'll have to think of all of them to know that this child actually is particularly at risk for a kidney failure. And the other thing is that because there's structural kidney disease, so abnormality in the structure of the kidney can also lead to abnormality maybe of the brain. So you can't just look at the kidneys, you have to look at the whole patient, or the whole body systems also, because sometimes they may have a structural abnormality in the heart. So all those things have to be dealt together. And then the next thing that we face is that many of these diseases are also genetic in origin. So this would mean that it would be important, especially if you're telling somebody to be a live donor. And the other thing is that for counseling for the next child. So this is another challenge that we as pediatric nephrologists face. So I'm very happy that somebody had talked about mental health, because what we have found that when we're treating these kidney diseases children, we have actually published 2 or 3 papers on this, that the kids actually undergo a lot of depression and anxiety, and it is not only the kids but also the parents. And this is more so in that adolescent age group where they understand that their kidneys are not failing and their parents have to spend a lot for them, and then they have some sort of, like guilty feeling. So whenever we're treating children with kidney failure, it is not only the nephrologist, the urologist, the pediatric surgeons who will be seeing the bladder abnormalities first. It's not only this. We need a geneticist to say that this is not a genetic disease, and can we take a family as a donor or not? We need a dietitian because these kids are a little bit fussy also in eating, and then to make them go for a renal transplant, you need an adequate weight, and you also need a psychologist because whatever they face is like tremendous, and none of us actually know how much we feel. More so, that's why I'm saying, even as you are interested in being transplant coordinators, please do have a look at pediatric transplant coordinators because this is the need of the day. And then the other pediatric consideration is that we don't have specific disease, like the natural history of diabetes, nephropathy, the natural history of hypertension, nephropathy, but it is not as clear for the different diseases of childhood. So whether, because they are not immune mediated, would this change in the transplant protocols? Would this change post-transplant? So we really need a lot of studies here. So even screening for family members also, what we have found out is that even in those structural abnormalities, if you screen their relatives, they also have some structural kidney disease. Then the challenge 4, which is also seen in adults, more so in children because they are asymptomatic till the late stages. So by the time they come to you, they're short, they're thin, they're anemic, they're puffy at times, their blood pressure is somewhere around 200 by 100. I mean, they come with so much of comorbidities that sometimes you feel, if only I could have seen this child a little bit earlier, maybe it would have been better. So this is one study that they said that most likely most of us pediatricians would have to see to identify those at risk, evaluate with just a serum creatinine and an albumin, the same way that they do in adults, and then try to decrease the progression of CKD. And then the other thing before renal transplant that actually challenges us is that when you're taking the BP for an adult, there is a fixed value. But for children, again, for different ages, it will be different. And you can take it from me, taking a BP for a small infant may take anywhere between 5 minutes to an hour, because you have to make the child understand that you're not pricking and the child will be crying. So these are the things that sometimes makes us frustrated, but then when you actually get a BP value, you feel so happy that these are the challenges that we face and we keep on facing. Reducing proteinuria, it's very easy for the adults to just say, I hope I'm not making her angry by saying it's easy for the adults. No, for the adults also it is difficult, but it is more challenging for us because you can't just say reduce protein intake because they have to grow. So this also becomes a challenge. Correcting the anemia, because as they grow, their requirement is more, and even if you give something like injection erythropoietin, most of them will not allow you to prick, and if they allow you to prick, also the cheaper versions of erythropoietin will come in 2,000 and 10,000, and that pen is a little bit expensive. So this is also another challenge. And then because they are growing, and you know that kidneys will also affect the bones, the calcium and the bones. So, in children, you have to ensure that at least they don't have any deformities, because anyone who wants to go for kidney transplant would not want to have crooked legs. So this is also a challenge that we have to face. And the most important is promoting growth, because our transplant surgeons may say that we want a weight of this much, and then we have to take the dietitian along with us. So the challenges of conservative management are anyway a bundle, but just look at the patients who are undergoing renal replacement therapy. This is from US, Australia, and Europe and Japan. Mind you, nothing from India, because we've not done as much. We don't have registries, so we don't actually know how many of them are undergoing renal replacement therapy. But if you see, it's just before this talk, they had discussed how much dialysis is better. I mean, the renal transplant is better than the dialysis in terms of quality of life, in terms of survival. But just look, even in the West also, you will see that most of them are under dialysis, and it's only a tip of the iceberg that are actually having, that have actually undergone a renal transplant. So this is where actually, again, I request everyone that, you know, we need to work on this. We need more force in this, because I think this is so much of a teamwork to make our kids actually have more of that green, where, you know, you have a better quality of life and a better survival, rather than undergoing peritoneal dialysis or hemodialysis. That is from the West. Our situation is even worse. So we've had only a bunch of kids who are still undergoing this peritoneal dialysis, and their outcomes is not as bad. They're equivalent to the West, but the people who can sustain peritoneal dialysis in India, especially for the kids, is anyway less. The other problem is hemodialysis again, because the catheter placement is a difficulty, because the dialysis, we can't get the pediatric dialysis. So even if we initiate dialysis at AIMS or PGI or JIPMA or Bangalore, then the nearby centers would not take these kids for the continuous maintenance dialysis. So again here, the only answer is actually a renal transplant. So let's look at renal transplant in children. When we're going through this, we'll go through transplant rates around the globe, pediatrics around the globe, and then what are the problems that we actually face in India. So this shows we're very lucky that we're not grayish, but we're still very low. The transplant rates in India are very low overall. If you see in Europe and in US, it is still quite good, because it goes to the range of 40 and 30 per million. But look at pediatric kidney transplants. In Europe, where there is 30 to 50 per million population, in kids it's less, it's only 13. And in the lower income and lower middle income countries, it's even less than 4. So you can understand the heavy feeling that we have when we see kids, because they are kids with kidney failure. We are able to dialyze some of them. Many get lost to follow-up, but renal transplant is still something that they are crying out. And it is actually up to us to listen to their cry. So we do not have any registry of pediatric kidney transplants in India. So we do not actually know how many per million population are actually undergoing renal transplant. But this is a problem actually at various levels in India. and in the lower middle class, countries, income countries, we have institutional level problem. That means the detection of CKD was not there, pediatric nephrologist is not there, dialysis care is not possible. But now we are trying to, catch up with this. And now what we need is to strengthen the disease organ donation, and also to have more transplant coordinators, and also to have people to spread the awareness that yes, kidney transplant is possible. A child having a kidney failure is not equivalent to death. Then at the state level, we have problems of legislation, and so on and so forth. And then if we look, this is one slide, like what Sir had told in the previous slide. I really want you to see this slide and remember, just see it, look at India. Whatever data that we have done, whatever data we have, the biopsies, the renal transplants done in CMC Vellore, in AIMS, in St. John's, Bangalore, what they've shown is that the graft survival of pediatric kidney transplant in the first year is almost 98%. So that means if we try hard enough, it is possible. 5 year, it is almost 92% survival rate, and a 10 year, it is 85. And mind you, these lower values are the ones that were done, the evidence that was done much earlier in the 1990s and 2000s. So that time, the transplant medications were different from what we have now. So now it's improved. So we can expect actually a very good graft survival. And therefore, I want you to remember that if any child with kidney failure has a chance of getting a renal transplant, the outcome is as good, or maybe it could be better than an adult patient. So these are what I actually wanted to show you, that the kidney graft survival is good for all these patients. And these studies were done, meaning the one from Bangalore was done in 2007. So I'm very sure that right now the success rates are even better. So I'll end up with this slide requesting, pouring out my heart to say that if any child is diagnosed with a kidney failure, they have hope, and we all as a team have to work together to improve not only the disease itself, but also overall. And is it challenging? Yes. Do I get frustrated? Yes, many a times. But I'm also happy most of the times. And can we do a renal transplant for kids? Yes, yes, we can. Yeah.
Ma'am, that was a very nice presentation, and I totally agree with ma'am. As a medicine person, for me, pediatrics is not my cup of tea. I mean, I salute you, ma'am, for the challenges they face, because I just had to take up pediatric cases during my nephrology as well, and I literally scratched my head like that. What do I do with you? I have to ask mother, can you just tell me the history? All right, ma'am, just one question, like, when do you suspect CKD? Like, when the child or the mother comes to you, what problem, what complaint do the mother tell you? And you suspect that this patient would be having a kidney disease?
So, it depends at what stage they come. But actually, I rushed through this slide because it is not very clear. But the structural kidney diseases, which are the bulk of them, you come to know from antenatal ultrasounds. So basically, nowadays, OPS is really flourishing. So nobody actually comes without an ultrasound at least in cities and towns. So the structural kidney disease would be detected even in the second and third trimester of the pregnancy. So the major chunk of them actually, if screened properly, can be detected from birth, and then we can follow them up with a serum creatinine and a urine protein. So, but these will be CKD stages, early stages, but then at least we can follow them at risk. The ones who come from, again, stage 3 onwards would be the ones who would come with failure to thrive. That means they're not growing well. They will come with decreased appetite. They will come with sometimes headache because of hypertension. They will come with difficulty in walking because of anemia. They have lethargy. So it depends at what stage actually. But if at all we see most of them, because 60 to 70% are because of structural kidney disease, so they can be detected very early on.
So the thing is, I think the carry on for this is like during your pregnancy, you should have at least an ultrasound. So to detect the structure abnormalities, which is prevalent, which we are falling, which we think it's a very small thing. But if you go back to towns, still it's not done, and they are doing the home deliveries, right, ma'am? Okay, ma'am, one more thing that again regarding the blood pressures. So the child is very small. So like when you take a BP, so how much size that cuff should be, and like adults we say it, okay, fine, sit here for 5 minutes and then we take it. Could you just tell about the?
Yeah. So we the bladder cuff, the cuff size. Nowadays you have ready-made ones that says that the mid-arm circumference should between this length to this length. So you can just ask for an infant cuff, a pediatric cuff, a child cuff, and an adult, small adult cuff. Or you can check the mid-arm circumference, and according to that also we have like Haynes and all, they have the companies, they have specific BP cuffs. But usually the length of that BP cuff should cover at least 80% of the circumference of the mid-arm, and the width should be 2/3.
And one more thing regarding, like we all said, like, yes, the children should be going with the transplant. So we already mentioned during the adult thing, the drugs, the immunosuppression. So we have to be very sure that we give the drugs to the children, and it would be the responsibility of the mother. So even the drugs which we have in liquid formulations as well. So if the child cannot swallow, we can give it. So it's nothing like that, bachcha dawai nahi kha payega. So everything is possible.
Very nice and a very heart-touching and a soul-stirring presentation by you, Dr. Kara, I must say. But I would request the audience to at least stand up and give a standing ovation to Kara. I'll tell you the reasons why. She has been doing such a fantastic work for children. So kidney failure, managing kidney failure.
Thank you so much. I don't think actually, if you see.
No, ma'am, I'll tell you why. Number one, because we see adult patients, we know what their disease is, we know what their abnormalities are. They have predictable medical histories, they have a predictable clinical course. More than that, when you are treating, and then as you rightly pointed out, there's so much negligence, there's so much ignorance, there is so much apathy from the institution, from the government, even from NGOs who are coming up to help these children, but they back up because they know it's a chronic kidney disease, itne der tak kaun kharcha uthayega. So these are real life situations in which the heart of a clinician ruptures, it goes into tears. More importantly, not being from the region. You belong to a different region of the country, and coming to this region of country where 90% mother tongue is Punjabi. So hats off to you to understand that language of mothers and then interpret the children. This is really commendable, and I must congratulate, compliment you, and wish you all the success to do such bright work in future. And two take home messages which I have for myself is that we have to learn to strengthen the pediatric transplant program because the results are very good, absolutely good, much better than the adults. And second thing is we must, as transplant coordinators, what Madam was trying to point out, that some of you should get inspired to work into the field of children with kidney failure. That's a really upcoming field where there are no people to take on those jobs. So these are the upcoming lacunae areas where one can find opportunities, where one can find their passion to be in the healthcare profession. So with those words, I would like to invite Dr. Anna as well as myself. We both should felicitate Dr. Kara. Thank you so much, ma'am, for taking out time today. With that, we go on to the next section, which would be the kind of work which we do. So Dr. Shashank has been our fellow for the past 3 years, and he is an excellent surgeon, and he has worked into the field of transplantation, and he is going to tell you the basics of kidney transplant in surgery and what happens inside the operation theaters. They've told you how do we manage these patients in the OPD, but once these patients are moved into operation theater, there's a specific group of specialist nurses in the OT who take care of them, and what kind of procedures do we do for them, and how do we actually do the process of surgery. So Shashank will take you through that.
A very fine good morning to all of you present here, the chairpersons, the organizers from the Mohan Foundation, and all the participants. Before starting, I would like to thank Dr. Priyadarshi Ranjan sir, who is also my mentor, teacher, and guide, and Mohan Foundation and Fortis Hospital Mohali for giving me the opportunity to speak and interact to all the participants who are attending the transplant coordinator training program. Today's topic is kidney transplant surgery. It includes both basics of living donor nephrectomy and kidney transplant. So first I will start with the history of the kidney transplant, assuming that all of you know the basics of kidney transplant, how it was started way back in 1900s, the century. And way back in 1912, a century ago, the French king was getting operated due to some intra-abdominal pathology, and he was died during surgery due to bleeding. And the bleeding was because of the intraoperative injury to the portal vein. Portal vein is the one of the largest vein in the body, and at that time there was no any standard suturing technique available for the vessel repair. So due to lack of this knowledge of suturing the vessels, the French king died at that time on the operation table. And Alex Carrel was a resident at that time, and he observed all what happened to the French king due to the lack of the knowledge of the suturing of the vessels, and he decided to go to Boston. And Alex Carrel went to Boston, and he studied and he did his research work on how to repair a vessel, how to do anastomosis of the different vessels. And he developed the mastery in suturing the vessels and anastomosing the vessels. And his perfection of suturing the vessels led to the winning of Nobel Prize in 1912 in the transplant surgery medicine. It was the first Nobel Prize given to a surgeon for a transplant sciences. So he's also studied the organ transplantation initially on thyroid gland, and after that he worked on kidney transplantation also, both autograft and allograft. The Nobel acceptance speech of Carrel was that concerning homoplastic transplantation of the organs, such as kidneys, homoplastic organ transplantation is allotransplantation. I have never found the positive results to continue after the few months. Whereas in autoplastic transplantation is isograft. The result was very positive, and the biological side of the question has to be investigated very much more, and we must find out by what means to prevent the reaction of the organism to a new organ. So way back a century ago, he observed that something is happening in the body. Because of that, the graft was not functioning for more than few hours or few days. So basically it was the rejection. So the second Nobel Prize in transplant surgery was won by Peter Brian Medaver and Frank McFarlane Burnett. It was in 1960, and their research work was on self versus non-self. So practically speaking, when a child is born, the immunity of child is 0. So with gradual due course of the time, with exposure of the environmental antigens, the child develops the immunity and alloantigens in the body. So 50 years ago, the Burnett and Medaver discovered that there is something in the body which reacts against the non-self antigens or non-self tissue in the body. So it laid the foundation of the immunology and nephrology at that time, which was related to the transplant surgeries, that someone has to work for the immunological basis of the transplant. So McFarlane Burnett gave the concept of self versus non-self, and he stated that the nature of the immune response as a major defense mechanism for the survival of the species and of the counterbalancing reactions that prevent autoimmunity. Medaver said that graft reaction is an immunological response similar to the tuberculin reaction. Allograft rejection was completely prevented in the mice if living cells from the future allograft donor were introduced into the recipient during fetal or neonatal life. It was a landmark year in the transplant surgery, 1958, when Jean Doucet, he discovered the HLA antigen. HLA antigen is the human leukocyte antigen, which is found almost all in all cells of the body, but preferably they are found on the leukocytes or WBCs. And the HLAs are transferred from graft to the recipient along with that graft, and it is responsible for most of the rejection which is done against the graft. So coming to the today's topic, first I will cover the living donor nephrectomy, principles of the living donor nephrectomy. So here in our institute, we prefer general anesthesia and low pneumatic pressure. Low pneumatic pressure is the pneumoperitoneum, which is created to create a space inside the abdomen for doing the surgery. So here we prefer the standard pneumoperitoneum, that is around 12 to 15 millimeter of the mercury. And here we are using the modern energy sources of the dissection, like harmonic scalpel, which is based on the ultrasonic principles, and also using the bipolar electrocautery and monopolar electrocautery. Good hydration of the donor is done during surgery by means of the IV fluids. And doing surgery, we dissect the ureter and the gonadal vein. After that, vascular dissection is done at the hilum, where the renal artery and the renal vein is separated. Kidney mobilization is done by separating the kidney from the surrounding structure and from the parietal peritoneum. Control of the pedicle is done by first clamping the renal artery and then cutting it, followed by clamping of the renal vein and then cutting it. The kidney extraction is done mainly by the phenylstein incision, which is given over the lower abdomen, and the kidney retrieval is done by that phenylstein incision. In this picture, we can see the laparoscopic donor port placement. This one is a 5 mm port, which is placed over the left subcostal margin. Here we are doing the left side laparoscopic donor nephrectomy. The second port is over the umbilicus. This is around 10 to 12 mm port, and a 12 mm port is placed over the left iliac fossa. An accessory port can also be placed over this mid of the flank region. It is midway between the left subcostal region and the left ASIS. This is an intraoperative view of the laparoscopic donor surgery, where we can appreciate the renal artery, renal vein, and this is ureter. This one is the kidney. So this is the picture taken before the clamping of the renal vessels. This is just immediate post-operative picture of the laparoscopic donor nephrectomy, where you can see the phenylstein incision. Hardly 4 to 5 sutures comes over there, and all the laparoscopic ports are closed by single sutures. What is bench surgery? Bench surgery is done when the graft is harvested from the living donor and before getting transplanted into the recipient. So during bench surgery, what we do, we cool the kidney with the help of the ice, and perfusion of the all arteries, if there are multiple arteries, or single artery, is done with a specified perfusing solution. And inspection of the quality and length of the vessel is done so that the length of the vessel should not be too short or too long. Removal of the perinephric fat is done. Ligation of the fibrolymphatic tissue around the hilum is done. Removal of the cliffs and staple line is done in case we have put in case of donor nephrectomy. Ligation of the 3 named tributaries of the left renal vein is performed. So this is the picture of the kidney after the bench surgery, where you can see the kidney is almost naked. All the perinephric fat is removed. This is the perinephric fat only around the hilum. This is renal vein, renal artery, and the ureter. And the kidney from the donor is about to be transplanted into the recipient. So what we do in case of the patient is having multiple renal arteries. So many people have one renal artery, some of them have multiple renal artery, 2 or 3. So we have to do one more step during bench surgery, that is anastomosis of the multiple arteries. So anastomosis can be done either end to side anastomosis, side to side anastomosis. Triple pantaloon is made in case of triple arteries. Ligation of upper polar artery can be done. It can be sacrificed if it is very thin. And we can leave 2 arteries for separate anastomosis in case of 2 arteries which are very long. So in case of 2 arteries, one artery is anastomosed to either of the external iliac artery or internal iliac artery, and the second artery is anastomosed to the inferior epigastric artery, which is already left by the surgeon during preparation of the bed of the recipient. So what problems we face when we decide to take a right kidney from the donor? So in right kidney, there are some anatomical differences from left kidney, that is long renal artery, short renal vein, thin walled renal vein compared to the left renal vein wall thickness, often multiple renal veins, 2 or 3 renal veins over the right side. 2 renal veins join together and make a very short stump of common opening into the IVC, precaval renal artery. Now moving to the recipient surgery. Here in our institute, we prefer general anesthesia with supine position of the recipient. Many incisions are described in the books, but we here prefer the Gibson incision in open surgery. Gibson incision is a lower abdominal incision, which is a reverse hockey stick incision, and it can either be given over right side or left side, which is preferred by the surgeon. Then extraperitoneal dissection of the external iliac vessel is done, ligation of the lymphatics, leaving some tissue between artery and vein on its posterior side, and minimal dissection of the artery more towards the bifurcation of the common iliac vessels. Standard bulldog metallic clamps are placed to control the arterial bleed. Arterial punch or trim can be used to puncture the artery for the anastomosis, and end to side anastomosis is done with polypropylene sutures. Venous control is done by Satensky clamp, which is a specialized clamp for vascular control for the veins. End to side anastomosis is done by polypropylene suture, and ureteric reimplantation can be done with or without stent, but here we prefer the stented anastomosis of the ureter. Wound closure without or with drain can be done. This is Gibson incision, which is given for the open surgery of the transplant. Here you can see this is reverse hockey stick incision. It can either be given on right side or can be given in left side. And the advantage of the Gibson incision is that there is excellent exposure to the iliac vessels and urinary bladder. This is intraoperative view of recipient bed. Here you can see this is external iliac artery and this is external iliac vein, which is already clamped by Satensky clamps. This is animated picture for simplified understanding of the how transplantation and anastomosis is done. So this is the graft kidney, which is taken from the donor. This is ureter of the graft kidney. This is renal vein of the graft kidney and renal artery of the graft kidney and renal vein of the graft kidney. Basic anatomy, all of you will be knowing that this is inferior vena cava, aorta, and here is the bifurcation converting into common iliac vein and common iliac artery, which further bifurcates into the external iliac vein and internal iliac vein and external iliac artery and internal iliac artery. So the graft renal artery is anastomosed to the external iliac artery in end to side fashion. The end of the renal artery is anastomosed to the side of the external iliac artery of the recipient. Here you can see the sutures. And in the same way, the renal vein is anastomosed to the external iliac vein of the recipient in end to side fashion, and the ureter is anastomosed to the bladder by Litch-Greger method, which is extravesical method of the anastomosis. So it is the similar picture which I showed you in animated picture. This one is the renal artery, this is external iliac vein, and these are the sutures. And this is external iliac vein, this is renal vein, and these are the anastomotic sutures. So this is a small video for simplified understanding. Abdominal opening is done by Gibson incision layer by layer. Then the graft kidney is placed into the right iliac fossa. Then anastomosis of the graft renal vein with external iliac vein of the recipient. Anastomosis of the graft renal artery with the graft renal artery with the external iliac artery of the recipient. Then perfusion of the kidney. Anastomosis of the ureter with the bladder over the stent. Closure of the bladder end. And then layer by layer closure of the incision. So in our era, what are the advances in the surgery of the kidney transplant recipient? So as all of you know that Fortis Mohali is the center of excellence for the robotic kidney transplant, which is the most advanced type of the kidney transplant done in the country and whole of the world. So previously it was done by laparoscopic methods. Laparoscopic kidney transplant is done same as the open kidney transplant, but only we use that laparoscopic instruments. And robotic assisted laparoscopic kidney transplant work on similar principle of the laparoscopic kidney transplant, but here we use the modern era robotic systems. Another type is the transvaginal insertion of the kidney and laparoscopic or robotic assisted laparoscopic kidney transplantation. Here we do not give incision for putting the kidney inside the recipient. Otherwise we put the graft transvaginally without giving any incision in the body. So it is a type of node surgery, natural orifice transluminal endoscopic surgery. Other one is robotic assisted laparoscopic dual kidney transplantation, in which in a single patient we transplant 2 kidneys at a time. Then last one is robotic assisted laparoscopic graft nephrectomy, which is done in donors. And other than laparoscopic methods, we also do donors by robotic methods. So summary of this presentation is evaluation of donor and recipient is essential to assess the feasibility, safety and outcome of the transplantation. Knowledge of law is must. Minimally invasive surgeries for both donor and recipients are currently in vogue. Knowledge of transplant immunology and immunosuppressant will give better understanding of the transplant outcome. The take-home message is kidney transplantation is a lifelong commitment to the patient, donor and family. It is not fit and forget. Thank you.
Very nice, Shashank. So, any questions? So, before you...
Thank you, sir. Sir, I just wanted to ask, in the starting you said that here you are using harmonic and monopolar and bipolar cautery. So when we are taking out the graft, at that time on the graft, do you use energy sources?
Yes.
Or it can change, it can damage the graft?
No, we are not, we don't put any energy source over the graft.
Okay.
We just put the energy sources on the parts of the graft which can be resected and cannot harm the graft after transplantation into the recipient.
Okay.
So we are using harmonic scalpel at the time of the vein surgery.
Okay. And my second question is, you said sometimes we do dual kidney transplant.
Okay.
So is that in the cases where the kidney size is small, or in any case you can do it?
No, in case of deceased donor, when 2 kidneys are available at a time, so we can do a dual kidney transplant in 1 patient.
Okay.
Yes.
And if the kidney graft is taken from a pediatric patient, In that case, can we put it in the in an adult only single kidney, or do you need to put 2 kidneys?
The answer will be better given by Dr. Ranjan sir.
I can make out from your question that you belong to the transplant OT. Okay, am I right?
No, sir, I work in pediatric surgery OT.
Okay. So, the first question is if we go to your first question, when do we need to put both the kidneys in one recipient? So, ideally, it is done in marginal kidneys. When we receive a brain dead donor, we take out the kidney. The donor's creatinine is a bit high. We know that the donor was diabetic. We do a biopsy. We see the Ramsey score. We see the kidney index. So if these are low, the kidney is functioning, say 60%, 70%. So when the surgeon or the treating team anticipates that one kidney might not be sufficient for the recipient is a bit heavy, more weight, then we put both the kidneys together. That is called as a dual kidney transplant. This situation is also possible when we receive kidneys from children. So when there is a brain dead donor who is a child, so the criteria is if the child is less than 10 kgs of weight, then both the kidneys are put in one recipient. If the child's weight was, whosoever is the donor, was more than 10 kg, then the kidneys are put separately. Okay, and the question about the energy sources, we very commonly now use harmonic scalpel over the graft for dissection. So that gives you a very clean field, especially with the robotic transplant that makes the life easy. Otherwise, we have to tie each and every bleeder, and in the robotics, you need a very clean field. So now we have switched over to using a harmonic scalpel over the graft. We don't touch the graft, but the entire dissection of the hilum, removing the fat, as Shashank rightly pointed out, is done with the harmonic energy source. So you must be working with Dr. Ravi.
Yes, sir.
So Ravi sir is my college senior. I was his second year JR. He was my third year senior.
Yes, sir.
So he does brilliant robotic work.
Yes, sir. In our department, we are doing robotics. We have done one tracheoesophageal fistula also. With
Yeah,
robotics.
yeah, I know he's a very brilliant robotic surgeon.
Yes.
So just to bring one more point, we are talking about transplant coordinators and everybody. One single point I want to make out here is that transplant coordinator is a very, very specialized field, but to run our transplant program, we need people from different backgrounds, and nurses form the backbone of our transplant program, whether it is in the OPD, whether it is in the OT, and whether it is in the ICU. So all the three areas are managed. If you go to specialized centers, if you go to US, Johns Hopkins, Mayo Clinic, New York Presbyterian Hospital, so these nurses are designated as clinical nurse specialists. So they handle a specific area. They will handle the entire pre-transplant counseling. They'll handle the pre-transplant workup. There'll be nurses in the OT who will handle the entire surgical operation. They are called as surgical assistants. So in India also, we are trying to introduce a course for these nurses who have specialized working with surgeons for more than 3 years. So they are designated as surgical assistants. And similarly, we have a clinical nurse specialist in the ICU. So she presents the entire round on the PowerPoint in the morning meeting. So they can manage the basic issues of post-transplant issues with the surgeons or the treating team. So there are so many avenues which are opening up for everybody of you who are here. Okay, any other question do we have? So so I would request Sudhir sir to please felicitate our fellow Dr. Shashank. So with that, we go for a quick tea break and come. We are running a few minutes late. So I would request to be back in 10 minutes. So have a quick tea and come back in 10 minutes. All right, everybody is settled. So I would now go into the actual working. How do we do a transplant? How do we make a transplant happen? And how are we able to achieve a good transplant outcome? Okay, so first of all, I would like to tell you that I've made this presentation in a hurry. So because I was so busy organizing all these things, so if there is anything which you don't understand, I've tried to make it as simple as possible for you guys, but at the same time, I should be able to put across the points which I want to make. Okay, so I'll be talking about traditional kidney transplant. I'm sure all of you must be knowing. And here at Mohali, we are doing some advanced work which needs to be disseminated to other healthcare professionals like you, and you should be aware so that if somebody is asking you, if somebody wants to inquire, you are able to answer their questions. So I would be covering three main advancements which have happened in the field of kidney transplantation. One is the development of the swap kidney transplant program. The other is, which swap kidney transplant is now also accepted by the Human Organ Transplant Act of India. The other major advancement is ABO incompatible kidney transplant. I'm sure you must have heard about it. So we'll delve into that. And third is a major surgical breakthrough technique, which is robotics in kidney transplantation, robotic surgery for kidney transplantation. The need of a swap and ABO incompatible arose primarily because, as you heard in the morning, Dr. Anna as well as Dr. Kara, there's a huge difference in survival between dialysis and transplant. So many patients are dying waiting for a transplant. They may have a donor in the family, but they are not able to get a transplant done. So that is how these techniques were developed. The concept of swap evolved, the concept of ABO incompatible evolved. And once we have standardized the techniques of surgery, see, kidney transplant technique has been existing for 60 years since when it was invented. And even in today's date, 99% of centers would do it the same way. So surgically, there was no advancement. But once the robotic surgery was introduced, it has made a major breakthrough in patients of kidney transplantation. You must see those patients to say their outcomes. Then you realize what difference has it made. So with that, I would like to start off. You know who is this person? Who is he? थोड़ा सा volume बढ़ाना. So before that, what is he famous for? Donald Trump. Crack jokes? What is he famous for? In the media, why do you listen about him? He does all sort of funny things. He speaks something which might not be relevant, and being such a high position and making such comments makes people laugh. So this is one comment from him.
Kidney, very special. The kidney has a very special place in the heart. It's an incredible thing. The kidney has a very special place in the heart. It's an incredible thing. People are working so hard to stay alive and to work.
So this is what comment he made, and certainly he was very oblivious of the anatomy where the kidneys are located. So I'm sure by now all of you know where the kidneys are located. Okay. But what the comment he made had the passion of the heart of a kidney transplant surgeon. So for all of us who are in the field of kidney transplantation, our kidney lies in the heart, or our heart beats for the kidney. So coming straight to the point, we face so many patients who have got a donor in the family. आपको अभी I think Shashi will tell you, for having a good match between a donor and recipient, they should have the same blood group. अगर A blood group का patient है तो उसको A blood group की kidney मिले तभी उसका transplant अच्छा हो सकता है, उसका match अच्छा हो सकता है, या फिर universal donor हो जो कि O blood group हो. तो बहुत से ऐसे परिवार होते हैं जिसमें कि A और donor है, एक living donor है. We are all bound by Human Organ Transplant Act of India, so we have donors. People have donors in the family. Suppose husband is the patient, उसका blood group B है, उसकी wife is the donor, her blood group is AB or her blood group is A. So she's not a good match with the husband. She wants to donate, but she's not able to donate. So these things are very common in our practice, and approximately 1/3 of patients who come to us with donors actually have a donor but are not able to get a transplant done, or not able to experience the benefits of a transplant because their donor was not matching. So for this, the government of India, the swap concept was introduced in by the Americans, Japanese very long ago. And this concept means that we can exchange the donors in between families. So it simply means that if there are two families who have got, and this has been now accepted by the Act, Human Organ Transplant Act, and it says if there are two families who have got donors, but the blood groups are different. So this is the first couple you can see, A blood group and B blood group. Vis-a-vis, there is another family who has a patient of B blood group and a donor of A blood group. And both these families are not able to receive a transplant just because their donors don't have a matching blood group with them. This is a difficult situation for both the families. One family is sitting at Jalandhar, the other family is sitting at Bhopal. Now what is our work? Our work is to collect those families. We make a registry of those families. We make a list of those families. Those inquiries come to us. So we make a list of those families and we try to cross match. And this swap doesn't mean only a 2-way match. It could be a 3-way match. It could be a 5-way match. It could be a 10-way match. The idea is to make more and more transplants happen, because we have to bridge that gap. We have to prevent people from dying when they want to receive an organ and save their lives. So this is the concept of swap kidney transplant, in which the donor of one family gives a kidney to the donor of other family, and a donor of the previous family extends a kidney to the other family. So this is a very, very well established concept, and very commonly we do swap transplants. We do approximately every month we do 1 or 2 pair of swap transplants, and it is a very good technique to match these pairs. More importantly, the message which you should take away is that this is not limited to 2-way. It could be 3-way, it could be 4-way. So it is difficult to explain you right at the start, but then you must have this concept in mind. O donor is a very, very important donor. I'll come to that concept. You want to see some stories of such patients?
मेरे को 2011 में इस बीमारी का पता चला कि मेरे को किडनी की प्रॉब्लम है. मैं 1 साल से किडनी डायलिसिस करा रहा था, तो डायलिसिस में बहुत दिक्कत होती थी. हफ्ते में 2 बार मेरे को डायलिसिस करवाने जाना पड़ता था, और ये बहुत पेनफुल थी.
डायलिसिस कराते बार हमें बहुत परेशानी आती थी, तो सुबह को डायलिसिस ले जाने के लिए मुझे अकेला जाना पड़ता था. मेरे घर में मेरे सिवाय कोई भी इसको डायलिसिस ले जाने के लिए सहमत नहीं था.
मेरा बीपी बहुत ज़्यादा शूटअप हो रहा था, तो जब अल्ट्रासाउंड कराया तो उसमें पता लगा कि एक किडनी कॉन्ट्रैक्ट हो गई थी और दूसरी किडनी में हाइड्रोनेफ्रोसिस था, तो यूरेटर में स्ट्रक्चर था, तो उसका ऑपरेशन करने के बाद में वो धीरे धीरे डिटरेट होती गई, और बाद में डायलिसिस 2011 में मैं डायलिसिस पर आ गया. अनेकों समस्याएं जो डायलिसिस के समय आती हैं, बार बार हॉस्पिटलाइजेशन, या आपके शरीर में दुर्बलता आना, क्षीण हो जाना, आपके आर्थिक समस्याओं का तो खैर साथ में अंबार लग जाता है।
और इसका ब्लड ग्रुप O है। मेरे परिवार, मेरे मिसिस का B पॉजिटिव है, A पॉजिटिव है और मेरा B पॉजिटिव है। तो शुभ के लिए किडनी की समस्या चली थी।
क्योंकि हमारा ब्लड ग्रुप मैच नहीं करता था, तो इसलिए काफी दिनों से हमारा ट्रांसप्लांट नहीं हो पा रहा था।
The blood group of the donor and the recipient is not matching, so we swapped it.
अदर मेंबर उसको किडनी डोनेट करने में अनेबल हैं, वो नहीं दे पाए।
कि मेरी मम्मी और परिवार के किसी भी सदस्य का मेरे साथ ब्लड नहीं मिलता था, तो इसलिए हम रेखा आंटी और पंकज अंकल से मिले। रेखा आंटी का ब्लड मेरे साथ मिलता था, तो रेखा आंटी ने मुझे किडनी दी और मेरी मम्मी ने पंकज अंकल को दी।
मैंने सोचा कि मेरी वजह से अगर 2 जिंदगियां बचती है तो मैंने स्वैप डोनर के ये से हाँ बोल दिया। डॉक्टर रंजन से मैंने कहा कि हम लोग स्वैप करवाना चाहते हैं। उन्होंने काफ़ी अप्रिशिएट किया कि हाँ ठीक है।
फिर हम डॉक्टर रंजन के पास फोर्टिस आए। उन्होंने हमें स्वैपिंग के बारे में डिटेल से बताया कि आप किसी को किडनी दे सकते हो और इस ब्लड ग्रुप की किडनी ले सकते हो। फिर हमारे को हरियाणा के नरेंद्र जी मिले, उनका बेटा स्वैपिंग के लिए तैयार हो गया। उन्होंने भी हमें 1-2 बार मुलाकात हुई तो वो देने को तैयार हो गए।
नरेंद्र जी जिनके साथ मेरी वाइफ ने उनको डोनेट किया, उनका A पॉजिटिव था, उनके बेटे श्री अग्नि जी उनका B पॉजिटिव था। इस प्रकार हम लोगों ने, अग्नि जी ने मुझे किडनी दी और मेरी वाइफ ने नरेंद्र जी को किडनी दी।
This is something which is legally allowed and it has been adopted by the Human Organ Transplant Act of India amendments. और ये ऐसी टेक्निक है जिससे कि हम ज़्यादा से ज़्यादा मरीजों की मदद कर सकते हैं और कई लोगों में ट्रांसप्लांट कर सकते हैं जिनमें अभी तक डोनर होने के बावजूद भी ट्रांसप्लांट संभव नहीं था।
ट्रांसप्लांट के पश्चात यदि आप समयबद्ध तरीके से अपनी दवाइयों का सेवन करते हैं या डॉक्टर से कंसल्टेशन, रेगुलर कंसल्टेशन रखते हैं, मैं नहीं समझता कि किसी प्रकार की कोई पेचीदगी आनी चाहिए या स्वास्थ्य में कोई दुर्बलता आए या इस तरह का कोई परिवर्तन आए।
मैं बता नहीं सकती मैं कितनी खुश थी। मैं सभी से ये बोलती हूँ कि किडनी देना बहुत बड़ा दान है और दूसरों की ज़िंदगी आप बचा सकते हो।
तो मेरा बेटा बिल्कुल स्वस्थ है और मेरी वाइफ भी बिल्कुल।
So just to highlight the lives of these people when they are suffering on dialysis, and once they are able to get a kidney, their life changes. And we have launched an iKidney app. So this is an incompatible kidney app. You can find it on the App Store. So in this app, we can actually register patients who have an incompatible donor, and that is how we
किडनी
get
फेलियर और इनकम्पैटिबल डोनर्स की समस्या से जूझ रहे मरीजों के लिए डॉक्टर प्रियदर्शी रंजन और चंडीगढ़ किडनी फाउंडेशन एक ऐप को लेकर आए हैं जिसके जरिए जरूरतमंद लोगों को किडनी मिलना आसान हो जाएगा। किडनी या इनकम्पैटिबल किडनी ऐप को सांसद किरण खेर ने चंडीगढ़ प्रेस क्लब में लॉन्च किया। इससे न सिर्फ क्षेत्र के बल्कि देश भर के उन किडनी फेलियर के मरीजों को लाभ पहुंचेगा जिनके पास परिवार के भीतर किडनी डोनर तो है लेकिन ब्लड ग्रुप मैच होने और टिश्यू इनकम्पैटिबिलिटी के चलते ट्रांसप्लांट नहीं हो पा रहा है। ऐप लॉन्च करते हुए किरण खेर ने कहा कि ऐसे मरीजों के लिए ऐप एक वरदान से कम नहीं है।
मेरे को लगता है बहुत अच्छी शुरुआत है और ये इसको और ज़्यादा फैलाना चाहिए और ज़्यादा लोगों तक इसकी अवेयरनेस जानी चाहिए, लोगों को पता होना चाहिए इसके बारे में, क्योंकि अक्सर जब लोगों की किडनीज आपस में मैच नहीं करती, घर वालों की, रिलेटिव्स की, क्योंकि या तो ब्लड ग्रुप नहीं मैच करता या उनके टिश्यूज़ या बाकी चीज़ें नहीं मैच करती, जो कि बहुत सारी चीज़ें मैच करनी चाहिए फॉर द बॉडी टू एक्सेप्ट द किडनी ऑफ द डोनर। तो इस तरह से अगर आपको एक फैमिली मिलती है जो कि ढूंढ रही है डोनर और आप दूसरी फैमिली मिलती है जो भी डोनर ढूंढ रही है, तो अगर उनकी आपस में मैच हो जाए तो वो एक दूसरे के साथ इसका एक्सचेंज कर सकते हैं। तो अगर इसी ऐप पे वो रजिस्टर कर लें तो मेरे ख्याल से इस ऐप के द्वारा बहुत जल्द बहुत सारे लोगों का फ़ायदा हो सकता है और लोगों को किडनीज मिल सकती हैं। जो लोग सालों साल वेट करते हैं, कुछ को तो बेचारों को मिलती भी नहीं, वो वैसे ही चल बसते हैं। तो मुझे लगता है कि अगर हम 1-2 जान भी शुरुआत में बचा सकें तो बहुत अच्छी बात है और इससे डेटाबेस बढ़ेगा। जैसे बाकी देशों में इतना डेटाबेस, लोगों बहुत सारे देशों में जो हम प्रगतिशील देश हैं उनमें है ये चीज़ें कि वो आपस में डेटाबेस बहुत बड़ा है, तो वो इमीडिएटली कर सकते हैं मैच की इसको ज़रूरत है, इसकी इससे कर लो। तो हम भी अगर इस तरफ कदम उठा रहे हैं तो बधाई के पात्र हैं डॉक्टर प्रियदर्शनी जी, और बधाई के पात्र हैं डॉक्टर पाली जी, आदर्श स्वामी जी और प्रेस क्लब जिन्होंने ये आयोजित किया है। तो मुझे लगता है कि जितने लोगों को भी किडनी का प्रॉब्लम है उनको इस ऐप में ज़रूर रजिस्टर करना चाहिए।
So, thank you so much. So after that, we do a lot of humanized emotional work also. So we try to match Hindu patients with Muslim kidneys, and there's a different kind of fun and kick we get. There's a patient from Kashmir who is a Muslim, so the kidneys exchange with a Sikh or a Hindu. So in a world where religions are drifting us apart, our profession gives us an opportunity to serve these people and bring those forgotten bonds of humanity together. So we have done many such transplants in which we have swapped kidneys across many religions. One more take-home point which you should have, whenever any family asks you, or there is somebody in your circle who has an O donor in the family, always encourage that patient or that family for a swap transplant, because O donors are rare. O donors are very rare, and there are lakhs of recipients who have got O blood group but who don't get a donor. So the concept of swap is that we swap kidneys in a way so that both families will benefit. There is a very pertinent and a very basic question that if a family has O donor, why would it go for a swap? Because the donor is a universal donor. So in those cases, the patients who have got O donors, if they are elderly donors, suppose एक किसी बच्चे की माँ उसको किडनी दे रही है, माँ की उम्र 60 साल है, बच्चे की उम्र 30 साल है. Vis-a-vis, if we are able to swap that O donor and उसका titers कम है, या मान लो उसका बच्चे का ब्लड ग्रुप A है, उसकी मदर का ब्लड ग्रुप O है, अगर हमको कोई ए ब्लड का डोनर मिलता है किसी ऐसे परिवार का जिसमें भाई बहन एक दूसरे को किडनी दे रहे हैं, सो उसकी डोनर की उम्र से 25 साल है, 30 साल है. सो इन दिस वे द family with an O donor has an advantage because they are getting a younger age donor. The younger the donor, the more are the chances of survival of that kidney. Young donor होगा तो उस किडनी का सर्वाइवल बहुत साल, 15 साल, 20 साल, 25 साल, it will function for long. Vis-a-vis एक 60-65 ईयर्स का डोनर है तो उसकी किडनी ऑलरेडी 65 ईयर्स वर्क कर चुकी है, उसका वैस्कुलर ट्री इज 65 ईयर्स ओल्ड. सो ट्रांसप्लांटिंग दैट किडनी vis-a-vis transplanting a kidney which is younger in age will have a advantage for the family with the O blood group donor as well. So ऐसा नहीं सोचना चाहिए कि O blood group वाले डोनर को कभी स्वैप में नहीं आना चाहिए. They should be in fact pulled out into the pool of swap transplant, and such a donor can trigger a very long chain of transplants, 8 transplants, 10 transplants. If you work out the mathematics, if some of you, I would request if some of you are interested in mathematics, so there's a couple in US called Dory Sajev and Somer Gentry. They are husband and wife. Wife is a mathematician and husband is a transplant surgeon at Johns Hopkins. So they develop these models in which they put in these O blood group donors into the swap program, and all of a sudden there are 30 transplants done. So this is the power of mathematics. So I would just request you, whenever you encounter such a family, कहीं से सुनने में आया कि किसी का transplant होना है, उसके पास O donor है, donor की उम्र ज़्यादा है, just encourage that family for a swap transplant because that can trigger wonders for many families. Okay? So let us go to the next advancement, that is an ABO incompatible transplant. As I told you before that there are families who have got donors in the family but they are not able to get a transplant done because their blood group is not matching. So first choice obviously is a swap transplant, but if we are not able to locate a good swap pair for that patient, we give them the option of ABO incompatible transplant. So ABO incompatible transplant has now become a reality. It's a very, very developed stage of ABO incompatible transplant. We started way back in 2013, but then in the US and the Japan, these were started in late 90s. So now the long-term results of ABO incompatible transplants are available. We also have patients who have got 8 years, 9 years of follow-up, and they really, these patients' outcome are even better than a normal transplant, because these are very, very emotional and very careful patients. They know that they have an ABO incompatible transplant. They will come to the clinic for follow-up very regularly, and that is the reason they have a better outcome. So ABO incompatible transplant is now a possibility. Just to give a brief overview about the technique. So as we all know, there are 4 types of blood group: type A, type B, AB, and type O. So somebody who has got A blood group, his red blood cells are coated with the A bead. That is why they have A blood group. But in their blood, they will have antibodies against B. They will not have antibodies against the A blood group, but they will have antibodies against the B blood group. So the moment something which is belonging to the B blood group or something which has an antigen coated with B blood group enters their blood, these antibodies will attack and that graft will be lost. The kidney will undergo rejection. Similarly, the blood group B antigens are present on a person who has blood group B. He has an antibodies which are against the A blood group. The AB blood group has both A and B antigens on the blood cells. That is why there are no antibodies in patients of AB blood group. That is why they are also called as universal recipients. So somebody, if he is fortunate enough to have AB blood group, then he can receive a kidney from anybody. But unfortunately, these are very minuscule, hardly 5 to 7% of population has AB blood group. Type O blood group is again a very common blood group, and I don't know what is the reason, but type O kidney failure patients are also the maximum. And they are always running around for a donor. So these have got antibodies both against the A blood group and B blood group. So whether you put a A blood group kidney, whether you put a B blood group kidney, both will get rejected. And that is why these patients are not able to get a transplant done. So ABO incompatible transplant is a technique to overcome this blood group barrier. So this is a technique by which we can measure the titers of these antibodies, which I just showed you. So these are the titers. We can measure it as 1:4, 1:1, 1:16, 32, 64. So it doubles. This is called as a double dilution technique by which we measure the level of these antibodies, and we remove these antibodies by a procedure called as plasmapheresis or plasma exchange. So it's a similar machine like a dialysis machine. We put a pheresis filter in that, and we can remove all these antibodies. Once these antibodies are removed, we put in a fresh plasma which is devoid of all those antibodies, and then do a transplant, and then such kidneys will function beautifully. So again, if you are interested to see a story, I can show you a story, otherwise we can proceed. You want to see a patient story?
मेरे पति मिस्टर जीएनएस गुरुदत्त का पिछले 4 साल से डायबिटिक थे और हमारे लाइफ में सब कुछ ठीक चल रहा था। ऐसा कुछ भी नहीं था जिसके लिए हम काफ़ी चिंता करते, क्योंकि बहुत संयमी है मेरे हस्बैंड, और वो कभी कोई जैसे शुगर है तो सारी परहेज भी करते हैं, मेडिसिन जो था वो टाइम पे लेते थे। लेकिन कुछ चीज़ें ऐसी हुई जो ज़िंदगी बदलने वाली बातें होती हैं। इस साल 2017 फरवरी में हमें पता चला कि इनकी दोनों किडनियाँ ख़राब हो चुकी हैं। फैमिली में किसी को अंदाज़ा नहीं था कि ऐसी बीमारी भी हो सकती है हमारे घर में। पापा का क्रिएटिन एक्चुअली स्टार्टिंग की रिपोर्ट में 5.9 पहुंचा था उस टाइम पे। मैंने सर्च किया तो मुझे पता चला कि ये तो 5th स्टेज की क्रोनिक किडनी डिजीज़ है। इसका मतलब इसके लिए अब आपके पास कोई मेडिसिन आपको ठीक नहीं कर सकती इस किडनी को।
तो ये सुनने के बाद हम लोगों ने यही राय ली कि फ़िलहाल डायलिसिस कराया जाए, और 6 महीने तक मैं डायलिसिस पे रहा। डायलिसिस के दौरान मुझे बहुत सारी परेशानियाँ हो गई। मेरे चेस्ट में पानी भर गया, जिसके कारण मेरा बीपी बढ़ा रहता था, और 6 महीने में कम से कम 6 बार मैं आईसीयू में एडमिट हुआ केवल बीपी के कारण। इसके अलावा जो मेरा वेट है वो 22 किलो कम हो गया डायलिसिस के दौरान।
2 महीने तक इनकी डायलिसिस कभी होती थी, कभी इन्फेक्शन आ जाता था, फिर 1-2 हफ्ते डायलिसिस पोस्टपोन हो जाती थी, काफ़ी दिक्कत रहती थी। मेरे घर में सिर्फ 2 बच्चे हैं, तो उनमें से बच्चों के ऊपर ही सारी जिम्मेदारी आ गई थी घर की। अच्छा खासा चलने वाला इंसान, काम करने वाला इंसान व्हीलचेयर पे आ गया था 4 महीनों से।
शरीर बहुत कमज़ोर हो गया, इसलिए हमारे पास ट्रांसप्लांट के अलावा कोई विकल्प ही नहीं था।
इनकी 2 बहनें हैं, कोई भाई नहीं है, दोनों बहनें डायबिटिक हैं, पेरेंट्स नहीं हैं इनके, और मेरा और इनका ब्लड ग्रुप भी मैच नहीं करता। तो हमारे साथ सबसे बड़ी दिक्कत ये थी, जो डॉक्टर ने बताया था कि आप मैचिंग ब्लड ग्रुप लाओ, अगर जेनेटिकल मैच नहीं ला सकते तो कम से कम मैचिंग ब्लड ग्रुप लेकर आओ।
चूँकि हमारा ग्रुप मैच नहीं कर रहा था, तो ये बात बिल्कुल हमें क्लियर थी कि जो हमारा ट्रांसप्लांट होना है वो इनकैपेटिबल ट्रांसप्लांट होना है। तो दिल्ली में जब हम लोगों ने डॉक्टर से कंसल्ट किया, तो अधिकतर डॉक्टर्स ने एक ही बात बताई कि इसमें रिस्क है। अब रिस्क का नाम सुन के हम और डर गए कि आखिर हम ट्रांसप्लांट कराएंगे कहाँ।
कुछ चीज़ें जो थी जो हमें या मुझे या मेरे बच्चों को सेटिस्फाइड नहीं करी थी, वो केयरिंग नेचर जो डॉक्टर का होना चाहिए, वो जो कंसर्न हमारे साथ रखे कि हम जिस प्रॉब्लम में हैं उसका सोल्यूशन सिर्फ उस डॉक्टर के पास है जिसके पास हम जा रहे हैं, ऐसा कहीं हमें नहीं मिला। हर डॉक्टर अपने प्रोफेशनल तरीके से बात करते थे और बस वो कहते तुम आ जाओ, हो जाएगा। हो कैसे जाएगा, उसके बाद क्या करेंगे, ट्रांसप्लांट में कितना टाइम लगेगा, क्या रिस्क है, ये सारी चीज़ों के बारे में किसी डॉक्टर ने बात ही नहीं करी हमसे। सबसे ज़्यादा ज़रूरी था कि हम ऐसे सर्जन को ढूंढे जो एबीओ इनकम्पैटिबल ट्रांसप्लांट्स में एक्सपर्टीज़ जिन्होंने रखी हो। तो हमने बहुत कन्विंस किया अपने पति को, कि मेरे हस्बैंड को, मेरे बच्चों ने भी किया कि एक बार चलते हैं मोहाली और दिखा कर आते हैं डॉक्टर रंजन को। उम्मीद बहुत ज़्यादा नहीं थी, लेकिन एक रास्ता था।
गुरुदत्त जी जब हम लोग के पास आए उत्तरांचल से, तो बहुत ही परेशान हो चुके थे, और इनकी परेशानी का कारण था कि इनकी किडनी खराब होने के साथ साथ इनके फेफड़े में भी काफ़ी पानी भर रहा था, इनका हृदय काफ़ी कमज़ोर हो चुका था, और ऑलमोस्ट एवरी 3rd वीक और 4th वीक इनके महीने में 1 हफ्ता इनका आईसीयू में ही बीतता था। इनकी जो है एडमिशन होती थी, चेस्ट में से टैप करते थे हम लोग, पानी निकालते थे, और इसके बाद जाके इनकी कंडीशन कहीं ठीक होती थी, और ये डायलिसिस भी बड़ी पुअरली टॉलरेट कर रहे थे।
डॉक्टर रंजन के पास जो हमारी पहली मुलाकात थी, उसी में हमें इतना विश्वास मिला उनसे कि हमें लगा कि शायद यही जगह है जहां हमारा ट्रांसप्लांट सही तरीके से हो सकता है।
उस दौरान उनकी कई बातें जैसे लगता था मैं यही सुनने के लिए आना चाहती थी। उन्होंने कहा कि ट्रांसप्लांट करेंगे हम, और इसमें उतना ही रिस्क है जितना किसी और के नॉर्मल ब्लड ग्रुप या जेनेटिक मैच के लिए जितना ट्रांसप्लांट के लिए है, उतना रिस्क आपके साथ भी है, और अगर कोई दिक्कत होती है तो हमारी टीम है, मैं हूँ, हम उसको कोशिश करेंगे कि ऐसी कोई प्रॉब्लम ट्रांसप्लांट के दौरान आए ही ना।
हमारे टेस्ट हुए, और टेस्ट में ये पता चला कि मेरी वाइफ की किडनी सूटेबल है, वो लग सकती है, अच्छा काम कर रही है किडनी।
ट्रांसप्लांट की डेट मिल गई हमें। हमारे घर में सब बहुत खुश थे कि अब ये सारी मुसीबतों से छुटकारा मिल जाएगा, लेकिन डेट मिलने के 2 दिन बाद मेरे हस्बैंड की तबीयत फिर से खराब हुई और फिर से वो आईसीयू में एडमिटेड हो गए। वो समय भी बहुत कठिन था, हमें लगा अब ट्रांसप्लांट नहीं हो पाएगा, लेकिन फिर भी शाम को डॉक्टर साहब ने देखा और बोला कि नहीं, ट्रांसप्लांट तो हम उसी डेट पे करेंगे, और बाकी के दिन ठीक से निकले। जिस दिन हमारा ऑपरेशन था 13 सितंबर को सुबह 8 बजे आईसीयू में एडमिटेड हुए हम दोनों, हस्बैंड वाइफ। एक दूसरे को बेस्ट ऑफ लक कहा, बच्चों को बाय बोला कि हम जल्दी ठीक होके बाहर आते हैं, लेकिन शायद कुछ और मंजूर था ऊपर वाले को।
उस दिन इनका ऑपरेशन था, उस दिन इनके जो सांस की नली थी उसमें काफ़ी स्वेलिंग थी। सो उस दिन एनेस्थीसिया देने के बाद वहाँ से इनकी सांस की नली से थोड़ी ब्लीडिंग होने लगी, इसलिए इनका ट्रांसप्लांट उस दिन भी टालना पड़ा।
तो डॉक्टर रंजन ने बाहर आके मुझे अच्छे से समझाया कि ये हुआ है बेटा, ये इस वजह से ऑपरेशन नहीं हो पाया, लेकिन तू टेंशन मत ले, हम इनको ठीक करके वापस भेजेंगे, ये अपने आप ठीक हो जाएंगे। हम देखते हैं अगर 2 दिन में अगर ये पूरा रिकवर कर जाते हैं तो हम 2 दिन में इनकी सर्जरी कर देंगे। लेकिन अगली सुबह ही मेरे हस्बैंड को होश आ गया और वो नॉर्मल लगने लगे डॉक्टर्स को। तो उन्होंने हमसे पूछा क्या आज आप अपना ट्रांसप्लांट कराएंगे। हमारे लिए तो सबसे बड़ी खुशी की बात थी, हम दोनों बहुत खुश होकर गया कि हाँ बिल्कुल कराएंगे ऑपरेशन।
हमारा ट्रांसप्लांट 14 सितंबर 2017 को फोर्टिस में हुआ डॉक्टर रंजन के द्वारा, और एक सफल ट्रांसप्लांट हुआ। उनकी टीम के द्वारा जो प्रयास किया गया वो बहुत ही सफल रहा।
24 घंटे इनको वेंटिलेटर पे रख के नेक्स्ट डे हम लोग ने इनका ट्रांसप्लांट किया और आफ्टर दैट ही नेवर लुक्ड बैक. हिज रिकवरी वाज गुड एंड he could achieve whatever he wanted to.
फिर हमारी दुनिया बदल गई, सब कुछ नॉर्मल रहा. किसी भी आम किडनी से ज़्यादा अच्छी किडनी मेरी वर्क करी इनके शरीर में, ऐसा डॉक्टर रंजन ने कहा.
उन्होंने जब मुझे बताया कि मेरी किडनी बहुत अच्छा काम कर रही है अनमैचिंग ब्लड ग्रुप होने के बावजूद भी, और जो मेरा क्रेटिनिन लेवल है वो 0.5 0.7 रह रहा है, तो मेरी खुशी का ठिकाना नहीं था. क्योंकि डायलिसिस के दौरान जो मेरा क्रेटिनिन था वो 10 और 11 रहा करता था.
आजकल तो बहुत सी न्यूक्लियर फैमिलीज होती हैं, तो फैमिली में माँ बाप बच्चे यही 4-5 लोग होते हैं और कोई जॉइंट फैमिली तो है नहीं. तो कभी अगर किसी की किडनी खराब हो जाए तो उसको ब्लड ग्रुप सेम मैचिंग का डोनर मिलना काफ़ी.
Thank you so much for that applause. It goes a long way to encourage and boost the confidence of all of my team members who are present here. And believe me, more than me, they do the hard work of getting those patients convinced for a transplant, carrying out all their formalities, as well as pheresis and all those things. They are so extensively involved that that is why we are able to deliver these things with success, because I'm backed by an excellent team of my nurses and coordinators. So coming back to the next development, which is a robotic kidney transplant. So these were the two developments, ABO and SWAP, which I told you were to cross the barrier of a non-matching blood group. The third advancement is the robotic kidney transplant, which is a technical advancement. So if you see these patients in the OPD once they come, I'm not carrying a picture right now, but they will not have an incision at all. If you see them after 3 months, it is very difficult to see where the incision was. Otherwise, normally in a routine kidney transplant, the incision is very long. So approximately 20 to 25 centimeters incision is given. The muscles are cut, there is blood loss, the recovery takes longer. But with the robotic kidney transplant, the incision is hardly 5 centimeters. So it is 1/5 of a normal transplant. And patient's recovery in terms of pain, in terms of blood loss, in terms of infections. Once the incision is small, the patient has all those advantages. So robotic kidney transplant is the newer age technique of transplantation, which is now emerging, and now more and more centers are also trying to push up these programs, including ours. And the standard technique, as I told you, of a kidney transplant dated back 60 years, because predominantly it was done by non-urologist transplant surgeons. Now, the urologist transplant surgeons are taking over this field, and the reason is that we are using a robot for radical prostatectomy and other pelvic surgeries, by which we can have a reasonable expertise to put out these kidneys and do a transplant. So now we are extending those advantages of a robotic transplant into these patients. This is a small video of our This is the Da Vinci robot which we have. These are the arms of the robot. As a transplant surgeon, robotic surgery for me means more magnification. It is just like I'm sitting inside the abdomen of the patient and then operating. So the magnification is enhanced to many-fold, which in turn enhances my surgical capabilities, my precision of my anastomosis and vascular suturing. It gives me an opportunity to deliver the best of my skills to our patients. As a surgeon, I feel it is less traumatic to the patient. There is a very small incision which almost is invisible after a certain period of time. More importantly, if the incision is small, it causes less blood loss to the patient, less weakness to the patient. There are no muscles which are cut in this surgery, and we are able to conveniently place this kidney in the patient without causing much trauma to his body. The overall cosmesis also after a kidney transplant is much better as compared to a traditional transplant. The incision is hardly visible after 3 months of surgery, and the incision is placed very low in the abdomen. So the incision is hardly 5 centimeters, which we use to just place the kidney inside. So practically, if you see the abdomen of the patient, you can't make out that he has undergone a surgery. Earlier, the robotic surgery or robotic assisted kidney transplant was designed for patients in which open surgery was almost very difficult or almost impossible, such as morbidly obese patients. But with advent of time, more and more patients are choosing and more surgeons are preferring to do a robotic kidney transplant rather than an open kidney transplant. The reason is that the outcomes are excellent and the trauma to the patient is minimum. So mostly younger patients, since they are more educated, more aware of the world, they are coming to us demanding about the robotic surgery for sheer reasons of cosmesis and pain-free. Whereas in the elderly group, the outcomes, the recovery, these are the more important factors. So I believe almost all patients are candidates for a robotic kidney transplant. Whosoever is being planned for a transplant is a candidate for robotic surgery. Only a select situations of patients who have got polycystic kidneys in which the kidneys are filling up the abdomen, those patients might be a difficult candidate for robotic surgery. Rest, otherwise, all the patients can undergo comfortably a robotic assisted kidney transplant. So robotic kidney transplant, I believe, is the surgery of the future. Initially, there is some inertia because the technology is not cheap. It's a huge machine which costs several crores. The learning curve is very steep. It's not easy to do a robotic kidney transplant. So there is some initial inertia, but I believe in days to come, almost all centers, more and more patients are coming up demanding a robotic kidney transplant. And in due course of time, I believe most of the centers will make it a norm to do a kidney transplant with the robotic technology. At this point of time, only a very few select centers in the world are offering this facility. But I'm sure in times to come, more and more centers will acquire the necessary skills and infrastructure because the benefits of a robotic transplant are immense. So thank you so much. But before that, I would like Shashank, Manish, and Shashi to stand up because these are the people who have bared with me when we are developing this surgery. They are the ones who have faced the music of complications, who have managed my patients well. So these are the people who have worked really hard to make this program a success. Thank you so much, all of you. Just to give you a brief, just to show you how does it look like when we do a robotic anastomosis. So this is an animation in which we do the entire surgery with the help of the robot. So this is a simplification of steps. The magnification is many-fold. We can see very clearly. It is just like sitting inside the abdomen of the patient and doing the surgery very easily and very comfortably. We have had patients in which we had to open up initially. But when we saw and we looked at the anastomosis, it was much better than what we do with open hand. So technically, I feel it's a safe procedure. It's a very, very good procedure for the patients. And now, once these patients come to the OPD, we see when they lift up their shirt, we hardly find any incision. So that's really a very great feeling to have. Thank you so much for that patient listening. So this is how the urine looks like. This is a happy face for a surgeon. Once we do a transplant, this is how the urine starts pouring out of the kidney as soon as we release the clamps. And this is what we are aiming for. Can you see this jet of urine coming? So this brings the smile in on everybody in the OT, whether it is the anesthesiologist, whether these are the assistants, surgeons, nurses, everybody is happy once we see this. With that note, I would like to thank everybody for a patient listening, and if there are any questions, I would be glad to take. So any doubts or questions? If you have, mic de dijiye, please.
Thank you, sir. Such a nice presentation. Sir, I want to know that what is the major difference between robotic and laparoscopic surgery?
So,
because robotic cost is very much high and laparoscopic is less cost.
So laparoscopy is a hand instrument.
Hand instrument. Yes.
Okay. So there's a surgeon tremor.
Yes, sir.
Number one limitation of laparoscopy. Number two limitation of laparoscopy is when we have to operate deep in the pelvis. So then it's very difficult because the space is very constrained.
Yes, sir.
And we have to operate so surgeons' hands are like this, and they are very, I think laparoscopic transplant did not carry on well at any place in the world. It was attempted at many centers, but then the results was not good, so it was aborted. So laparoscopy is a very good technique when we have to operate straight.
Yes,
like donor. We
Yes,
don't
sir.
need a robot for the donor because the results are excellent even with laparoscopy with minimal cost. But for a recipient, it's very difficult to operate. It is technically very challenging, and Robo has made the job very easy. So for pelvis surgeries in which we have to dig deep into the pelvis, like robotic radical prostatectomy or a transplant, in these two surgeries, robot has really made a boon. And if you see these patients in the OPD, they have very small incision here. Like 1/3 of a cesarean, mini cesarean incision through which we put the kidney. And that heals beautifully. There is no muscle cutting, there is no muscle splitting, there is no pain. The patient doesn't even know that there is an incision on the body. So when you see such kind of patients, then you feel happy and you feel more motivated to develop these techniques.
Okay, thank you, sir.
Welcome.
Sir, I want to ask one question. Sir, it's really great to see how you are doing, how you are serving the society. And my question is, how you handle the patient expectations? Because once that lady, she was also saying, we really want to hear what he said to us. And we came after consulting from lot of people. So the combination of a exceptionally expert surgeon and a good human being, how you handle this?
So answer is very simple. I have burnt myself over the years. I have burnt myself with the pain of my patients. And fortunately, I have such a brilliant team in the OPD to support me. They would convince the patient. They do most of 90% of the jobs they do. So once the patient meets me, I always tell them that I am a man who is full of errors. I have made mistakes. I've burnt my fingers. And this is I never hide the truth. If the patient has died in my hand, I always tell the patient that in my initial course of learning, these patients did not make it much. But then in today's date, I am confident to deliver this kind of result. This is expected. And still 1 out of 10 patients might go wrong. If we are crossing a road, there is 1 out of 100 chance that we might meet an accident. So this is what I tell them, and I always tell them the truth. And what I've learned over the years, the best way to convince the patient is to tell the truth. If we hide the truth, if we say I'm a 100% successful surgeon, so that is not going to work, and that is not the right thing. Once we tell the patient that this is what complications we have faced, and we have learned with these complications over the years, matured ourselves, And this is what is expected. And plus, if there is a complication, my entire team is always there in the ICU, and we are trying to manage the patient. And most of the times we are successful. So the patient's attendants also keep seeing कि डॉक्टर साहब भी 2 रात से सोए नहीं, हमारे मरीज के साथ हैं. So they, even if unfortunately the outcome is not good, still they know that we have worked hard for the patient, and that, I think that is the right strategy to do. And we have never faced any fight or harassment with the patient. So I always believe that telling the patient the truth is the most important thing. We started this program in 2017. So initially robotic transplant, it was a very difficult technique to master. We struggled 10, 12 cases. We struggled like anything. Then 2018, I gave up. No, I'll do an open transplant. But then again, in last year, after the COVID, we started doing it, and now our results are good. So I always admit that in front of my patients. Yeah. Yeah. No, exactly. We are doing such a big surgery, and we have to be on the same page with the patient. We have to treat the patient and counsel them as if they are our own family members. We have to tell them the truth. If we hide the truth, it counterfires. It will always come back. It will boomerang. So you always tell the truth to the patient, and most of the times patient will accept.
Thank you, sir.
Welcome. It's 2 lakhs expensive than the normal transplant. So whatever is the cost for a normal transplant, 2 lakhs rupees extra.
Thank you, sir, for this great presentation. So I have I have question. You have data regarding this laparoscopic surgery and robotic surgery?
I didn't do laparoscopy because
okay.
Transplant is a a procedure with very high stakes, very high expectations from the patient.
Okay.
And I never found myself to be fit enough to do a laparoscopic transplant, so I did not attempt it.
Okay. So regarding robotic surgery, you have data regarding this?
Yeah.
Okay. So we can find out and we can study.
Yeah, absolutely.
Okay, sir. Thank you, sir.
Can you please take the mic? Mic pass kar dijiye, please.
Good morning, sir. So actually, just want to know that as we have seen that the success rate of ABO incompatible patients in kidney transplantation, it is very successful. But can we do the same thing in RH incompatible patients?
Yeah, RH factor is not that important in kidney transplant because the RH antigen is not expressed in the kidney tissue. So RH is never a barrier. So B positive, B negative, it doesn't matter. So RH factor is absolutely negated. It is only the blood group. Mic le lijiye, please.
So, while performing robotic surgeries, what all complications do you felt while performing surgery that you have to? You said you were not confident. You have to do open. So I just want to.
My life is full of complications. So if I start enumerating that list, it would be too much. But yes.
And drawbacks of robotic surgery.
So robotics is a very difficult system to arrange. So there are complications with setting up the system and putting it up to the patient, docking and itself. It's entirely new for all of us. So everybody is learning. So I think we are not that senior enough to tell you all the complications. But yes, the only complication which I have experienced is number one, when we are flipping, that is a very technical thing. I don't know whether you'll be able to make up. When we are flipping the kidney in robotic transplant, we have to be very, very careful. That is the time where maximum bleeding or torsion in the kidney occurs. Because in this transplant, we are putting the kidney intraperitoneally. We try to make it retroperitoneally, which happens in a day or two automatically because the peritoneum regenerates. But then that is the point where I've opened a patient, although I just opened it because of my fear and apprehension. But once we opened it, we saw everything was fine. So we did not have to do anything. But then out of my anxiety and fear, I had to open that patient.
Any drawbacks?
Cost. Cost
Other-
is a big drawback, big hindrance.
Other than that,
Because we are not able to contain the cost. It's a very expensive machine from the hospital. The consumables are very expensive, but in due course of time, we should be able to bring down the cost. Other than that, once that learning curve is over, I think this is the Range Rover.
thank you.
So with that, I would like to invite Shashi to continue with her talk and finish it off in crisp 10 to 15 minutes because we have a lunch and we are already getting delayed. Yes, definitely.
Thank you, sir, for very excellent and crisp presentation. I would like to invite Divan sir for felicitation of Dr. Ranjan. Thank you, Divan sir.
Shashi, I would just request you to stretch over because running short of time and we have to break for lunch. So make it as short as possible. So Shashi would be talking about the way we counsel these patients before a transplant, what are the legal formalities they have to undergo and what are the things we should remember as coordinators or as the members of the transplant team when we are preparing the files of such patients. I think she has got a file here also of one of our transplant patients. So any doubt if you have, you can go through these files.
Hello everyone. So today we will discuss about the counseling and legal workup for a living donor kidney transplant. So why is counseling needed? Unaware patients, clueless about the disease, don't know what is the survival benefit. Tremendous anxiety in first visit, do not accept surgical treatment at the first go, myths about survival in society, myths about cost, false impression of a dome in life.
Mic on. So this is the most important part when a person is coming to you for a transplant, this is the most important slide we have. The entire crux of presentation she has brought into this slide. When the patient initially talks to a counselor for a transplant or a coordinator, now we are talking about living donor transplant, we are not talking about deceased. So the patients most of the times are clueless about this disease. As Dr. Anna rightly pointed out in the morning, most of the patients are asymptomatic. So they don't know what is the disease. They come with a value of a creatinine of 5. So they will not know, they will not accept that they have a disease and they have end-stage kidney disease. And to break the news that they are a candidate for transplant, it is too much for them. They will run away from the OPD. They don't want to accept. First stage is denial. The patients are actually unaware of what is the survival. They are very anxious. So this counseling part is very, very important, and this should be done by one of the senior people in the team. Spend 10 minutes, understand their anxieties, let their fears come out, and then start talking. This is the most important part which will make the success of the transplant program, because these patients actually develop confidence once they talk to the coordinators. So I always tell my coordinators also, they are the first line of contact between huge expectations. He has a lot of anxieties in mind. And the coordinators, transplant coordinators, are the first people who interact with these patients. So to have a balanced head, to have a very soft engagement skill is very, very important. And to know all these points beforehand that the patients will be anxious goes a long way when you counsel these patients for a transplant.
So the principle of counseling assurance of survival over alternative treatments, building faith in your surgeon and the center, assurance of donor safety, assurance of recipient's outcome, financial aspects pre, during, and post-transplant, simplification of the legal procedure, minimization of time to transplant. So would you like to elaborate?
The only thing is that the transplant coordinator should be able to build a trust of the center with the patient, because most of the time senior doctors are not the first ones who are interacting with the patients. These are the transplant counselors. So these are the principles by which, when you are counseling, your patient is likely to build trust and faith in your center. Not just go straight away and talk about the finances and the treatment. First, you should be able to, as Dr. Anna pointed out, you should be able to tell them what is the survival on alternative techniques, alternative ways of treatment, such as dialysis and anything. And then all these points come on. Many patients are afraid of legal formalities. Court jana padega, kachari chakkar lagana padega, affidavit banega. So they are very frightened. Kaun court kachari ke chakkar mein pade, isse acha dialysis kara lo. So these doubts needs to be cleared. This dirt has to be vacuum sucked by the transplant coordinators.
So the explanation of the process. We follow the two processes. First is medical workup and another one is legal workup. So in the medical workup, we do the donor and recipient investigations, fitness of kidney, fitness of donor to donate a kidney, fitness of recipient to receive a kidney, mutual compatibility, that means cross-match, optimization of the existing comorbidities. And in the legal workup, there will be the establishment of the identify of donor and recipient, establishment of the relation, establishment of an emotional attachment, establishment of donor safety, establishment of the proof of residence, NOC, and clearance from authorization committee.
So this is also the job of the transplant coordinator, to bring it to the notice of the treating team that whether the donor is genuine or not. So this is a very, very important aspect which you should learn, and this comes with experience. The more you talk to the patient and the attendant and the donor, the first interview with the donor and the recipient is very, very important. There are so many hidden signs which you notice. The body language between the donor and the recipient, the way they are talking to each other, the way they are behaving outside the OPD chamber. There are so many, my coordinators, they will sometimes tell me, sir, ये तो donor recipient आपस में लड़ाई कर रहे हैं, इनका कुछ पैसे का चक्कर है, ये ऐसे behave कर रहे हैं. So these are the some signs which you need to be vigilant and notice. When the patient has left your room, you must observe what they are doing, what they are talking, how they are fighting, how they are behaving. These are very evident signs by which you can predict that there is some foul play between this donor and the recipient. So the transplant coordinator is the first person who has to be very, very vigilant and pick up those cases to bring it to our notice, because normally doctors have very little time. They come out of the OT and they see the patient in 10 minutes, they might miss. But once you are talking and counseling the patient, you must be very, very vigilant and observant of the physical body language of the patient, the way they are producing the proofs. Everything you need to notice. That maturity comes with time. The more and more you talk to these patients, the more and more you interact with these patients, the more you are able to pick up those things.
So these are the basically stages of CKD.
You can skip these and go to the...
All right, sir. And this, we already had a discussion on this. So next, the cause of poor survival on dialysis. First is heart attack, stroke, multiple infections, anemia, poor nutritional reserve, dialysis transmitted infections. So is the kidney transplant expensive?
Yeah, this is the slide which we're talking about in the morning, the costing. You can see after second year, in the first graph, you can see after second year, the expenses of dialysis cost is much more rather than getting a transplant done. So once the patient crosses first year of dialysis, then his expenses are actually more than what he would have incurred on a transplant.
So complications of AV fistula. So
All
there
these
is
are financial implications to the patient. They develop complications with their vascular access, fistula problems.
timing of the transplant. So
Again, what Dr. Anna told in the morning, preemptive transplant is the most important phase in which a patient should be transplanted. Unfortunately, patients do not know about it. Most of the patients would go on dialysis and then from somewhere they learn about the transplant and then they come for a transplant. Actually, a patient of chronic kidney disease, once his creatinine is 5, 6, 7, once the patient as well as the clinician knows that this candidate is being matured for a transplant, they should be offered a transplant even before the start of dialysis. That is the right treatment, because the survival of a kidney as well as the patient is much better when the patient is done in the preemptive phase, when the patient is transplanted before the initiation of dialysis. Once the dialysis starts, the patient loses so many advantages. The graft life halves, the complications because of dialysis. Even one dialysis can make you HCV, HBV or HIV positive. So once you become hepatitis B positive, there is no treatment available. You might end up spending 50 lakhs on a liver transplant as well. So the best results of a transplant are occurred in the preemptive phase, and this is a very important aspect to be counseled to the patients in the OPD.
So again, the survival of kidney and
Come
patient.
to the legal formalities. पीछे जाओ. हाँ, who all can give a kidney? Yes.
So who all can give a kidney? It could be parents, brother, sister, spouse, children, grandparents, grandchildren, emotionally related.
So these are the people who are defined by the Act, who can give a kidney to their loved ones. We have a Human Organ Transplant Act of India, and there are amendments in which they have included now grandparents and grandchildren also as near relatives. So these are the genetically related people, and the last one clause is emotionally relative. So this is also a very important clause which you should know. So somebody can be emotional. The law says there should be no organ commerce. There should not be a transaction of money between the donor and the recipient, or the donor shouldn't be harmed. There is a clause of genetic relation or emotional relation. So emotional relation could be between a servant and his employer. It could be between two friends. It could be between absolutely two unrelated individuals. There are people, one of our transplant surgeons, senior transplant surgeons, donated a kidney to one of his friends. So emotions, there is no price, there is no replacement for emotions. If somebody out of love and affection wants to give a kidney to somebody, so law doesn't stop it. Only thing law needs is that the proof that this is entirely out of love and affection. It is not because of money or any other interest.
So the documentation of identity, legal documents, supportive documents, medical genetic establishment, photographs of the family event and long-standing association.
Have you got the photographs of the family?
Yes, sir.
Just show them, just show all those. These are the government agencies. Most important is now you all know this website, UIADI. What does it stand for? Who will tell the full form of UIADI? One of you please stand up and tell. Whoso knows? Anyone? What is the full form? Wonderful. So this is a very important website for all of us who are working in the field of transplant. Once the patient produces an Aadhaar card, you can very well identify the genuinity of that Aadhaar card on this website. So we have to involve the personnel who are from the legal department. We are healthcare professionals. Our job is not to establish the identity of the donor and the recipient. हम तो अस्पताल में बैठे हैं, मरीज का इलाज कर रहे हैं. हमें ये कैसे मालूम कि ये असली जो है हस्बैंड वाइफ हैं या नकली हैं? तो उसके लिए सरकार ने बहुत सिंपल से सिस्टम सेट कर रखे हैं. एक तो उनका आधार कार्ड उनकी वेबसाइट से वेरीफाई होना चाहिए. दूसरी चीज़, जो उनके एफिडेविट्स बनते हैं वो एसडीएम जो फर्स्ट क्लास मैजिस्ट्रेट होता है, डोनर रिसिपिएंट के एफिडेविट्स वो अटेस्ट करता है उसकी प्रेजेंस में, जो कि तहसीलदार से वेरीफाइड होते हैं. तब SDM के पास पहुंचते हैं और वहाँ कैमरे में सारा कुछ रिकॉर्डेड होता है. So responsibility is not us. Our responsibility is to check that the patient has made a genuine affidavit. Have you got a copy of the affidavit?
Yes, sir.
Just show the. You all know how does an affidavit look like? So this is an example of an affidavit. So this is how we make two affidavits from the donor and the recipient. The donor pledges that so and so is my relative and doctors have advised a kidney transplant and I want to donate my kidney out of love and affection to that person. And this is attested by the SDM of that area. So similarly, an affidavit is made by the recipient that so and so person is donating me a kidney, the relation is this, and I have not pressurized or I am not passing on any money for donation of my kidney. So these two affidavits are attested by the SDM, Executive Magistrate, First Class Judicial Magistrate. And the third affidavit, fourth affidavits are of the close relatives. So somebody who can testify that these two people are brother and sister, these two people are husband and wife. So other family members such as father, mother, brother, other relatives also have to put an affidavit in which they can testify that this is the relation between the donor and the recipient. So this is a very, very important part of the legal workup of the file. Come back to the previous slide. So this is a police verification. You can see this letter comes from the police SSP. So one step is employment of the government agencies in the identification. One was UIDI, Aadhaar card. The second was the SDM, and this is the third government agency which is involved. This is the SSP. So we write a letter to the SSP to verify the place of residence and the other identification of the donor as well the recipient. So the SSP deputes a team, whosoever is the local police station, and they go to the home of the donor as well as the recipient, identify whether they are living at this place or not, whether they are true residents of that place or not, and they give us a report in written, which the previous report. So this is very important to achieve. So two things are very important. You should have those affidavits. Number two, you should have a police verification. These are the two most important documents in your file when you're preparing a file for a transplant. Then there could be supportive documents which could be from the mayor, which could be from, well, people of distinguished social repute, some IS officers, some who can attest and testify that this person is so and so. Again, this is, all of you know what is Form 5? What is Form 5? Sujata told you on the first day. What is Form 5? So Form 5 is given by? So the Form 5 is given by the head of the family, head of the lab, who certifies that this patient is genetically related. Okay, so this is again a very, very important, and this should be signed by the lab, head of the lab, that these are two patients who are genetically, this is father and son, this is twin brothers. And this is form number 4, again, you remember form number 4? So this is the medical fitness which is given by the treating doctor, that this donor is fit to donate or this patient is fit to receive a kidney. So form 1, form 2, I'm sure you must have gone through all these forms when Sujata gave you. So these are the photographs which we are looking at. These photographs should be normal, natural looking photographs. This should not be photoshopped. You should be very, very careful when you receive these photographs from the family. Check the background, what kind of background is there, what kind of people are standing, and does this look like an original function or not. So a transplant coordinator's eye has to be very, very vigilant in picking up any abnormalities in these photographs, whether there is any photoshopping or hanky-panky going on or not. So we ask for multiple photographs, multiple events which date back 5 years, 10 years before, so that we know the length of the relationship. So again, this is very important. So with all these documents, the patients are presented to the authorization committee, and the authorization committee consists of so many people, in which there are doctors from the hospital, as well as there are personnel who come from government agencies, such as the DRME office, such as the civil surgeon office. There's one person from the judiciary. So there are multiple people from different fields. None of the transplant team members are a part of the authorization committee. So once this is done, then we are all set to go with the transplant. Once we receive this letter from the authorization committee, then we can carry out these transplant formalities. Okay? Chalo, I think we can go off. So with that, if there are any doubts, you can straight away ask. Yes, Sujata. Yeah, so most of the times when we get suppose the police verification, when we ask for the police verification, we never receive the police verification by hand by the patient. Right. So we address it to the SSP by email as well as by a registered post, and when the letter comes back, it comes back by the name of the medical director. It doesn't come by hand with the patient or through the email. So those emails are already verified emails. This is not a fee, although there is a possibility of phishing, but then we have to be very, very careful.
Right.
Yes. It depends upon the intelligence and the alertness level of the patient and the attendants. कई दफ़े ऐसा होता है कि लोग एफिडेविट बनवाने में ही 6 महीने लगा देते हैं, आज नहीं कल चलेंगे, कचहरी में लाइन लगेगी, और कई इतने तेज़ तर्रार पेशेंट होते हैं 7 दिन के अंदर एफिडेविट बन के कमेटी हो के ट्रांसप्लांट करा लेते हैं. So it depends upon the level of the family. कई बार families जो बड़ी ढीली ढाली होती हैं, आज कराएंगे कल कराएंगे, but most of the patients at our center would receive a transplant within a month. So simplification is we tag each transplant coordinator with the patient. So one of my transplant coordinators is regularly in touch, talking to the patients, and whatever problems they have now, by virtue of being in trade for more than a decade or so, we know the most of the authorities at different places. So जहाँ भी मरीज का काम रुकता है, we know who is the key person who can get it done. कहाँ पे कौन तहसीलदार है, कहाँ कौन नोटरी है, किसकी परमिशन कहाँ से होती है, कौन सा कागज़ किसके ऑफिस से निकलता है. So we can just make a phone call and try to simplify those things. Otherwise, most of the formalities are very, very simple. If you write to the SSP, if you approach the senior most officer in the hierarchy, they are very prompt to respond. And police takes hardly 7 days, 3 to 5 days to revert back. So, the legal formalities are very, very simple. You just need to have an affidavits in place, which are attested by an executive magistrate. You need to verify either the Aadhaar card, passport. Usually these are genuine documents, but you have to be very, very careful again. And then once these cases, so these are the two most important things. One is the affidavit and the other is the police verification. Once you have these two documents in place, others are supportive documents. The bank statement, many a times patients and donors have joint bank statements, aging years. So you know that this is a genuine pair. So this is how, with experience, we know that if something is going wrong or not by simply the body language, the way they are talking. One more important aspect, I think, which you had written was ITR. So the law always also says that you see the income tax return of the donor and the recipient. So if there is a mismatch, the donor is a rich, very poor person who has an ITR of less than 1/3 of the recipient, the law wants it to be investigated by a judicial officer. कि अगर किसी की जो किडनी ले रहा है उसकी कमाई साल की 1 करोड़ रुपए है, जो किडनी दे रहा है उसकी 10,000 रुपए है, तो कुछ हैंकी पैंकी है. सो नॉर्मली एक किस तरह के कपड़े पहने हैं डोनर ने, किस तरह से बात कर रहे हैं, इनसे आइडिया लग जाता है कि दोनों लगभग एक ही समान उसके हैं कि अलग अलग हैं. भूख लगी? चलो, थैंक यू. यस 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 प्लीज. बेटा ये हैं डिफरेंट लेवल्स पे हैं, कभी हो जाती कभी नहीं. नॉर्मली इतना समय ही नहीं होता मरीजों के पास. दे आर सो सिक. कई पेशेंट अप्लाई करते हैं, बट यस बिहार गवर्नमेंट हाँ कर दो. So this is yesterday's photograph. I would request, we had 2 sets of photographs. तो आप लोग अपनी देख लीजिए किसकी कौन सी फोटो किस में अच्छी आई है, तो वो अब मुझे बता दो नंबर, so that we know the numbers, we can get it printed. So we have one more photograph. इसमें जितने लोगों को चाहिए वो आप प्लीज़ हाथ उठा दो, so that we know the count. So one of you please help me with the count. Simran, you should count. नहीं, नेक्स्ट फोटो में आ जाएगा, इसीलिए मैं कह रहा हूँ जितने लोगों की इसमें आई हो. ठीक. And this is the second one. So just count the number of the first photograph and number of second. ये आप लोग सिमरन को लिखा दीजिएगा, so that we can get it printed. Okay, let's see. Let's do it on the day of certificate distribution, last day. So be in your best clothes then. Okay, be prepared for the photograph. Okay. Sorry? Previous one? I think this is the previous. Okay. So everybody will get both. Don't worry. No worries. So let's move towards next session, which is a very, very interesting and a very, very important organ in the field of transplant. I would request you come on the front seats. It would be better. We have a very, very eminent and a senior speaker with whom you would, I'm sure, ask multiple questions. So pancreas transplant is one of the most difficult transplants for surgeons, and only a very few surgeons across the globe are doing it. And in India also, we have very few centers which are offering this program, and I'm glad that our PGI Chandigarh is one of the foremost centers in developing this program and leading this program in the country. So can anybody of you tell me what is the indication of a pancreas transplant? Does anybody know? No idea? Don't worry. Dr. Ashish sir is there. He'll tell you everything. So for delivering that talk, we have one of the most prominent surgeons, transplant surgeons in the country, Professor Ashish Sharma. Sir has been my teacher also, and he is currently heading the Department of Transplant Surgery at PGI Chandigarh. Yesterday, all the talks you read about donation after brain death, donation after cardiac death. So DCD program is primarily pumping in PGI because of his initiatives. So they are a busy department of transplant, and they conduct more than 50-60 transplants every month. They have a very robust cadaver kidney transplant program as well as the pancreas transplant. So sir has come here. Sir, thank you so much, sir, for taking out time to deliver us a talk on pancreas transplant. And sir will tell you what is the current status and how do we actually make this difficult surgery happen. This is one of the most difficult surgeries for transplant surgeons. So with those words, I would like to invite Ashish sir on the dais.
Thank you, Ranjan, for the kind introduction. So at the outset, I would like to thank Mohan Foundation along with the management of Fortis, Dr. Ranjan, Diwan, and I think it's a great initiative. I mean, unfortunately, north part of our country has been lagging behind in organ donation. So much activity happening all across the country. 1,000 donations in 1 year is what we have achieved, but nothing from the northern part of the country except for PGI Chandigarh. So we hope that we are able to have more and more hospitals involved in this process, and for that purpose, this CME and similar CMEs are most important. So it's a post-lunch session, and I don't. It's a difficult subject, difficult organ. So I don't know how many of you are going to fall into the trap of sleep. So I'll try to make it more interactive. So can I have a show of hands? How many of you are actually nurses? So almost. And how many are not nurses? And what are the other professionals who are sitting here? So how many are not nurses? So doctors, are you all doctors or what? So can you just say what background do you have? Because the talk will obviously depend upon. So क्या background क्या आपकी? Paramedicus. Okay, right. So you will have some knowledge of. So it's a great show. I mean, the hall is full. On third day, if the hall is full, that means the program is going very good. So now coming to the subject, why do we need it? Why do we need pancreas transplantation? Right. So these are the broad questions you must be having in your minds when we talk of pancreas transplant. So if you have anything more than that, you are free to interrupt anytime or after the talk, right? So first of all, this is the thing we are going to talk about, right? So very inconspicuous organ if you open up the abdomen, but causes a lot of difficulty when it gets inflamed, is what is called as pancreatitis, right? So when you are doing your surgery, you are taught that do everything whatever you want to, but don't fiddle with the pancreas. So pancreas को अगर हाथ मत लगाना, वो अगर छिड़ गया तो फिर आपका सारा सर्जरी खराब हो जाएगा. So before I start, I'll just again tell you something about the anatomy. So this is the pancreas. तो स्टमक होता है यहाँ पर, स्टमक के बाद आगे स्मॉल इंटेस्टाइन ड्यूडेनम बन जाता है, एंड ये स्प्लीन है. तो ये पूरा कॉम्प्लेक्स ही, जब हम पेनक्रियास ट्रांसप्लांट की बात करते हैं तो पूरा कॉम्प्लेक्स ही बाहर निकलता है और पूरा कॉम्प्लेक्स ही पेशेंट में, रिसिपेंट में लगाया जाता है. अकेला पेनक्रियास नहीं लगता है. कोई भी ऑर्गन लगाने के लिए उसकी ब्लड सप्लाई बहुत ज़रूरी है. तो पेनक्रियास की जो ब्लड सप्लाई है 2 जगह से आती है एज़ कम्पेयर टू अदर ऑर्गन्स. ऑल अदर ऑर्गन्स है 1 डोमिनेंट सप्लाई. आपको रीनल आर्टरी, एक आर्टरी मिलती है, आपने एक आर्टरी को जोड़ना, आपका काम खत्म हो जाता है. सो पेनक्रियास गॉट अ डुअल सप्लाई, सो यू गॉट अ डबल सप्लाई. और दूसरा कॉन्फ्लिक्ट इसमें आता है कि लिवर और पेनक्रियास के काफ़ी ब्लड सप्लाई कॉमन है. So whenever you are having a multi-organ retrieval with pancreas, there is always a fight between the liver surgeon and the pancreas surgeon. Liver वाला कहेगा यार ये मेरे को दे सारा, pancreas वाला नहीं भाई मेरे तो चाहिए, मैं क्या करूँगा. So this fight always goes on. So what is the function of pancreas? अगर function पता होएगा, then only we'll say कि what deficiency disease will it produce in deficiency, right? So we've got 2 functions, exocrine, endocrine. तो टू सिंप्लीफाई कि आप जो भी खाना खाते हो तो ये पेनक्रियास जूस सिक्रीट करता है स्टमक में, और उसी से ही वो डाइजेस्ट होता है. जो दिखाया था ये सी लूप ऑफ ड्यूडेनम है. तो सारा जूस, सारा हमारा फूड जो है इसमें ट्रेवल करता है, और पेनक्रियास के जो जूसेस हैं वो इसमें आते हैं. तो दे जस्ट ब्रेक डाउन ऑल द फूड, राइट? एंड दैट इज़ अ डिफिकल्ट पार्ट ऑफ इट. नॉट ओनली दे ब्रेक डाउन द फूड, अगर ये आपका थोड़ा बहुत भी लीक हो जाता है, जो भी आप ज्वाइन लगाते हो, अगर थोड़ा सा भी लीक हो जाता है तो आपका सारा कुछ बॉडी को भी ब्रेक डाउन कर सकता है. द एंजाइम्स आर सो स्ट्रॉन्ग, राइट? एंड यू कैन इमेजिन इफ इट इज़ रिक्वायर्ड फॉर अब्जॉर्प्शन ऑफ फूड, अगर वो ब्रेक डाउन ही नहीं होएगा तो अब्जॉर्ब नहीं होएगा. अगर एक्सोक्रीन डेफिशिएंसी हो जाए, अगर पेनक्रियास खराब हो जाता है, एक्सोक्रीन पार्ट डैमेज हो जाता है, तो यू एंड अप हैविंग chronic diarrhea, malabsorption. But the second more important function is the endocrine function. We don't do transplant. Very few transplants are done for an exocrine deficiency, right? Most are because of its endocrine function. Endocrine function, diabetes, सबने सुना होगा. Everyone is aware of diabetes? Yes. So, and is everyone aware of 2 types of diabetes, type 1 and type 2? Yes. So it is type 1 and type 2. So the people who deal with diabetes, so what do you think, are they similar or are they different? Loudly please. In what way they are different? Yes please.
Type 2 diabetes mellitus, insulin is there, but
Yeah, so in type 2 early part, you've got more insulin than the body, right? And in type 1, there is no insulin. So that is a very simplified definition. But if, when you talk of managing the patient, it's a very different spectrum altogether. Type 2 कुछ नहीं है, 2 गोली एक खाली आपका sugar control होता है, right? For many years, you will be control on 1 tablet, 2 tablet, maybe 3 tablets. Later part of 10, 15 years down the line, you might require some insulin. Even then, you carry on easily. थोड़ा सा baseline sugar high रहता है, but that's okay. चल जाता है 20, 25, 30 साल चल जाते हैं. Type 1 is a very different disease. You have no insulin in the body, right? So, if you have any food, your sugar will spike up. 500, 600 हो जाएगा. If you inject insulin, it will go into hypoglycemia. Sensitivity of insulin is so high because the body does not have any insulin. Body becomes very sensitive to insulin. So, if you give a little extra insulin, your sugar may drop to 50, right? So, this is the wide variation, and this is what causes a lot of difficulty for these patients. And then the onset is very different. Type 1 will happen in very young age. Most cases will be below 15 years of age. It's in fact one of the most common chronic disease in the kids. And as I said, that the fluctuation is so much that they will invariably come with coma and many times similar situations. Right. So this is the patient after about 20 years. Because they are young, they are going to live for many years, and invariably they are going to land up with end-stage kidney disease. They will not die of diabetes if it is managed with any medical therapy. So earlier they used to die of infective complications. Diabetes है, sugar uncontrolled चल रही है, they will die of infections. But now with some insulin being given in, so they will not die of infections. Now this is the second most common thing. They will end up with kidney failure, and that is when they come to us. And not only they have kidney failure, they have got some retinopathy. They will have some changes in your retina, blind. Many of them will have some laser therapy for it, and they will have neuropathy. So in effect, they are the most complicated recipient. That everything microvascular disease, सब tissues में हर जगह है, and they are very prone to any complications if it happens, right? And even on dialysis, what we have seen that currently now we have patients on dialysis. What is the longest patient have you seen on dialysis? Any one of you? कितना longest survivor on dialysis कितना देखा होगा? Maybe Dr. Anna can tell. Yes, 16 years, right? So, and Dr. Anna, आपका तो और भी होगा.
Staff patients, yes, we have seen probably they are going for 12 years, 13 years.
Yeah, so it like easily now dialysis becomes so good that you have patients who are surviving for 12, 14 years. And we know that patients who have diabetic nephropathy, they survive for lesser time, right? But with type 1, we have only one patient who has survived for dialysis for 4 years. That is the only patient. The rest, all they die within 1 or 2 years. So it's a very different spectrum. Everything is very different with them. Very difficult to manage them on this type of therapy. So that is why this transplant becomes all the more important, right? So what are our expectations from transplant? Obviously, we want a normoglycemic state कि आपका जो sugar बढ़ा हुआ है वो कम हो जाए, normal हो जाए, and ये normal medicine से भी हो सकता है, insulin से भी हो सकता है. But the trouble with insulin is that whenever you try to reach a perfect normoglycemic state, you end up with complications of hypoglycemia. Insulin को जितना टाइट कंट्रोल जब भी करने की कोशिश करोगे हाइपोग्लाइसीमिया आएगा, और इन पेशेंट्स में बहुत ज़्यादा होता है बिकॉज दे डोंट हैव एनी रेगुलेटरी मैकेनिज्म जो बॉडी नॉर्मली कंट्रोल करती है. अगर हाइपो है तो पेनक्रियास बाकी हार्मोन सिक्रीट करता है, शुगर्स को नॉर्मलाइज करता है, इनमें वो मैकेनिज्म सारे खत्म हो गए हैं, राइट. सो करंटली एंड लॉट ऑफ एडवांसमेंट्स इन इंसुलिन थेरेपी ऑल्सो. एक्चुअली नाउ वी गॉट पम्प्स, इंसुलिन पम्प्स की बॉडी में इंसुलिन पंप लगा दो, वो कंटिन्यूसली इंसुलिन देता रहता है. And not only that, we have feedback pumps also कि वो continuously glucose monitor करते रहते हैं. They keep on beeping it, and now those are actually integrated also कि जैसे ही शुगर कम होनी शुरू हुई तो वो बंद कर देता है, और जैसे ही शुगर बढ़नी शुरू हुई 200 से ज़्यादा हुई तो इंसुलिन लगानी शुरू करता है. But even with these type of feedback loop pumps, you cannot achieve normoglycemic state, right? So currently, despite all medical advances, even in the US, this is the only way to achieve sustained normoglycemia, right? And we can do either a whole organ transplant, and I'll come to beta cell transplant later. So this is one of my patients, right? 30 years old, developed diabetes at the age of 4 years. Just imagine a 4-year-old child developing diabetes, and he's on insulin injections. 5 बारी उसकी शुगर चेक होती है, 6 बारी इंजेक्शन लग रहा है, And despite that, continuing his parents, I just hats off to them. 25 years they managed him like this, right? Till he ended up with us with kidney failure, and he was totally devastated. Didn't want to live altogether. कि भाई इतना साल हो गया करते हैं, I am tired and I've given up. So he had hypoglycemic awareness. Normally when our blood sugar goes down, sweating होनी शुरू हो जाती है, heart rate बढ़ जाता है. But with this diabetes, neuropathy happens after a while. Microvascular changes, nerves भी damage हो जाती हैं, and this mechanism is also lost. So you even are not able to tell that sugar is going down, right? Normal person will भूख लग जाएगी उसको, तो he'll have something, but they lose that ability also. So he used to go into coma while sleeping. So his family used to sleep with him. जगा के देखते रहते, भाई जिंदा है ना अभी. So this is the type of state he was in, and now he's enjoying cup of barista and he's driving car, and so back to normal life. And he's not the only one. In fact, we have a lady also. I don't have her picture. So she also was transplanted at the age of 20 years, had developed diabetes at the age of 9 years, and now after 5 years after transplantation, she is married and she's into pregnancy, and that will be probably the first pregnancy after pancreas transplant being reported from our country. So coming back to the next part of the talk, like how can you do pancreas transplant? So either you can do both together. You have a patient who's got a kidney disease, so दोनों pancreas kidney दोनों लगा दो, एक ही बार में दोनों problems का छुटकारा हो जाएगा. But what happens is that sometimes pancreas are not available or the expertise is not there, so patients end up having only a kidney transplant, right? So you got a living donor, you don't want to wait for the pancreas transplant कि कौन wait करेगा 2 साल, आप मेरा kidney कर दो, pancreas बाद में देख लेंगे. So that is also possible. That's what we call as pancreas after kidney transplant. And the third category is pancreas transplant alone. So a lot of people actually come to me कि why wait for the complication to happen? Why to develop nephropathy, end-stage kidney disease, and then do a pancreas? Why not we do it beforehand only? So so these are the 3 situations we can use. And very rare are the patients with exocrine deficiency. So normally very rare. So we have not done even world literature also, but it is possible to do it for that. So first was done in 1966, so quite a way back. Kidney was done in 1954. So about 12 years later, they did the first pancreas transplant. But still, it's not a very common operation. And this is the graph, total number happening over the world. So if you see that there was a peak in about early 2000 when actually a lot of interest was developed in pancreas transplant alone, which has now waned off. And now I think about 1,000 transplants per year happen across the world, and out of these 1,000, most of them happen in the US actually. So it's not a big number if you see. So that's what I was talking, that the PAK and the PTA are the lower ones, and the SPK, this both pancreas and kidney. So that is the one which is continuing to carry the most of the activity. So बाकी दोनों में interest wane हो गया. So we'll talk about it. And what about in India, right? So we a lot of experience in India with kidney, liver. The centers are blooming, right? So many centers, but where are the pancreas transplants, and where are the pancreas going, right? So less than 150, right? Even in the last decade, so many donations have happened, almost nearly 1,000 donations every year, and we still done less than, total number is less than 50 since the beginning of pancreas transplant in 2004 at All India Institute, right? So these are the numbers of individual centers. Ours are the latest. Others might be about a couple of years old. So very few centers. And why are the numbers so low, right? So one, we know that the disease donation was never there before 2008 से पहले there was cadaver donations were almost non-existing. But the second important thing is that there's no training program in the country. So no program in the country is at presently focusing on pancreas transplant, right? And it's got a high complication rate. But the most important reason I believe is that when it started with a very bad publicity. Right, so bad publicity means that we've had the first transplant, I think in 2010 in, I believe Chennai, Tamil Nadu, Apollo Chennai possibly, and that was wife of a colonel, young patient, 40 years, diabetic. So they did both the transplants together. The pancreas ended up with a complication. The surgeon tried keeping in rescue it, but ultimately ended up with losing the patient. The colonel went to the court, and it was found that the license of the hospital was only for kidney transplant, not for pancreas transplant. Surgeon had to cut a very sorry figure. He had to leave his practice in the country, and that is why it fell into bad. A lot of publicity in the press happened with this. And the most important reason, but I still believe, is that there is a lack of trained surgeons in the country. And we see that the dominant source for these organs is the deceased donor only. So this blue bar is living, but you don't see the blue bar numbers are probably less than 10. It happens, but dominantly only in one center in the US does a living donor pancreas transplant, where you just take a part of the pancreas and put it in the recipient. Right? Rest all are dominantly deceased. So this is the publicity which I was talking about, the negative, and this was Fortis Hospital, and actually not Apollo, Fortis Hospital. So what do you require as an patient आएगा आपके पास? You are all, some of you would be coordinators for the living donor program. So what all living or disease donor program? So what all preparation is same as kidney or any other transplant. Standard list of investigations, standard consultations. So this is the only additional 2 or 3 investigations what you require for pancreas recipient. So basically, you have to document that their blood sugars are well controlled before you take them up for a surgery. So you don't want to end up with the patient on the table who's got a very high sugars, poor control leading to infection and leading to all the comorbidity. So the only extra investigation is the C-peptide. So C-peptide basically measures the insulin in your body, right? So you don't measure the insulin because आप exogenous insulin patient को दे रहे हो. If you try to measure the blood level of exogenous insulin, वो उसमें reflect हो जाएगा जो भी insulin आप लगा रहे हो. But C-peptide is कि when the body secretes insulin, उसमें एक C-peptide है, उसको break करती है and then insulin works. So if you measure the C-peptide, you know that what part of the insulin is coming from your own body and what part is exogenous. So your C-peptide should be less than undetectable, either undetectable or less than 4 or 5, and then you measure the antibodies against the pancreas. So these are the antibodies actually which destroy the pancreatic islet cell for before the patient lands up in type 1 diabetes. So I'll just skip this. So sources, we already talked that it has to come from mainly the donors after brain death. So one of the reasons why the numbers are low are that you are very selective as far as a pancreas donor is concerned. You want them to be in optimum condition, right? No risk factors. Age has to be less than 50 years. You prefer a non-traumatic. So all trauma cases you take. The non-traumatic, you just ignore them, right? You don't want patients with strokes, right? Because they have other comorbidities. In the donors also. Ischemia, you want time, you want to restrict to less than 12 hours, and multi-organ donors are the best suited. And obviously, if the donor has history of diabetes, you will not take pancreas. And obese patients, anyone who has got a BMI of more than 30, they have fatty infiltration of the pancreas, so you just don't take all those donors. So this is the timeline. I think you must be all aware. So this probably is quite similar for all recipients and all donations. So I thought I'll just share some of the pictures. So this is a liver on the top, which is being retracted, and stomach on the bottom, and you open up the what we call as lesser sacs, so whatever tissue, and then you see the pancreas. You assess, it should be there should be no fat around it, right? And this is the pancreas which has been just prepared at the time of transplantation. So this is the C loop of the duodenum, head of pancreas. This is the body and the tail, and this is the arterial supply. This is the venous supply. So we talked that there are 2 types of 2 arteries. So both are joined together to form a single trunk, which is then anastomosed in the recipient. So this is again another picture. So this is the graft duodenum. The portal vein, the superior mesenteric artery, splenic artery. So these are the 2 arteries which supply the pancreas in the donor, and we join them with an arterial Y graft, 2 Y limbs to both the arteries, and this is the common trunk then. So this is the part of dissection going on in the donor. So pancreas always comes out with the spleen in place. You don't handle the pancreas a lot. You just use spleen as a handle to manipulate the pancreas and just take it out with it. So coming to the recipient operation. So when you do a recipient operation, the cut on the recipient is different. You give a midline incision so that you can approach both iliac vessels. On the left side, you place your kidney, whereas in a normal kidney transplant, you always place it on the right side. And on the right side, you place your pancreas transplant. The anastomosis, the arterial and venous anastomosis are almost the same. The only difference is that you have to drain the exocrine secretions of the pancreas. If you don't do anything for it, they can cause havoc. And what you do is that the C loop of the jejunum is joined with the recipient's intestine so that the secretions can easily drain into the recipient intestine. Early in the history, this was thought to be more challenging in the sense that these pancreas used to reject a lot, right? So you will have rejection. So there was no way to monitor them. Kidney is very easy. Do a biopsy, you will know but pancreas you can't do the biopsy, kidney biopsy, to document whether the pancreas is being accepted by the recipient host appropriately or not. So they used to drain the duodenum into the urinary bladder, and in urinary bladder you can measure the pancreatic secretions, कि उसका mileage कितना चल रहा है, urinary mileage, so you can monitor. But definitely the enzymes used to cause a lot of cystitis, so bladder urinary symptoms होते थे. So then now it is almost gone out of practice. No one uses it, except if you have a complication and you want to rescue the pancreas, then you can convert from a bladder to an enteric drainage. I think we can probably just skip this. So this is how it looks after all anastomosis have been done. So this is the pancreas here. That is your C loop of duodenum here. And here it has been joined to the small bowel of the recipient. So the most important thing, if you do all this effort, what are the outcomes? Survival figures, right? And these are the historical figures starting from if you see 1980s. So if you see that 1 year survival, the top uppermost is 1 year survival, the lower graph is the 5 year survival, and there are 4 lines drawn on it. The top 2 lines are the simultaneous pancreas kidney survivals. The topmost is the kidney survival in SPK, and the second one is the kidney, the pancreas survival in SPK, right? So if you see that there's always some difference, even now there's about 10% difference in kidney survival versus a pancreas survival, because there are complications and we still lose about 10% of the pancreas in the perioperative period. But if you see the others, the pancreas alone and the pancreas after kidney transplant, they are much lower. They are almost at half the survival. Although in the recent years the survival has improved, but still it is inferior to having both the organs put together. And even at 5 years, the current survival rates are pretty good. So almost enjoys an 80% survival rate at 5 years. So what have we done at PJ? So I've just put it in 3 eras. We started in 2014. So nearly equal numbers in these years, except the last part was there are a lot of interruption because of COVID, but still we are able to manage almost the same numbers. So if you see DGF was 6 out of 11, like the kidney did not function primarily in the early period, and now it is down to 1 in 11 in a disease donor setting, so which is very good. And if we talk of graft pancreatectomy, so 3 out of 11 in the first era, 2 out of 14 in the second era, and now there is no graft. Last 11 patients, there is no graft pancreatectomy. All pancreas are functioning well, right? We lost 1 patient in the early phase, no mortality in the first 30 days in the last 5 years. The re-exploration rate, 10 out of 11. Almost all patients used to be re-explored, which has now dropped to about 3 still there, but significant drop, and this is probably acceptable as far as the best centers in the world. The hospital stay is still, we are working on it. If the transplant operation is uneventful, the patient is discharged within the 10 to 14 days, right? But we still are having re-exploration, so the patients who get re-explored, they end up in the hospital much longer, causing the mean hospital stay to be a little longer, but I'm sure with experience this will also come down. And the last part of talk is islet allotransplantation, right? So this was about the whole organ. So out of the whole organ, if you see, we only need few milligrams of tissue for the diabetes to get controlled, right? We only need the cells which are the islet cells, right? If we just can infuse those islet cells in the liver, they go there, they harbor there, and they start to produce insulin. And the insulin they produce is enough to get rid of the diabetes in the recipient. So this concept was again came in 1980s, and where they said, why to do all this operation with so much complication rate, and why not to do this allotransplantation? So this has become quite popular now, except for the fact that to get one patient off diabetes, you probably need 2 to 3 pancreas, right? So that is the challenge here. But if you have 2 or 3 pancreas, you've got good preparation of these cells, you can use this as an alternative to pancreas transplantation. But setting up an allotransplant is very expensive as compared to your standard whole organ transplant, where you do not need any extra cost. The same operation theaters, same ICU setting, keeping the patient, but to separate isolate islet cell, you need a culture facility which would be like a zero bacteria facility. So those costs are there. So in our country, so far we don't have any such facility as far as I am aware. So this is the preparation. You see under the microscope, these are the islet cells, and then you make a solution of them and then just infuse them. The standard immunosuppression is given, and definitely advantages are there. There no operation is required, and you just are OPD procedure. It's an OPD procedure, and you probably, if you start having a good culture facility, you probably can from one patient, if you start culturing the cells, then you may be able to use for more than one recipient. But at the moment, it's the other way around, that you need 2 or 3 pancreas to fit into one patient. So surgical complications are still significant in pancreas transplants. Even the best of centers, they still report about 5 to 10% of complication rate leading to graft loss. That's what I showed you in the graph also. That's a 10% difference is only because of surgical complication. Thrombosis is the most common of them. It's a low flow organ. Any damage happening to the organ while during management of the donor or during the retrieval will lead to a thrombosis, right? And other complications are pancreatitis, bleeding, etc. So I think we can skip this slide. So to conclude, I think this is possibly bound to increase, as now I see that more and more centers are emerging. At least there are 4 active centers in the country at the moment. So but we are definitely going to, the activity is going to be restricted to centers with experience, right? And those with have already established disease donor programs. But we definitely need to develop a transplant training program in the country so as to cater to the needs of these patients with type 1 diabetes who at the moment just lose their life in the prime of their age. All of them are in their 30s, 40s, and they just die off. Thank you very much. This is our second patient who got transplanted in 2015. So again, a young person at 21 years or 22 years, he developed diabetes. Because his diabetes was not managed well, he actually did not achieve his normal height also. He didn't, when he came for transplant, he didn't have any facial hairs, right? So all was because of the hormonal changes. So once the pancreas transplant was done, so everything came back, right? His all reproductive function became normal, and now he's still leading a good life. Almost now 8 years after transplant, kidney function is okay. He remains off insulin. In fact, he's employed with our endocrinology department as a assistant for their projects. Thank you very much.
Thank you so much, sir. Thank you for that excellent talk and the excellent path-breaking work which you are doing. I must congratulate you and compliment you to be one of the leaders in the country and pioneering the way forward for many aspiring surgeons like all of us. So if there are any questions, please, you can ask Professor Ashish.
So questions mean that you have been awake.
They are not brain dead.
Thank you, sir, for such a great presentation. And sir, like we are doing here for a transplant coordinator training program. So in pancreas transplant, there is a team of coordinator, or?
So the coordinators remain the same. So that is why, but they have to know everything, right? So as a coordinator, your role is very important, right? Okay. You are the person who is going to inform, okay, this person is there in my hospital, right? Your hospital may have a team of liver transplant, kidney transplant, they will be interested in their own organs. But as a coordinator, you have to know that, okay, pancreas is also possible, right? So please send an alert if this organ is usable to for some other center.
Like main thing is like awareness among the public. Yes, sir. And sir, you told that like pancreas is a low flow organ. What do you mean by, sir?
Low flow means that if you talk in terms of how much is the amount of flow going through any organ, right? So kidney, 1 minute, if I'm not wrong, probably takes about a liter of flow. A liter of blood passes through the kidney. Pancreas is like 100 ml, that's all. So yeah, so there is some stasis. So stasis होने से thrombosis हो जाता है.
Sir, in one like slide you have shown a pancreas, and there are like I think there is a small sutures.
Yeah.
So what is for that, sir?
So that is the reconstruction. So pancreas come with multiple arteries. Is this the slide? Yeah. So it comes with multiple arteries. So there are 2 or 3 arteries in this patient.
So after that it is a low flow organ. After that?
No. It is a low flow in the normal human body. It's a low flow state only.
Okay.
So low flow का बेसिकली अर्थ है जब भी हम किसी ऑर्गन का ट्रांसप्लांट करते हैं तो उसमें ब्लड सप्लाई अच्छी चाहिए होती है, चाहे किडनी हो चाहे जब ब्लड सप्लाई अच्छी होती है तो उसके क्लॉट होने का, थ्रोम्बोसिस होने का चांस बहुत कम होता है. पैंक्रियाज ट्रांसप्लांट इज़ अ लो फ्लो ऑर्गन, तो अगर आपकी टेक्निकली अनास्टमोसिस ज़रा सा भी सब ऑप्टिमल है तो थ्रोम्बोज हो जाएगा और ख़त्म हो जाएगा, ख़राब हो जाएगा, वो निकालना पड़ेगा. दैट्स व्हाट द पॉइंट आई थिंक यू वांट टू नो. सो लो फ्लो मीन्स it is a very strong technical challenge for the surgeon to transplant an organ which is a low flow. Because of stasis, it has a very high chances of thrombosis. That is the reason why pancreas transplant has not been picked up by most of the centers. So this is the reason why complication rates are very high.
Yeah, not only technical, like whenever you take an organ, there is something called an ischemia reperfusion injury. So जब भी कोई organ लेते हो तो उसमें कुछ ब्लड सप्लाई इंटरप्ट होती है, इस्कीमिक डैमेज होता है. सो इस्कीमिक डैमेज विल डैमेज योर एंडोथेलियम, जो ब्लड वेसल की इनर लाइनिंग है. सो दैट गेट्स डैमेज. तो अगर फ्लो ज़्यादा चल रहा है तो उसको कोई फ़र्क नहीं पड़ता, वो डैमेज से आपका ये सिस्टम रिकवर कर लेता है. बट फ्लो कम होएगा तो वहाँ पे थ्रोम्बोसिस बन जाता है.
लाइक हम देखते हैं सर वार्ड में लाइक इन एनी अदर वार्ड्स देयर इज लाइक RBS ऑन before breakfast, after breakfast, before like lunch, after lunch, before dinner, after dinner, and there is a one is a 3 a.m. in early in the morning. So what is the reason 3 a.m.? Because the patient is sleeping and sometimes we are also lazy and then we have to So what is the main reason behind it?
So the reason for 3 a.m. blood sugar is that we want to see. So if you have a morning, you see the morning blood sugar. So sometimes your morning blood sugars are low, 60, right, 50, 60. So it is possible, and so if it is 50 or 60, so or sorry, if the morning sugars are high, so you want to assess why are they high, right? So normally what will happen is that if your morning sugar is 200, you will increase the insulin in the night, right? Okay. But sometimes that morning high sugar can be because of hypoglycemia happening at 3 a.m., right? So you had your meal at 10 p.m. By 3 a.m. your sugar has gone so down, and the body automatically starts to raise the blood sugar. So so उसके लिए you have to reduce your morning. So it's nothing to do with pancreas transplant.
Thank you, sir. Thank you.
Please use the mic.
After pancreas transplantation, they still require insulin. They were insulin dependent. Almost every patient, 11 out of 11, they were insulin dependent.
Independent.
Sorry, I thought it is insulin.
Independent. So that is the term we use, right?
Fine.
That they should stay off insulin, off all drugs. So or now all are insulin free. Yeah, so I mean, so that's a very good question. That normally also when we do kidney transplant, almost 10 to 25% will end up having diabetes, right? So that's a big challenge, especially for our ethnicity. Means that Indian population is very predisposed to developing diabetes after transplantation, and we have to give immunosuppression. There is no second thought about it. Without immunosuppression, so what people have done is that for pancreas transplant, almost all centers in the world, they use just steroid-free immunosuppression. If you don't give steroids, your diabetes rates are very low, less than 5%, or probably 1 or 2% only. No, you only give steroids for the first week, right? So yes, first week only. After that, you don't give any steroids also. So your rates are very low. Unfortunately, we tried that in our center. So the first 3 years, all patients were steroid free. But we landed up with complications, which at that time we thought it's probably, so then we just went to the standard immunosuppression, right? So some part of that was because of having increased rejection, right? So, and this rejection in pancreas is difficult to pick up. So we've just gone back to a standard immunosuppression to have a good cohort. Now we have 11 patients with no complications, all pancreas are working fine. And now we will again plan to switch back to steroid free.
Thank you, sir.
Yes, so if you want a living donor pancreas, so it is possible to do it. The almost majority of the islet cell which produce insulin are there in the tail of pancreas, right? So it is possible to have this organ split here, right? If the organ is split here, right? So one supply is, remains in the donor. This part remains in the donor. This part can come on in the recipient. The challenge with us here is that as a population we are very prone to diabetes, right? So in a very selected patient you can do it. It's not that you cannot do it. I mean, people do it, but we still have yet to come across a patient who has a suitable donor who can be offered this, right? But we are in the talks already. Like we have our mentors are there to help us for this also. So we are ready for this if we have to do it, but we still yet to come across a suitable recipient.
Sir, in case of CA pancreas, transplantation is possible?
CA pancreas normally would end up having all the organ taken out. So that organ is not used. You can use the cell, so you can use an auto transplant of the islet cell. That is possible.
Sir, after the transplant, so what happens to the original organ that the patients have? So
That
patient will have two
keeps-
spleen and two
Yeah, so that
pancreas.
patient is there with the patient. We don't do anything with it.
Okay.
Same as kidneys. So kidneys also, patients 2, 3, 4, number keeps on increasing.
Sir, as we are doing islet cells transplant in the patients, is it somewhat like dialysis to the patients of kidney transplant? Or it is a...
No. It's altogether a different modality of therapy. It's like a stem cell. I don't know how many of you heard of stem cells. So it's a different modality. You give one infusion, then it is cured. The diabetes is cured for the next 5-10 years.
5-10 years.
Yeah.
Why are all the questions coming from this half? Is this half brain dead? No questions from this half, only this half is functional. So any questions from the other half? See, sir is a busy man. They have been busy with the cadaver donations last night also. There have been 3 donations in last 2 days. And sir did a pancreas also. And all the questions pertaining to pancreas only he can answer. Nobody in this hall can answer. So you put all those questions, whatever you have, whatever comes to your mind, please do ask. Hanji.
सर आपने वो एक लाइक स्लाइड दिखाई थी. सॉरी.
Is transplant possible in pancreatic cancer?
I mean, to be used as a donor organ?
As a recipient, can this be done?
Normally, I mean, there are medications to manage, so it's not required most of the times. I mean, once you have a cancer, otherwise also like you have very stringent criteria before you become fit. So it's not a common indication. Pancreas transplant as such has a very poor outcome.
But pancreatic cancer also has a very poor outcome.
Yeah, so if the recipient has a cancer, then their survival rate is otherwise also very low.
Very
so
low.
they don't end up having on the waiting list for transplant. And you cannot use it as a donor organ, clearly.
Sir, in one slide you have shown your data, like hospital stay and number of pancreas. Yes, sir, in this. So in when we see in 2014, 17, 18, 20, 21, 22, So mean creatinine level is I think 22 to 21 to 22. It's like 1.54. It's
high.
beyond the normal.
Yeah, so it's high. So I mean,
Yeah.
it's very
After that, there is like good results. So what is the?
So, I mean, that means that you've been really awake. So that's one odd thing I did not discuss, right? So it has the change, right? So we have this period we were learning, very cautious, use the best donors, still didn't have good outcomes.
Oh.
Second period, we just got established, right? Now we are going beyond, right? So this year we've done almost one pancreas every month. So, and how has it come, right? So it has come from an extended donors, right? So 2 donors in this were less than 5 years of age, right? So if you see, when I showed the criteria, it is between 10 to 50 years of age. So I removed the 10 because we've now started doing as early as 4 years. That's again probably would be the youngest pancreatic donor in the country. So, and if you put a half kidney, one kidney of a 4-year-old child into a 30-year-old person, so your creatinine remains plateau at 2 or 2.5 at the time of discharge. Afterward, it comes down. Maybe it may take 6 months, 1 year, or even 2 years also.
Thank you, sir.
So with that, thank you so much, sir, for this wonderful talk on pancreas transplant, a much less discussed and less known subject. And with that, I would request Sudhir Diwan, sir, to kindly felicitate Professor Ashish on our behalf. Dr. Anna, please join. So after that, we have the next presentation from our pharmacy department. And I would request Dr. Shivani and Ashwini to come over and discuss about the various medications, immunosuppression, and other medicines which we use in patients of transplant. How much is the cost? What are the medications used? How do patients take it? And what are the drug interactions? What is the dosage? So this is also an important aspect of learning of transplantation, because many patients would ask you questions. How much is the expense of medications? Which medicines are used? What is the mechanism of action? So for that, I invite Shivani and Ashwini on the stage.
So thank you so much, sir, for inviting us. The most important part of the in transplant patient, that is medication management in transplant patient. So I would like to invite Dr. Shivani, so sharing their thoughts with you.
So thank you, sir, and I would like to thank the organizing committee to recognize the clinical pharmacology aspect in relation to the transplant patients, because this is one thing which we feel always need an emphasis and is being neglected, and this time with sir's help we are able to bring it forward that the medication management is very important aspect when it's about all the patient, but since this is a special category of patient and we need to have a look into the important aspects of medication management. So I'm a clinical pharmacologist here. I'm heading this department with a team of clinical pharmacists. So my team of clinical pharmacists are going in the areas, they're looking into the prescription appropriateness review, and wherever inputs are required and wherever the help in the medication process is required, the clinical pharmacists are extending their help to the doctors, nurses, everyone in the form of their own expertise. So I'll be just starting with an overview about what is the importance of management of medication in transplant patients, and my clinical pharmacist Ashni will take over the details of the drugs which are given in these transplant patients and what are the important aspects of those drugs which are required to be monitored. With this, I would like to start with what are all important things which are required in management of medication. It is not only one, it's a teamwork. So it starts from pharmacy where the drugs are stored. They are kept as per the required manufacturer recommendations. Then moving on from the storage to prescription, transcription, administration, monitoring, educating the nursing team, educating the patient, that all aspects are being seen by the aspects of pharmacy as well as the pharmacology. Because drugs, they keep on changing their number of things in our body in the form of pharmacokinetics and pharmacodynamic parameters, which need to be seen, precisely. That will only help us to monitor the drug effects, and we can then aim to look into a better patient outcome. So why are we looking at all these aspects? We want to avoid all the errors which are related to the drugs and they are reaching the patient. So they could be related with the drug storage. At times we don't see, okay, oh, this IV fluid is stored and it's kept anywhere and it's being used in the patient. No, every drug, every fluid has a way to be stored so that we can maintain its efficacy. So storage is very, very important, and we need to look at the recommendations given by the manufacturer, and then we have to define those storage conditions and keep on regularly monitoring it. Then the pre and the post-transplant medication errors. So there could be some latencies with respect to the administration of the drug, or the type of the drug, the dose, strength, everything. We need to look into all aspects of the drug. So that starts from prescription. So if the prescription is not appropriate with respect to the components of the drug, there could be any error occurring which will, affect the outcome of the patient. Then regarding the administration, so we have a lot of specifications which differ from drug to drug, but these specifications are not at times taken care of. And when the drug is being prepared before administering, even the diluent is a very important part, and at times what we see, we take it for granted, okay, I have been using this drug, so if another company is giving the same drug, I have to make it in the same way. No, it may be different. So we need to keep ourselves awake when we are going for any new brand or new substitute for any kind of patient, and especially for these vulnerable patients. Then monitoring. Monitoring is very, very important. Once the drug is administered, the drug needs to be monitored precisely from the time given to the next dose we give. Because there are a number of ADRs which are not recognized. So ADRs are basically adverse drug reactions. So what happens is we think, okay, this is a vulnerable patient, or this is a very critical patient, and he's already having a lot of comorbidities. So whatever is happening may be because of the disease. But we try to, sometimes we shift our focus from the drug to only disease. But at times what happens, that particular symptom can be because of the drug. So that is being missed out. So unless we have a sound knowledge of the drug, we are not able to make up that whether it is related with the disease or with the drug. So we need to be, educated or trained, or whenever we are into one same subset of patients and giving that subset of drugs, we need to know that these are the drugs. They can, if we cannot remember all the things, but at least we can remember some important aspects of that drug. And then if something is encountered, we can relate it to the drug also. So that is one important part in monitoring. So what is the medication management helping out? So it is helping us in, managing the patients to get the best outcomes. So that is what we people are doing here in Fortis Hospital, Mohali. So as I said, that critical drugs are involved in transplant patients, so medication management plays a crucial role here. So as I said, it's a teamwork. So it starts from the clinician and goes till the patient. So clinician is writing a prescription wherein all the previous drugs, which is medication reconciliation, are taken care of, because the patient who's coming up for a transplantation might be having another comorbidities, or must be taking treatment for a long term, because it's a the chronic things landing the patient into the transplant. So that needs to be taken care of, and some of the drugs has to be continued further. So then the instructions about the drug are given by the clinician till the follow-up. Now, what is the role by the pharmacy? As I already said, that storage is important, so that starts from pharmacy. So not only the storage, if in a hospital that we know that these subset of patients need these kind of drugs, so there has to be a proper inventory maintained, because at the time of the need, we cannot always run to chase the drugs and find out what is required now and where would we get the drug from. So that is a big role played by pharmacy, wherein availability and storage are the key points to be taken care of. Coming on to the nursing. So whenever I take classes of nurses, I always say you are the advocates of the patient, because everything comes from your side. If the patient has any issues, he may not communicate to the clinician, but he will certainly communicate you, because you are in the close proximity of the patient for a good time. So patient assessments begin from the nursing, followed by medication reconciliation. So reconciliation starts from a clinician when the patient is admitted, but sometimes they are being missed at that point of time. So since the nursing playing a key role always with the patient, and the patient is also in a comfortable zone, so they also like to communicate few things which are being missed out. So reconciliation plays an important role, wherein if something is missed, if the nurse should also take a brief history about the drug from the patient, even if the clinician or the doctor on duty has taken that information from the patient. So that will aid in filling the gaps if any drugs are already there and are being missed. Right? Then after that, the role comes to indenting, then preparation of the drugs, administration of the drug, monitoring, as I already explained you, and patient education. So in this subset of the patient, these patients need to be very well educated about the kind of therapy we are giving, what type of the things they need to monitor, and at times communicate you wherever required. Coming to the role of a clinical pharmacist. So the clinical pharmacist is reviewing the prescription, looking at the drug protocols, aiding, helping, making drug protocols, giving you references, easy references to quote and to look into wherever the administration of the drug is required. After that, what is to be monitored? Because the clinical pharmacists are staying in the areas, they look at the patient creatinine levels, other transaminases level, and other critical parameters which may be affected by the drug. So clinical pharmacist gives a kind of a reference to the nursing or those who are dealing with the patient, what are the parameters which need to be monitored when these particular drugs are given. Then about the drug-drug interactions, drug-food interactions, what all ADRs to be monitored. So these all components of the drug are included in the training and the education which are provided by clinical pharmacists to the area nursing staff who are dealing with this patient. Then comes the patient education. So patient is supposed to be told about the drugs which are to be given at home, what all things are to be monitored. They are not supposed to miss the dose, take the dose rightly. If missed, then communicate to the clinician so that they can achieve good outcomes as we give our efforts in giving those drugs and everything to the patient after the transplant. So with this, I just wanted to emphasize again that medication management is not only a key role by the pharmacist or the clinical pharmacist, it is basically a collaborative effort which starts from the clinician till patient goes with the help of the nursing and the clinical pharmacist. So wherever possible, because the expertise plays a role. If the clinical pharmacist is looking after the drugs, it is his duty to educate the nursing staff also to know about the important critical points of the drugs which they can monitor further. So with this, I'll forward this presentation to the clinical pharmacist. Ashwini is the lead AMS clinical pharmacist who's looking after especially the antibiotic part along with the other drugs, and he's also playing a key role in looking after the transplant patients here. So he'll discuss briefly about the drugs which are given in these transplant patients and what all parameters are need to be monitored and taken care of. So I would like to thank you all again for giving us this opportunity to come here and share our experience. Thank you, sir.
So how many of you are working in the and looking after the transplant patients? So you know, these are the various classification of immunosuppressant that we are using, like T-cell inhibitor, cyclosporin, included tacrolimus, sirolimus, ibrolimus, and azathioprine, and the most important part is the biological drug. So biological drug that we are using, ATG, immunoglobulin, infliximab, adalimumab. So this basically these drugs play an important role to manage the patient, and the recommended doses regimen for I have mentioned, like tacrolimus we are using 0.12 to 0.5 mg per kg per day in divided 12-hour doses, and mycophenolate from 500 to 1 gram BD, and cyclosporin with oral and IV formulation. For oral formulation 15 mg per kg per day, and IV for 5 to 6 mg per kg per day. So here dose is always on weight based. So totally that immunosuppressant dose depend upon the patient weight. Now see, immunosuppressant used in the various transplant patients. So you see the common immunosuppressant that are used in the heart transplant, liver transplant, and kidney transplant. So that's why they are playing an important role to manage the patient with these immunosuppressant. So one more most important fact that I have discussed here is the tacrolimus comes in two doses form. One is the immediate release, that is normal, and one is the extended release. So please take this message that we cannot interchange with the immediate release with the extended release, because the formulation is different from extended release with the immediate release. So monoclonal antibodies, have you handled, किसी ने use किया monoclonal antibody? And you know ये होते क्या है? So monoclonal antibody play an important role in transplant patients. First, to avoid rejection and to boost the immune system of the patients. So thymoglobulin, human albumin, infliximab, vasiliximab used as in to manage the transplant patient pre and post. So when we are going to administer these drugs, these are the high risk drugs and cause the serious adverse event. So how we can prevent these drugs, these ADRs? Basically, before starting the MAVs, we have to pre-medicate the patient with the antipyretic, antihistamine, and corticosteroids. And for administration instruction, you have to, just we cannot push the drug immediately to the patient. There is a protocol to administer the biologicals. First of all, we have to check the patient parameter that it is hydrated, or we have to use a center line with separate port. And before starting any infusion, we have to flush the center line. And after that, always start the infusion with very low rate as per the manufacturer recommendation, and after completing the infusion, you have to flush the line. Otherwise, if we are not following this stuff, then we landed with the patient with the adverse event. So that's why here comes with the definitive protocol for administration and for prescription of the MAPs. So prophylaxis and treatment in transplant patients. So before transplant, we have to start the biological or the immunosuppressant to maintain the blood drugs targeted in the patient's blood. So as a surgical prophylaxis, we are using Programe as per recommendation or as per the clinical condition of the patient, but the time defined for administration of surgical prophylaxis is within 60 minutes. ये नहीं कि ट्रांसप्लांट पेशेंट का शाम को होना और सुबह हम उसको सर्जिकल प्रोफाइलेक्सिस दे दें, बिकॉज अदरवाइज we ended with the infection to the patient, and some of the drug, like if we are using metronidazole, vancomycin, then the infusion should be completed within 30 minutes of starting the incision, and redosing after 4 hours. And if we are using clindamycin, then the redosing time 6 hours. And no redosing time for vanco and metronidazole. Here, redosing time depend upon the drug half-life period. If the half-life period is 2 to 4 hours, then we have to repeat the drug after 4 hours. Otherwise, if the half-life period is extended like 12 hours, 13 hours, then no need to repeat the redosing of the patient. So other than that, we are using immunosuppressant, immunomodulator, and other comorbidities like comorbidic drugs like hypertensive, diabetic, hypothyroidism. And one most important part is some of the drugs are contraindicated to these patients, and these are the nephrotoxic drugs. So why nephrotoxic drugs are contraindicated to these patients, especially for kidney transplant patients? Reason? So always keep in mind when there is a renal transplant patients, please check that either this patient is on any nephrotoxic drug. Otherwise, we will lose the patient or even graft rejections with these drugs. So prophylactic medicines. So have you seen the patient landed with the PCP and CMV virus post-transplant? Have you seen any patient who have CMV and so these are the drugs that used as prophylaxis as well as for treatment. So for prophylaxis, we are using Vangal cyclovir or acyclovir with the 450 to 900 mg once daily dose as a prophylactic. But for treatment, we are using 900 mg BD for 14 to 21 days. And for this sulfamethoxazole or trimethoprim, basically used to prevent the PCP. And the recommended doses are always as a prophylactic is once daily. So now the role of therapeutic drug monitoring. ये therapeutic drug monitoring होती क्या है? And क्यों करते हैं हम? So basically to check the drug level in blood. So based upon that, we have to modify the dose, or so the whole scenario is to basically avoid drug toxicity and to maintain the drug therapeutic levels in patients. So most important thing is if patient is on tacrolimus immediate release, then we have to send the sample within 12 hours of taking last dose of the patient. If patient is on extended release, then we have to repeat the patient sample within 24 hours of the last dose taken by the patients. And reason? Is anybody know the reason? Because जो extended release tablet होती है ना, वो हमारी intestine के अंदर जाके stuck कर जाती है, and from there slowly वो release करती है. So immediately disintegrate and distributed and excreted by the renal. But extended release tablet always stick with the intestine and released by the layers. That's why we are preferred to send the blood sample within 24 hours of for extended release and 12 hours for the immediate release tablet. So these are the common ADRs of immunosuppressant drugs like nephrotoxicity, hypertensive, pancytopenia, thrombocytopenia, secondary infections. So have you seen the lots of list of ADRs with the immunosuppressant drugs? So we cannot prevent every ADR of these drugs, but we can minimize the occurrence of these ADRs. And how we can minimize these ADRs? Like education of patients, monitoring like TAC level, investigation, drug level, monitoring interactions, basically drug-drug interaction, drug-food interactions, and strict follow-up these patients, strictly follow-up of these patients. So coming to next, drug-drug interaction and drug-food interactions. So in immunosuppressant drugs, there are number of drug-drug interaction and drug-food interactions. So, but we can consider only the serious one. So drug-drug interactions are basically some who decrease the level of these drugs like phenantine, carbamazepine, phenobarbital, rifampicin, caspofungin, or proton pump inhibitor for mycophenolate. And some of the drugs that increase these level of these drugs are clarithromycin, azole, like fluconazole, itraconazole, boriconazole, and antidepressant fluoxetine, diltiazem, amiodarone, prednisolone, and PPI for tacrolimus. and pharmacodynamic interaction like aminoglycoside, amphotericin B, NSAID, statin, digoxin, phenantine. Basically, these drugs are either increase the effect of these drugs or inhibit the effect of these drugs, like aminoglycosides. For example, amikacin. If patient is on amikacin, then what we have to monitor with the immunosuppressant? Creatinine of that patient, because both of these drugs interact with each other and increase the action of both drugs, and this leads to nephrotoxicity. And statins, basically immunosuppressant increase the effect of statins, and if the effect of statin increase, then what will happen? Muscle injury और liver toxicity हो सकती है statin से. And the most important part is the drug food interactions, and these drugs interact with the grapefruits like papaya, pomegranates. So whenever patient is on immunosuppressant, we have to instruct the patient that you have to avoid these drugs, because these alter the blood drug level of patients, basically by altering the pH of in gastric media. So now how to avoid these drug interactions? We can not permanently like avoid, but minimize the drug-drug interactions. How we can minimize, like completeness of prescription? Means ki we have to, by clinician, the instruction mentioned on the prescription, appropriate instruction for nursing staff as well as for counseling for patient, and strict monitoring after drug administration. So, see, this is our hospital prescription written by sir. So, have you seen the tacrolimus 2.5 per oral with 10 a.m., 10 p.m., mycophenolate 7 a.m., 7 p.m., and prednisolone with once daily. So, these are the best practices to avoid the drug-drug interactions. And with administration, appropriate assessment and administration. So appropriate assessment is most important part for patient as well for clinician or as well as for nursing staff. So have you seen these, the patient weight, height, comorbidities, drugs, previous drugs, assessment, and the administration part? Have you seen the mycophenolate dose, tacrolimus, and the visolin dose? We cannot combine these doses together, like if tacrolimus 10 बजे दे रहे हैं तो mycophenolate भी 10 बजे दे दो. अगर हम pantoprazole 7 बजे दे रहे हैं तो mycophenolate भी 7 बजे दे दो, because pantoprazole inhibit the absorption of mycophenolate. But this comes over with the gastric resistance mycophenolate dosage form. But we have to keep these things in mind to avoid the drug-drug interaction and drug food interactions. So importance of patient education. So why patient education is important in for immunosuppressant as well as for the other transplant medication. So the success of the transplant organ depend upon the best medication management in anti-rejection medicines. Patient education is mandated to know all their medications. So patient have to knowledge, and it's our responsibility or clinician responsibility to educate the patient regarding their medicine. So even instruct that don't miss the drug doses, don't skip their doses, and don't take any wrong dose. Or if the patient is either missing the doses, then you have to inform their clinician. And most important part is cordial relationship with the patient, upscaling their morale. Thank you.
Hello. So thank you, Shivani and Ashwini, for bringing that important and less talked about aspect of transplantation. Medication management is a very, very important aspect, because slightly lesser dose might lead to rejection, slightly more dose might lead to infections. So just to give you a gist of the presentation, the kind of medications which we use for transplant patients is divided into 3 parts. So one is called as the induction immunosuppression. The other is called as the intraoperative immunosuppression. And third part is the maintenance immunosuppression. सो इंडक्शन का अर्थ होता है जब किसी ऑर्गन को हम ट्रांसप्लांट कर रहे हैं तो उससे पहले जो दवाइयाँ उसको देते हैं ताकि वो ऑर्गन की रिजेक्शन ना हो, उन मेडिकेशंस को इंडक्शन इम्यूनोसप्रेशन कहते हैं। जो हम ऑपरेशन के दौरान थोड़ा सा हाई डोज में दवाइयाँ देते हैं जब किसी भी ऑर्गन का ट्रांसप्लांट करते हैं, तो जब ब्लड फ्लो उसमें होता है, रिसिपिएंट का ब्लड उस ऑर्गन के अंदर दौड़ने लगता है, तो रिसिपिएंट के अंदर ब्लड सेल्स में जो इम्यून एंटीबॉडीज़ होती हैं, इम्यून सेल्स होते हैं, उस ऑर्गन को नुकसान न पहुंचाएं, उसके लिए इमिडिएटली वी गिव समथिंग विच इज़ कॉल्ड एज इंट्रा ऑपरेटिव इम्यूनोसप्रेशन। एंड द थर्ड इज़ पोस्ट ऑपरेटिव या मेंटेनेंस इम्यूनोसप्रेशन, जिस डोज पे मरीज ज़िंदगी भर रहता है। तो ये 3 तरह के इम्यूनोसप्रेशन होते हैं। जो इंडक्शन इम्यूनोसप्रेशन होता है वो उन मरीज़ों में दिया जाता है जो थोड़ा सा हाई रिस्क होते हैं या फिर ऐसा लगता है कि जिनमें रिजेक्शन का चांस हाई है। There are 2 drugs used for induction immunosuppression. One is a thymoglobulin, which he had shown, and the other is called as basiliximab. It comes by the name of Simulect. So these are the 2 important induction immunosuppression medication which you should remember. The intraoperative immunosuppression is given in the form of high dose steroids, pulse steroids. तो जैसे ही सर्जन्स क्लैंप खोलते हैं, किसी भी ऑर्गन को रीपरफ्यूज करते हैं, उससे पहले एक बहुत हाई डोज ऑफ pulse methyl prednisolone दी जाती है. So that works against the cellular rejection. So that prevents cellular rejection in that organ to happen. And after that, the aim is to prevent the antibodies to form inside somebody's body so that this organ is not rejected. So the commonly used protocol for maintenance immunosuppression is known as the triple drug immunosuppression. You must know what are the 3 drugs. The classical triple drug immunosuppression includes number 1 tacrolimus. The broad category is CNIs. So it is CNI tacrolimus. Number 2 is mycophenolate, which is an anti-proliferative agent, and number 3 is prednisolone or visolone on minimal doses. So this cocktail of 3 drugs has proved to have the best outcomes in organ transplantation, especially kidney transplantation. After 2005, these are the 3 drugs which are used, and most of the patients would be on these 3 drugs until unless there is some adverse reaction happening or something else is happening. So apart from these 3 drugs in a typical transplant prescription, you will see these medicines are given to prevent rejection. So once we want to prevent rejection, we lower the immunity of the person. Once somebody immunity is lowered, then he is prone for infections. So that is why we need to give some prophylaxis. So two medications are used for prophylaxis. One is for bacterial pneumonia, which is called as pneumocystis jirovecii pneumonia, which is very common after the transplant patients, for which we give a medication called as Septran. It is cotrimoxazole. The other medication is given for prevention of cytomegalovirus, which comes by the name of valganciclovir or ganciclovir. These are the 2 common medications which are given oral, and a third topical agent is used, which is called as a candid mouth paint or clotrimazole application in the mouth, because these patients are prone for oral infections, candidiasis, fungal infections. So a typical transplant prescription will carry these medications. If somebody has some other problems such as hypertension or diabetes, the other medications can be continued, but primarily a typical transplant patient is on these 3 triple drug immunosuppression, 1 antacid, and one of these, all of these prophylaxis agents. This is a typical prescription for a transplant patient. The typical cost for a 60 kg person with an average built and average immunological history, in the first 6 months, the cost of medication is close to 15,000 a month. As time passes by, many prophylaxis agents are removed and the patient is only on basic immunosuppressive medication. So as the time after the transplant increases, the dose of the immunosuppression decreases. So the cost also comes down. So a patient who has spent, say, 10 years after the transplant hardly has a expense of around, say, 3,000, 4,000 over these medicines. Okay? So if there are any questions, you can let me know. Mic de do, please.
So thank you, ma'am, and thank you, sir, for this great presentation. And usually, pharma is like my out of the like top of
Out of the head.
Yeah.
Most
Even for
boring.
us. Even for us.
But
Exactly, and they are so that is why जहाँ हमें परेशानी होती है हम इनको कह देते हैं आप पढ़ के हमें बता दो जो डोज में कहोगे वो लिख देंगे.
तो आप सिंपल सा बता दो को इवैल्यूएशन में आ रखा है क्वेश्चन हमारे लाइक कि इम्यूनो सप्रेसेंट अगर इफ एनी लाइक पेशेंट और रिलेटिव आस्क कि ये जो इम्यूनो सप्रेसेंट्स जो हैं वो लाइफ लॉन्ग चलेंगे आफ्टर सम टाइम्स ट्रांसप्लांट के बाद बंद हो जाएंगे तो हम क्या कहेंगे उनको?
बस सर
लाइफ लॉन्ग.
थैंक यू.
लाइफ लॉन्ग डिपेंड. देखो हर जो ट्रांसप्लांट में इम्यूनोसप्रेशन है ना ये डिपेंड करता है इंडिविजुअल रिस्क असेसमेंट बिटवीन अ स्पेसिफिक पेयर ऑफ अ डोनर एंड रिसिपिएंट. फॉर एग्जांपल अगर दो सगे भाई हैं जो कि HLA आइडेंटिकल ट्विंस हैं जिनका 6x6 मैच है इसमें किसी इम्यूनोसप्रेशन की ज़रूरत नहीं है. उसमें दवा की ज़रूरत है ही नहीं क्योंकि वो 100% मैच है. विस कोई सेंसिटाइज पेशेंट है जिसका सेकंड ट्रांसप्लांट है ABO इनकम्पैटिबल ट्रांसप्लांट है तो हम थोड़ी हाई डोज लेके चलेंगे. विस कोई पार्शियल मैच है बाप बेटे हैं भाई बहन हैं जिनका पूरा मैच नहीं है पार्शियल मैच है तो इंटरमीडिएट डोज है. सो अ लॉट डिपेंड्स अपॉन द इम्यूनोसप्रेशन की डोजेज एंड लेंथ डिपेंड्स अपॉन व्हाट हैज़ बीन द ट्रांसप्लांट हिस्ट्री ऑफ दैट पेशेंट. जो मरीज़ अच्छे फॉलोअप में रहता है सपोज 10 साल तक कोई हमारे अच्छे फॉलोअप में है हम धीरे धीरे उसकी मेडिसिन टेपर करते चले आएंगे ओवर द ईयर्स. एंड हो सकता है कई पेशेंट्स ऐसे भी हैं जो कि बहुत ही मिनिमल डोज पे आ जाते हैं 1/10 डोज पे आ जाते हैं आफ्टर 10-15 ईयर्स. सो ये कहना भी शायद पूरी तरह से गलत होगा कि हम पूरी ज़िंदगी दवा खानी पड़ेगी. हो सकता है कि बहुत कम दवा खानी पड़े कई पेशेंट्स में बंद भी हो जाती है. But most of the patients will carry some minuscule dose of immunosuppression over the years. Again, it depends upon उसकी हिस्ट्री कैसी है. अगर वो 10 साल तक ट्रांसप्लांट में हमारे पास फॉलोअप में है तो उसको कितनी बार रिजेक्शन हुआ कभी खून चढ़ा कि नहीं चढ़ा कोई और सेंसिटाइजेशन इवेंट तो नहीं हुआ इन्फेक्शन तो नहीं हुआ किसी पेशेंट में इन्फेक्शन ज़्यादा होता है उसकी डोज कम कर देते हैं. सो दे आर सो मैनी इफ्स एंड बट्स ऑन विच वी डिसाइड द ऑप्टिमल डोसेज ऑफ immunosuppression. Yeah, so tacrolimus is one medication which is seen to be very effective at a certain level, and these levels are described in different phases of transplant in different immunological risk categories of transplant. So शुरू में जैसे अगर liver transplant है या kidney transplant है kidney is a थोड़ा antigenic organ, so we need a little higher tacrolimus level. A typical tacrolimus level with experience would पहले हम लोग टेक्रोलिमस लेवल बुक्स से चलते थे कि 10-12 रखते थे बट ग्रेजुअली इन माय प्रैक्टिस आई रियलाइज्ड कि इंडिया में इन्फेक्शंस होने लगते हैं टेक्रोलिमस की टॉक्सिसिटी होती है टेक्रोलिमस से डायबिटीज़ होती है मेटाबॉलिक डिस्टर्बेंसेस होते हैं. टेक्रोलिमस इटसेल्फ इज़ अ नेफ्रोटॉक्सिक मेडिकेशन. टेक्रोलिमस कुछ सालों में धीरे धीरे किडनी को ख़राब करने लगती है न्यूरोलॉजिकल टॉक्सिसिटी होती है. सो टेक्रोलिमस को थोड़ा थोड़ा टेपर करते करते अब धीरे धीरे हम लोग को पता चल गया कि लगभग ये लेवल पेशेंट के लिए ठीक है. So these levels are arbitrary and they depend upon the geographical population you are catering to, the kind of immunological risk history the patient and the recipient have. So a typical level, if you ask me a certain level, so maybe first 6 months after the transplant in an average risk patient, it should be somewhere between say 6 to 8, 9. And then after 6 months, it should be 5 to 7. After 1 year, it should be 6. So it goes on decreasing as the time passes by.
So every drug has a therapeutic range. So the concept of therapeutic drug monitoring comes with these kind of drugs wherein we need to maintain a level to achieve the therapeutic outcomes, just as the sir has mentioned. So what happens is that some regular intervals are defined wherein we look at the levels. So there is a window or a range wherein if the dose is less than what is required, will not produce the therapeutic effect. But if it is above the range, then it will come up in the form of adverse drug reactions. So ADRs are basically the therapeutic extension of the drug. So when the dose which is required is not there and we are giving more dose, it will come as a ADR. So we need to maintain that level within the therapeutic range. So that is why we need therapeutic drug monitoring. So there is a specific time interval defined. Maybe sir can tell you what is the frequency here. They mentioned for the patient that you need to get your monitoring or the blood levels done after 2 months or 3 months. So therein, when we look at the levels, then we decide the dose. I hope, sir, you agree with me. The dose is decided basis the therapeutic drug monitoring. That is, the level of the blood, level of the drugs in the blood are checked, and we see if it falls in the therapeutic range, then we do not need to alter it. If it is not, then we might have to increase or decrease the dose. So that's basically the crux of deciding the dose of the drug.
And there's a lot of inter-patient as well as intra-patient variability. जो ये ड्रग लेवल्स होते हैं ये डिपेंड करते हैं कि लिवर की मेटाबॉलिज्म कैसे है. जो ड्रग की मेटाबॉलिज्म हो रही है, जो भी दवाइयाँ हम खाते हैं वो लिवर में मेटाबोलाइज होती हैं. सो जब भी ये लिवर की मेटाबॉलिक स्टेट भी डिफरेंट होती है. हो सकता है 6 महीने पहले कुछ दूसरी हो, अब कुछ दूसरी हो. So some people are fast metabolizers of a drug, some people are slow metabolizers of the drug. That again depends on the condition of the liver. So कई दफ़े ये ड्रग लेवल्स जो होते हैं बड़ी रैपिडली चेंज होते हैं. कई पेशेंट छोटे कम लेवल पे ही टॉक्सिसिटी प्रोड्यूस करने लगते हैं, कई पेशेंट बहुत हाई लेवल पे भी रिजेक्शन हो जाता है. सो अगेन इट वेरीज फ्रॉम केस टू केस एंड I think rather than defining a level, it differs from patient to patient, because many patients would display a toxicity, severe tacrolimus toxicity at a level of 3. They will have tremors, neurological toxicity. Many patients would tolerate a level of 15, 20, 30. So there is a lot of intra-patient variability. Same patient में अलग-अलग समय, अलग-अलग levels हो सकते हैं, and inter-patient variability. दो मरीजों में अलग-अलग variability भी हो सकती है. So it is a very It can only be achieved after a consistent and a very precise monitoring, therapeutic drug monitoring, as Shivani already said. Yes, Bete. Right half is the functional half. Nobody from the left half is coming up with any questions. Tomorrow you exchange your places. All of you sit on that side.
Drug doses will be adjusted on the basis of creatinine clearance too.
Yes, maybe a few drugs.
Not all, but few drugs. Like those drugs are nephrotoxins. They are dosed based upon the creatinine clearance.
So many drugs are excreted by the kidney. Many drugs are excreted by the liver. So creatinine clearance is primarily used for those medicines which are excreted through the kidneys. There are many drugs which are metabolized in liver. In those patients, creatinine clearance doesn't matter.
There are so many medications we have listed down: 2 immunosuppressants, corticosteroids, 2 antivirals. How to give them? Like you said, tacrolimus and this MMF can't be given at the same time.
We have to differentiate with the timing. I have shown you that like अगर patient tacrolimus ले रहा है तो 10 AM 10 PM the best time. So before 1 hour and after 1 hour patient को कुछ नहीं देना है. And for mycophenolate, early morning 7 AM and pantoprazole before 7 AM, because we have to make a gap of 1 hour.
ऐसा क्यों? 10 बजे क्यों लेनी होती दवाई?
So reason कि अगर
MMF is given 7 AM.
जो माइकोफेनोलेट की एब्जॉर्प्शन होती है वो खाने के साथ अच्छी होती है.
That is what I was asking. कि I was simply asking if a patient comes in emergency with all these drugs, so we act as a patient advocate. So if patient is not taking these medications on time, we can alter check and we can say them. So that is why I'm asking which drugs can be given empty stomach at the night, like
बेटा जब
statins are
इमरजेंसी
given.
होती है तो इन दवाओं से बहुत दूर जा चुका होता है मरीज. जब इमरजेंसी होती है ट्रांसप्लांट वाले पेशेंट में तो दवाएं सेकेंडरी हो जाती, पहले उसकी जान बचाना बड़ा इंपॉर्टेंट हो जाता है.
Apart from transplant, patient has transplant before years and now patient comes with some other problem. In general, I am asking if you are studying about drugs. Thank you, ma'am.
नो. खुल के पियो, खुल के जियो. If it's a kidney transplant and the patient is anuric or oliguric, then yes. If the patient is if the patient doesn't have oliguria or anuria, then whatever he wants, kidney is clearing water, then he can take whatever fluid he wants. Nothing important. या जो किडनी फेलियर होता है ये दो प्रकार का होता है. सुबह डॉक्टर एना ने बताया था, वन इज़ एन ऑलिग्यूरिक किडनी फेलियर जिसमें कि पानी का क्लियरेंस तो होता रहता है, यूरिन आता रहता है मरीज़ को, लेकिन क्रेटिनिन बढ़ता जाता है. दूसरा किडनी फेलियर होता है जो कि एनयूरिक होता है, जिसमें यूरिन आने की मात्रा कम हो जाती है. जब यूरिन बाहर निकल नहीं रहा है, फ्लूइड निकल नहीं रहा है, तब हमें फ्लूइड रिस्ट्रिक्ट करना पड़ता है या उतना ही फ्लूइड डायलिसिस में निकाल देना पड़ता है. अगर मरीज़ ने 1-1.5 लीटर पिया है पानी तो डायलिसिस में 1.5 लीटर फ्लूइड निकाल देना होता है. So fluid restriction again depends upon the kind of urine output the patient is having. मेरे सवाल का जवाब नहीं दिया किसी ने. 10 बजे क्यों खाते हैं टेक्रोलिमस दवाई? 10:01 पे खा लिया तो क्या होगा? 10 बजे क्यों खाते हैं? चलो भाई हमारे स्टाफ में से कोई बता दो. परवीन, शशि, रीना, why do you take that medication at 10 o'clock? नहीं, अश्विनी नहीं बताएगा. कौन बताएगा 10 बजे टेक्रोलिमस क्यों खाते हैं? इट्स अ वेरी सिंपल क्वेश्चन. सूरज के साथ रिलेशन है? तो रिमेंबर 10 क्यों 9 बजे कर लें, 9 बजे खा लें. यही पूछ रहा हूँ कि 10 बजे का टाइम क्यों इतना प्रचलित है. वंडरफुल, वंडरफुल. टैक लेवल के लिए, उसके लिए भी 9 बजे टैक लेवल नहीं कर सकते, 8 बजे नहीं कर सकते, कर सकते हैं? Yes, this is the reason. So the reason behind taking 10 o'clock, it is convenient for the patient and for the treating clinician. जब मरीज़ 10 बजे लेता है तो उसका जो टैक लेवल का टेस्ट होता है वो ट्रफ लेवल टेस्ट करते हैं. जब ब्लड में सबसे कम लेवल है उसका, तो उसकी जब नेक्स्ट डोज ड्यू है उससे पहले हमें लेवल टेस्ट करना है. तो अगर 10 बजे मरीज़ दवा लेता है तो 9:45 बजे उसको टेस्ट कराना है. और जब मरीज़ 9:45 बजे टेस्ट कराता है तो 11-12 बजे ओपीडी में डॉक्टर के पास आ जाता है और दिखा के चला जाता है. इसके अलावा कोई भी टाइम रखेंगे तो या तो उसकी रिपोर्ट नहीं आएगी, या सुबह लैब नहीं खुली होगी, या डॉक्टर साहब उठ के चले जाएंगे. सो दिस इज़ द रीज़न वी प्रिस्क्राइब टेक्रोलिमस एट 10 o'clock. नो अदर रीज़न. क्या कह रही प्रवीण? जोर से बोलो, स्पीक लाउडली. तो ये साइंटिफिक ही है, ये अनसाइंटिफिक है. इज दिस अनसाइंटिफिक? दिस इज साइंटिफिक. See, don't think science is only with the books. Science begins once you complete your books and once you face the reality. There is the science. Anyway, thank you so much, Shivani and Ashwini. Yes.
Sir, what are immunomodulators and what is the difference between immunosuppressant or modulators?
Ashwini, आप बताएंगे कि मैं बताऊं? बताओ. So, immunosuppression means we want to suppress the immunity. We want to prevent rejection. That is called as immunosuppression. Immunomodulator need not be an immunosuppressant. Immunomodulator are those medications which are goal directed to modulate the immunity for a specific problem. किसी को अगर एलर्जिक रिएक्शन हो रहा है या किसी और बीमारी के लिए अगर हमें इम्यूनिटी मॉड्यूलेट करनी है, मॉड्यूलेट का मतलब होता है नॉट सप्रेशन. So modulation could be enhancement of the immunity also. So modulation does not mean suppressing the immunity. It could go either way.
Thank you, ma'am. Thank you, sir.
Immunotherapy involves immunomodulators. Excellent. Yes, because see, tacrolimus is a medication. All these immunosuppressive medications have long-term side effects in the form of sarcopenia, in the form of osteoporosis, in the form of muscle weakness. So that is why we encourage these patients to adopt a very healthy lifestyle. They are advised to have weight-bearing exercises. We advise them for regularly participating in the gym so that once they are doing muscle strengthening exercises, osteoporosis automatically is taken care of. We regularly do the DEXA scans to monitor how is the bone density of the patient. If the patient's bones are going weak, is developing osteopenia or osteoporosis, then such patients are prescribed on calcium supplements or maybe vitamin D. So these are all side effects of immunosuppressive medications. We have a book about post-transplant management. Maybe we should be able to give them on the last day of the meeting. So probably you will get how to live healthy after a kidney transplant. So there's a book in which we have put down all these points. So these will answer all your queries. Yes, ma'am. So we stop mycophenolate. So there are many women, we have a pregnancy clinic at our hospital. There are many women who give birth, who conceive and have successful pregnancies after a transplant. There is only one change made. If there's any antihypertensive which is fetotoxic, that is removed, and mycophenolate is switched over to azathioprine. So we have to stop this anti-proliferative agent because this leads to fetal malformations. That is the only change we have. That's a very, very super specialized, super intelligent question. Anything else? So with that, I would like to request Sujata, please do the honors and felicitate our clinical pharmacists. They have been doing really great work behind the curtains and handling all our drug-related queries all the time. Praveen, photo ले लो आगे आके लो. Thank you, thank you. Okay. Okay. So shall we break for tea right now? Or we can have a next session in 10 minutes. We can quickly finish off post-transplant.
The faculty is ready. Faculty is here.
Navdeep is already here.
Okay, that is challenging case study. Should we do it?
Okay, so let's break for tea and then we come back again. Okay? Okay, so we'll break for tea for 10 minutes, 15 minutes, and then come back for other sessions. Okay? ठीक है नवदीप? So immediate post-transplant management is one of the most important key areas. Many a times what happens that we are doing a swap transplant, 2 transplants, 3 transplants in a day. So we just keep on operating and sending the patients to ICU. And there, if the clinical nurse specialist is not geared enough to know how to take the acute care of the patient, because many a times the patient is pouring out 1 liter, 1400, 1500, 1700 of ml of urine every hour. So in that period, the acute care is very, very important. So I have with me Kritika. Kritika is our ICU nurse who manages the transplant ICU. So she will just take you through the journey of a post-kidney transplant patient the moment he is received in the ICU. So it's a very practical presentation. It's a very day-to-day work presentation. So it just shows you the kind of care we give our patients to till the time they are discharged, once after the surgery. So with that, I invite Kritika for the talk.
A very good afternoon to everyone. Myself Kritika from Renal Transplant ICU. Today I am going to present a small presentation about care of the kidney transplant recipient. So start with the after the search. So after the surgery, kidney transplant recipient will be transferred to the intensive care unit from the OT to the prior observation and a brief observation. So first, the principle of the transplant management ICU, to start with the airway status. If the patient is intubated, if the patient is extubated, to clear the airway of the patient, to maintain the clear airway of the patient, and to maintain the saturation of the patient. Next is volume hemodynamic status. In volume hemodynamic status, arterial blood pressure should be maintained, manual blood pressure should be maintained, pulse rate, patient is in sinal tachycardia, sinal rhythm, AF, VF, or etc. Arterial trace, pulse volume variation, OT intake output balance, and blood transfusion. So next is check all lines. Patient having a arterial line, HT line, CVC line, RRT, and drain. Arterial line should be connected before the OT shifting, and after the OT shifting, dialysis line and central line should be cleared, IV fluid should be connected, RT should be in a accurate position, drain should be not kinked, it should be in an accurate position. Assess of new kidney. After the patient receiving from OT, urine speed of a trickling. Urine speed of trickling means urine should be in a draw form, in a drizzling form, or in a thin lane. Urine volume amount. Urine volume amount should be maintained every hourly, and it should be intake on every hourly. Color of urine. Urine color should be cleared, or it should be hematuria. Then how does a transplant ICU specialist nurse handle a KTP patient? Most of the patient is on non-ventilator, only 10% patient is on a ventilator. Then start with the initial or first hand care. So either patient on oxygen or a ventilator, firstly assess the vital sign of the patient. Blood sugar monitoring, as a protocol, blood sugar monitoring is 1 hourly on infusion and otherwise second hourly. Strictly intake output monitoring. IV fluid 100% replacement, and in IV fluid maintenance of electrolyte balance is a first priority. Blood investigation to be sent. In blood investigation, we send the hemoglobin, creatinine, sodium, potassium. Then ABG second hourly if patient is on ventilator. Keep patient in supine position for 6 hours. Anyone know why we put the patient in 6 hours for supine position? Anyone know? We put the patient in supine position for 6 hours to prevent the bleeding. Check the catheter pulled or blocked. Check the drain color and amount. If drain color is more, then inform the surgeon immediately. Renal Doppler is optional. Then on POD first, we routine blood investigation. In routine blood investigation, we send the CBC, creatinine, sodium, potassium. If patient is extubated, to plan for, if patient is intubated, to plan for extubation and start the weaning. And check bowel sound. Before giving anything to the patient, to check the bowel sound should be present. RBS fortali, ambulation is important for patient, spirometry and stimulation. Spirometry and stimulation for important for patient to maintain the breathing airway and to improve the breathing airway. Thyminoglobulin inductions. On POD second, TAC level monitoring. Ashwani sir already told you and Dr. Shivani already told you that TAC level is important because it should be given according to the weight of the patient. That's why we, on second day, we will go for TAC level. Electrolyte supplementation. Electrolyte supplementation is important because heavy urine output, it imbalance the sodium, potassium, etc. So, allow soft diet, change of surgical side dressing, diuresis management according to urine, patient urine output. On POD third and POD fourth, change of blood sugar monitoring. If patient is diabetic, to check the RBS premiums. If patient is non-diabetic, to stop the blood sugar monitoring. Plan of removal of drain, allow full diet, remanagement of IV fluids, renal graft, transplant Doppler to check the functioning of the kidney. Diuresis management according to urine output, change of surgical side dressing if soaked. On POD fifth, removal of drain according to amount of drain. If drain amount is less than 50 ml in 24 hours, then we will remove the drain. Fall is removed, replacement, repeat serum electrolyte, calcium, magnesium, all the electrolytes. All injectables stopped and it will convert into a tablet form. On POD 6th, IV fluid stopped, CVC line removed, drain removal side dressing changed if it is soakaged or soiled. Then on a day of 6th, home care education should be done to the patients. Now we will start with the long-term care. Immunosuppressive drug to be taken a fixed schedule to prevent the further complication. Complication result rejection. Dr. Shivani Juneja and Mr. Ashwani sir already told you that it will take on a at fixed time. Follow up with blood reports twice a week for first 1 month, once a week for second month, and after that it depends on the patient condition according to the surgeon, according to the nephrologist. Maintaining isolation at home. Isolation is important for after the kidney transplant. For starting 3 months, isolation is most important. Drinking plenty of fluids. Plenty of fluids क्यों ज़्यादा patient के लिए necessary होते हैं, क्यों important होते हैं? Kidney की proper functioning के लिए. Maintain proper hygiene and keep surrounding hygienic. Maintain healthy lifestyle. So be aware, be alert, protect your kidney and yourself. So thank you so much, guys. At last, I have a small word for Dr. Ranjan. So you are a great surgeon. You are doing an excellent work. I hope in next coming years you will rock, and I am glad to work as your team member. Thank you so much, sir.
Stay there, don't run. Hello. So first of all, thank you for that excellent talk, and many thanks again, because she has been working day and night for the past 5 days. Our transplant ICU is full, and she has been working in night duty, and then also she took up the challenge of presenting. So I must appreciate that step. That's a very big step.
Thank you, sir.
So I really appreciate her courage and the strength to make a presentation, and she's one of our most new entry nurses. She's not a very senior nurse. So to take up this challenge, I must congratulate you and compliment you, and the kind of confidence you have showed, I'm sure you are going to go a long way. Okay? So what Kritika told about the immediate post-op care, I think she has summed up everything very well. More important is that as soon as we operate a patient and the patient is shifted in the ICU, the first 6 hours are very critical, extremely critical. So extremely critical because kidney is a very, very vascular organ which works on perfusion pressure. So if the kidney doesn't get any transplanted organ, whichever is metabolically active, so if that doesn't get an adequate perfusion pressure in the right amount of time, then that kidney will go into ATN. ATN is acute tubular necrosis, or the graft will slow down its functioning. So maintenance of patient's initial hemodynamic status for the first 6 hours is very, very important. And for that, there's a target of 100, which was told yesterday, that the mean blood pressure should be around 100. The pulse rate should be less than 100. And the patient should be adequately diuresing. The urine output should be more than 100 ml per hour at least. Usually these patients are in actively diuresing state. They produce urine which is approximately 1 liter every hour. So the replacement has to be really quick with the right kind of fluid. It is very important in renal failure patients which kind of fluid you are replacing. So all those things are taken care of the ICU staff, and I said many a times we are doing back-to-back transplant, robotic transplant, swap transplant. So these are the people who manage in the ICU, and they know the danger signs, when to alert the surgeon, when is the drain output more, when is the blood pressure dripping, how is the saturation of the patient. So there are so many things which can go wrong. So managing the acute care immediately post-transplant is one of the most challenging and exciting areas of transplantation. So if there are any questions, you can put across to Kritika, or I may answer them. Mic दे दो.
Transplant care. So sir, I have one question.
Kindly keep the mic up. Yeah.
So what is the classical sign of graft rejection?
So graft rejection, usually that doesn't occur in the immediate post-op period, number one. Because now our immunological techniques are very, very advanced. We can do a cytotoxicity, ADCC, cytotoxicity cross-match, which is called as the CDC cross-match immediately before the transplant. So in my experience of over, say, 1,200-1,300 transplant, I am yet to see a hyperacute rejection. Number two, the rejection most of the times occurs on day 2, day 3, day 4, day 7. So the rejection is of two types. One is a cellular rejection, the other is an antibody-mediated rejection. The cellular rejection is the most common type of rejection, to prevent which we give the intraoperative steroids, as I dwelled in the last lecture. The signs of rejection are, whenever there is rejection, there is some fall in the urine output. So a patient who is actively pouring out urine, all of a sudden starts decreasing the urine. So somebody is putting out, say, 500 ml of urine every hour, the urine suddenly drops to 200 ml, 100 ml, 50 ml, 30 ml. So number one is urine output monitoring. Number two is the serum creatinine is monitored very, very vigorously in these patients. Every 6 hourly or 8 hourly, we do a serum creatinine. So as soon as the patient reaches another serum creatinine level, say creatinine was initially 9 at the time of transplant, it comes down to, say, 5, 4, 3, 2.1, and then it starts rising again, 2.3, 2.4. So either there is an insult to the hemodynamics of the patient, so either the volume replacement has not been adequate, or we are giving some nephrotoxic drug, or there is a rejection happening. So a rejection classically happens on day 3 or day 4. If it is antibody-mediated rejection, usually it occurs on day 7 to 10, or maybe after discharge. So there are no telltale signs of rejection. It is only high index of clinical suspicion. The other important sign to notice is the color of the urine. As she rightly pointed out, the color of the urine is very important, and by looking at the urobag every day 100 times, we know what color of urine is healthy. So if the color of urine is getting concentrated, it's getting dusky, even they can point out, sir, this color, my ICU nurses would tell me, sir, the color of the urine is healthy or not healthy. So this is a very important sign to observe and interpret. So once the rejection is occurring, the urine is full of sediments, it becomes a little duskier, it doesn't appear as healthy as it is. So apart from that, there is no other sign of rejection. It has to be a very high index of clinical suspicion. You should do a Doppler, which will show a increased resistive index inside the kidney. Immediately do a biopsy.
So sir, if like a patient has fever, then what can we think?
Fever is usually not a sign of rejection. Okay. Fever is usually a sign of infection. Okay. And fever in the immediate post-operative period is not that important, because fever could be drug-related fever. Surgery mein there are so many medications which are given. So fever is only important when, number one, it is recurring, it is coming again and again. Number two, it is accompanied by other signs of sepsis. So which might include leukocytosis, which might include neutrophilia, which might include a raised elevated CRP, which might include the clinical setting of a patient who has multiple histories of infection prior to the transplant. So isolated fever is not important.
Thank you, sir.
Okay, so we go ahead and conclude with this session. Thank you so much, Kritika, and I would request Sujata to kindly felicitate. Come here, why are you running away? There is no duty. You have ran away twice. Are you in a hurry? Your boss is calling you in the ICU. एक फोटोग्राफ तो ले लो. So with that, we go on to the next session. We have Navdeep with us. You met Navdeep yesterday? One of the most prolific youngsters in PGI who is making things happen in PGI in the field of deceased organ transplantation. So we would be discussing some challenging case studies. There was a session which was ethics in organ transplantation, which was put in the schedule. That has been rescheduled on the final day, day after tomorrow. So today we would be discussing some of the challenging case studies which these people face as transplant coordinators in the field when they are convincing the families or trying to convert the families for organ donation. So with that, all of you know Navdeep by now. Yesterday he had an excellent session. And with that, I request Navdeep to please start his talk.
Good afternoon, everyone. So starting with some of the challenges we face as the transplant coordinators in PGI. So when we started this, when we were appointed as the transplant coordinator in the PGI, every case brings a lot of challenges. Things were not so streamlined. There were only one coordinator, and the cases were only 5 to 6 cases per year. So when we joined the number, due to the settle of the ROTO and NOTO and the various and the interest in the transplant, the cases suddenly increased. So there were a lot of challenges we faced at that time. Like we were initially, we were even not have any room to consult the patient. We used to consult the patient in the doctor's duty room or the nursing room or in the ICUs only. So then and even we were not having any sporting. Even we were not having any sporting staff. I remembered when me and Rajinder used to collect the sample of the patient. We visited various labs to get the sample done, and then we again rushed to the labs to collect the reports of that sample. So these were the various challenges that we faced. But luckily, we were able to convert some of the patients, and we were able to overcome all these challenges. So there can be various challenges related to the family of the patient. Some medical or the institutional challenges, then some social issues which are related with the organ donation, and some legal aspects related to the organ donation or organ retrieval. First is with family, as we also discussed yesterday, non-acceptance of patient condition. That family is never going to understand that their patient is brain dead. They will say, how you can say it's a patient is dead because heart is still beating, the body is still warm. So all these issues always remain with the family. They are not going to accept the patient as brain dead. Second is refusal from family. Maybe family may have given consent after first committee or the second committee, and at any time they can withdraw their consent and they can refuse for organ donation. And we have to accept that feelings or the decision of the family, and we abandon all the efforts related to transplant. Then decision maker not present in the hospital, as in North India or as per our culture, most of the time it's the male persons who attend the who are present with the patient in the hospital. Most of the time females are not there, but we are very particular in case of taking consent from a married person. Then we must need a consent from the wife of the patient if there is any male patient in the hospital, and most of the time they will not be available in the hospital. So for that we use telephonic consent or the video conference to take consent from the relatives if they are not available in the hospital. Second is family divided over the decision to donate organs. It's always there. Some of the family member will say yes and others will refuse for the donation. Then family thinks organs are given to wealthy person. It's again a big hurdle that as per the law we can't disclose the identity of recipients to the family member. So they always think like that, that they are not, sometimes they don't give consent. They ask where our organs are going to used. We want to meet that patients, or we want to know everything about those patients. So sometimes due to this issue only they are not going to take the consent, give the consent, but we try to manage it. Like we, if they are so adamant to give consent only on this point, then we said them that okay, we will show you the patient, but there will be no communication. Then related to the hospital or the medical, very less referral to transplant coordinators. Some of the consultants or neurosurgeon are in favor of organ donation, and some are not. So there are very less M1 patient or patient with low GCS score which are transferred to the transplant coordinator or are informed to the transplant teams. Inadequate awareness of the doctor and staff involved, as most of the residents are working, they will frequently change, staff will change, so they are not aware that when to inform the particular patient to the transplant coordinator or the transplant team. For that we do regular rounds through the various ICU, and we give some research work to the students over there, so that the staff and the doctors should be aware about when to call the transplant team. Even now we at night or even at any time we get some calls on our number that such and such patient expire 2 hours back, and DC is ready and all, you come and consult the family for organ donation. So people are not aware that when to call the transplant coordinator for organ donation. Patient not fit for organ donation, as most of the in public sector, most of the time usually patient remains in the triage area or the emergency area only, and with the embu bag, and as the stable increase in the triage area, there will be no oxygenation of the organs, or there may be chances of sepsis, and the patient will not remain fit for organ donation. So that's again a challenge. Maintenance of potential donor is also an issue. Initially, we used to visit all the pharmacy and the surgical items. Then we plan to make a kit which is having all the necessary items for maintenance of donor for next 48 hours. And limited resources, limited availability of ICU bed. There are no bed. We can't give bed to every patient. The patients are segregated as per their chances of recovery. Then and as per the age criteria, and the beds are given. So we can't provide bed to the every patient in ICU in the PGI or from the triage area. So there are limited number of ICU bed, and for that, as the patients were increasing, a number of organ donors were increasing. So we now reserve 2 beds for these patients, although they are used for other patients also, but they are reserved for the organ donor only. And poor management, quality of care of patients, and most of the time patients are not satisfied, or the relatives are not satisfied with the care of the patient they received in the triage area or the emergency area. And suddenly when they are going to say yes about the organ donation, they started receiving the VIP care. पहले उनको एक सेग्रीगेट कर देते हैं कि दिस पेशेंट इज़ नॉट गोइंग टू सर्वाइव, पेशेंट इज़ M1 और सपोज टू a potential brain dead patient. No, staff is so much busy and even neurosurgeon are busy. They put their efforts to for a patient to whom they can revive. And these patients get neglected in the triage area only. But when we counsel them, then that patient receive VIP care. It's again put a question mark in the minds of the family. Then COVID-19, we all know it's again a hurdle. It was a hurdle for 7-8 months when the transplant program was stopped. So it's and also there are some needs that there should be a recent COVID report with the patient. Some social issues, lack of awareness is there in the community. People are not ready to accept the brain death. Non-understanding of concept of organ donation. People are not aware till now about the organ donation. Long process of organ donation. Sometimes when we declare the patient dead, then they become so much in hurry. Okay, you declare the patient dead, give us body in next half an hour or 2 hours or 1 hour. But it's a legal and legal process, and lot of teams are involved. So it's a long process that we have to counsel family again and again, and we request them to wait for next 12 hours or 24 hours until the retrieval process get completed. Then negative influence, what people will think. Most of the family will say, okay, we are ready, but our community will not allow. और अगर हमने यहाँ पे डोनेट कर दिया तो लोग सोचेंगे शायद अब हम अपने पेशेंट के ऊपर खर्चा नहीं करना चाहते थे, जहाँ लोग बोलेंगे कि हमने उनके ऑर्गन सेल कर दिए हैं. So such a type of thing. So for that we involve the local leaders like Sarpanch or the other members who are the local leaders over there to come forward and to convince family for organ donation. Illegal trade of organ donation, it's always there. And family thinks their religion does not allow organ donation. Most of the family, some of the family from a particular religious group think that this organ donation is not as per their religious belief. Electronic media showing case of negative aspects, it's then positive aspects. Even if we are covering 100 news for organ donation in a positive way, if there will be only one news from the negative aspect, that will give more attention. People will give more attention to that news. So it's always a challenge in such cases. Then some legal challenges, that is act does not clarify many things. Like in the act there is next of kin available in the hospital, we can take consent from that. But that is not clarify who from from which particular person we can take the consent. And in case of married individual, consent to be taken by the spouse, that's again a difficulty. NOC from police, it's also a very problematic situation, even difficult than taking consent from the family. Family will be willing to give the consent for the organ donation, but taking NOC was very difficult from the police officials. So now we will discuss some case studies. There was a case of 16-year-old male with a history of ICH, then admitted to PGI on 12th Jan. And patient was, on the 12th Jan, history was on 12th Jan, then patient was referred to PGI on 14th Jan, immediately shifted to OT. But GCS score suddenly fall, it becomes 3, and patient was not get operated and shifted to the ICU setting. And on 17th, patient was suspected to be a potential brain dead donor, and first brain death declaration committee declared the patient brain dead at 9 p.m. And family gave oral consent for organ donation, as it was a first brain death declaration committee, so we take only oral consent. And second committee was planned on the next day in the morning, 9 a.m. Question was also there yesterday that if some movements come. So what's your opinion? Can we declare this patient brain dead or not? How many of you say that we can declare the patient brain dead? Who are in favor ki we can declare this patient brain dead? No, patient was already declared in first committee. It was the time of second committee. At that time, the patient started moving. In the same thing, our committee members were not in dilemma state only. Some were saying, okay, it's a spinal reflexes, we can declare the patient brain dead. But some of them not willing to declare the patient brain dead. So the second committee, there were some flickering movements, and committee people refused, that brain dead declaration committee refused to declare the patient brain dead, and they plan that, okay, we will again meet after 12 hours, let's wait for to stop these movements. But benefit of doubt is given to the patient, and committee was abandoned. And then we take opinion from the various experts from the neurology, neurosurgery departments. Even this video was sent to out of the country to the various experts to give their opinion whether we can declare this patient brain dead or not. All other mandatory tests were positive. Apnea was positive, Doll's eye was absent, cold calorie test was negative. But due to that, movements committee was not ready to declare that patient brain dead. Patient was in the same condition for more than a week, a tragic situation for the family, what to explain. It was my case, I explained to the family after first brain death, okay, patient is declared brain dead, but at the second committee, it was now more than 10 days. It was a very emotional draining situation for me and as well for the family. What to explain? Family was saying, okay, you are saying you are not going to declare brain dead, so our child is improving. But I can't say that we were in the plan that these are the spinal reflections only, and a patient, that child is not going to survive. And whenever, जब भी मैं duty पे जाता था, and before my reaching, they used to come in my room. वहीं पे मिलते थे वो हमेशा. Even I was so fed up with so much pressure was that we were not able to take the next patient. The bed was already booked for 10 days. Even all the resources were, that kit was complete. We have to bought such things from, we can't give any slip to the family to bring even a small thing, even a syringe, would not allow from a family if they once give consent for the organ donation. So all the, they waited, ma'am. No, ma'am, they were not ready. They said whatever happened, it will happen in the PGI only. Whether the patient had cardiac arrest, they will not take. Due to that movements only. It remains for 7 to 10 days. But opinion differed, ma'am. They were not ready to declare in such movements. So, but at the 10th day, we planned that let's go for the confirmatory test to take a final call on this. So scan. Major blood supply to the brain of this patient. But then also the committee was, as the role of confirmatory test is not clear in the act, then also committee was not ready to declare this patient brain dead. 50-50, ma'am. Two disagreed. And we asked from various neurosurgeons and neurologists, same opinion we received. Some were agreed, some were saying it's a spinal reflexes, some were saying we can't declare. So, so then luckily these movements stop on the next day of the confirmatory test. Then we again constituted the committee, and the patient was declared brain dead after 10 days. And we were lucky that family not withdraw their consent, and in the end they donated liver, bilateral kidneys, and cornea. And by collecting data from such 3-4 cases, we recently published a paper in Neurology of India that, and we try to convince that there should be emphasis on the confirmatory test, that there should be some role that on the basis of confirmatory test we can declare a patient brain dead. So this was published in this July only after taking data from such cases. So then the next case, it was a 21-year-old male, unmarried, with a history of RSA and head injury. And the patient was kept in ICU but declared brain dead on the 9th. And this is the brain dead declaration form of this patient. And after that, all the members who were available in the hospital were consulted, and all the male persons like father, brother, and whosoever were available in the hospital gave their consent for organ donation. This is the consent given by the family for organ donation of this patient. But being a MLC case, I contacted with the IO of this case to give us a NOC for organ retrieval, and that person or IO was not aware about the NOC, and so I call his senior official SHO, DSP and SP. This DSP was even he was known to me, but I tried to convince him, but even then he said ki I will not interfere in this, it's the solely the decision of the investigating officer. Even they were not aware, so they said the call will be taken by the investigating officer only. Even after efforts of 1 day, he did not give NOC. We tried for more than 1 day, or then also we were not able to convince him to give NOC for this case. And the patient was already declared brain dead. Only thing was pending that NOC from the police. And the father was in hurry to take the body so that they can do the last rituals. Forensic team, then we move forward and we ask from the forensic team that what we can do in this case. They said, okay, we are giving you the NOC, you can proceed for this case. But it was the first case where we were not getting the NOC, so we were not getting anything in return. So as a transplant coordinator, we thought that let's not proceed for this case. Then we again put pressure on this by including our medical superintendent and other officials. And when we put more pressure on that investigating officer, they took in written from, but he did, he sent some police personnel at the native place of that patient, and they bring the mother and the sister of that patient, who were even not aware about the condition of the patient. Like the father or the brother were calling, okay, he is fine, still in ICU, getting worse or whatsoever. They were not, the mother and the sister were not even aware about the condition of the patient, but that IO sent some police personnel at the native place of that patient, and they bring the mother and the sister in their police station. So just imagine that person is not aware about organ donation, but way of communication he may have narrated the news that your son is no more and your husband is going to sell the organs and all these things. So when we insisted more for the NOC, but he sent a official letter from the mother of the patient that she don't want to donate the organs of her son. So I was forcing him to send the NOC. Then he sent me this official letter that mother of such patient don't want to donate the organs of her son. So yes, ma'am. Yes, ma'am. Like yesterday we also discussed, ma'am, till 2020 we were taking NOC, but after facing such problems and after discussion with forensic team and the other legal authorities, now we change it to the intimation, information to the police. Now it's a information to the police. We take a consent from one parent, maybe father or mother can give a consent. It's their family decision, ma'am. If they want to withdraw the consent, then they can. But we can proceed with one consent from one parent. So, but in the end, father opted for Lama. He said ki even if agar to it was a RSA, the postmortem was mandatory to take any legal opinion in this. So अब फादर ने बोला कि अगर एक भी इंसिजन लग गया तो मेरी फैमिली बोलेगी कि आप ऑर्गन डोनेट करके आ गए. So then he opted for Lama, and we were not able to convert this case. यहाँ पे the father written that although we were agreed, but some of our family members are not willing to go for organ donation, and we want to take the patient Lama. So this was an unsuccessful case. We were not able to convert this patient as a donor. But after that, we lose, I think, 3-4 cases due to the police official, and then now we change it to the police information. Although I am not favor in police information, I am favor in taking NOC from the police. So still the debate is going on. Let's see what will be the ultimate decision. Lama, we send patient Lama. They take the body as such. It was a medical legal case, but they can opt for Lama. They can opt for Lama. They can take, ma'am. No, no, ma'am, it's not mandatory. Then police officials have to work, but they can take the body to home. So next case.
Technically speaking, if it's a medical legal case, you can't take the body lama. So there has to be a police intimation. Normally, whenever we face such patients who might not even be for organ donation, so first step is once such a MLC case is admitted, we send a police information form. As soon as the patient is discharged, we again send a police information form. In case the patient is going LAMA, there is a special form which is called as police abscond form. So we have to send the abscond form to the police. Yeah. Yeah, in medical legal cases, you have to inform the police. Lama is done for non-medical legal case. I can do a Lama for non-medical legal case. But if it's a medical legal case, it is my responsibility to make that patient stay in the hospital. If the patient is going against my wishes, I have to inform the police. So idea is to inform the police before the patient takes away the body. What do you have in PGI? Which form?
Sir,
which
we give LAMA, but at the same time, the police post is there. We inform them that the such and such patient is going.
Police information is very important because these are medical legal cases and you can be called, pulled up in the court.
We give LAMA, but at the same time, we inform to the local police post that such and such patient is going LAMA. So next case was a 34-year male with a history of roadside accident, admitted, referred to PGI on 3rd of March and declared brain dead in the next day in first brain dead declaration committee. Patient was separated from wife but not legally divorced. No contact with wife from last 2 years. Father was no more. Mother and sister of the patient was strongly willing for organ donation. So what's your opinion? Can we proceed in this case for organ donation? So in PGI, we always, if the person is married, we always go with the consent of the spouse. So wife was not there, she was not ready to come. So efforts were done to call wife, but she refused. So, but the mother and the sister were so much willing to donate the organ. They said कि हम organ donate करके ही जाएंगे. It's our wish. It's my son. You should proceed for the organ donation. So we were in a very different situation. Like mother is saying कि ये मेरा बच्चा है तो जो भी इसका decision होगा मैं ही करूँगी. But wife was not listening. She was saying कि she will not come in the hospital. So what was done, the petition was put in the court by the mother. We help her in this case to put a petition in the court. And the court issued order to call wife on the next day. And the wife appeared before court on the 6th March. And then the lawyer asked her regarding the organ donation. Then she again refused that she is not going to give consent for organ donation. उसका सिर्फ एक ही consent था कि जो मेरी लॉज की फैमिली ने बोल दिया मैं उसके उल्टा जाऊंगी. अगर वो बोल रहे हैं कि organ donation नहीं करने तो मैं बोलूँगी कि करने हैं. But if they are saying कि organ donate करने हैं तो मैं नहीं करने दूँगी. So it was just a tussle between both the families. And then they started कि शायद इन्होंने खुद मार दिया या इसने एक्सीडेंट करवा दिया, and all these angles came. So what the court said, then she refused that I am not going to give the consent for organ donation, but the court decided, okay, if you are not going to give consent for organ donation and the patient is already declared dead in first brain death declaration committee, then you are going to bear all the expenses until the patient will remain in the hospital. So they ordered to the wife that if you are not going to give consent for organ donation, okay, then it's not the responsibility of the mother only that she is going to bear the expenses. You are going to bear the expenses till the heart is beating or the patient will remain in the hospital. Then the wife said, okay, give me some time, I will think and give my decision. So in the court only, I think spent 2-3 hours with the wife of that patient to explain about the organ donation, that okay, give consent, otherwise all these things will happen, he's not going to survive. But in the end, that she gave consent, okay, you can go for organ donation. And these were the court decision. In that they said, okay. Yes, ma'am, it's available. And then when I think we spent two days in the court only for this case, and when we received the order, then there was some mistake. We received the orders, okay, you can proceed for the organ donation, but there was a mistake. The judge in that statement they wrote, you can take organs after postmortem. So as soon as we reached PGI, we got a call, there is a problem in the order, so you wait for more for 1 day. So again we wait till the court will open on the next day, then they correct it, okay, you can take the organs, and then the postmortem should be there, but it should be done by a board, as the wife was claiming. So thanks to the ICU team that they were able to maintain that donor. So this was a successful case. Next was this case is already discussed that from a particular religion, this was a RSA roadside traffic accident admitted to PGI, kept in ICU, declare brain dead in first brain dead declaration committee. Patient belonged to the Muslim community, and we were very hesitant to counsel these families. हमें जब भी हमारा एक्सपीरियंस होता था कि दे डोंट वांट एनी कट एज पर देयर रिलीजन ऑन द बॉडी ऑफ देयर पेशेंट, एंड दे यूजली इवन इफ ए मेडिको लीगल केस दे ऑप्ट फॉर लामा, दे विल नॉट गो फॉर एनी इंसिजन और द पोस्टमार्टम ऑफ दैट पेशेंट. But as per their religious taboo, they don't go for postmortem, and only in the initial meeting, I just explained the prognosis to the family that your patient is not going to survive. But while I was explaining the prognosis to the family, I find a sport person. It was a sick landlord where this family was working in his house. So after few hours, we gathered some courage and start talking about organ donation with that person. Then he convinced that family that okay, this is one possibility is there, you can donate the organs of your father, or to his wife also. He motivate, and then family show some reluctance due to religious basis. Then we call the local religious leader, Maulvi was there. Then we have some conversation with him also, whether they can go for organ donation or not. But in the end, they shows interest and they gave consent for organ donation, and this was the first case in PGI where a Muslim family gave consent, and after that we use this case as an example, and there are more 5-6 donations from such community. So this was the nice media coverage at that time, that convinced by a Sikh Muslim family gave organs and saved the life of a Hindu family. So in the end, just a request that if you are going to spread regarding organ donation, also work to spread news on skin donation. It was recently launched by us in PGI on 13th August. So it's a request to spread this also for skin donation. Skin bank, ma'am. We are starting this skin bank. Thank you.
Thank you so much, Navdeep. Such interesting cases. Any query? Anybody has any question related to the cases that Navdeep has explained? If none, thanks a lot.
Thank you, sir.
Excellent selection of cases, Navdeep, I must say, and very informative, educational, as well as creating awareness. There are so many points which are getting cleared in all of us, whatever doubts we have. I'm glad you brought these cases to us. Thank you so much for that presentation. Are there no questions? Everybody seems brain dead. Or all of you are exhausted on day 3? Okay. No questions at all? Yes. बिल्कुल होता है, खूब होता है.
Most of cases, ma'am. ऐसा केस मैम नहीं आया कि आफ्टर डोनेशन वी डोंट फील सच सिचुएशन, बट इफ लोकल leaders or something get involved and they are saying a negative view about the organ donation, then we said family, then whenever you want, we will be there. From PGI side, we will be there, and we try to put a stall on the last religious rituals of that family. so that of that person, so that we can clear the doubts of that person also. So we give them all the support they want from us.
Thank you, Navdeep. Thank you. So after that, I think we have some interesting quiz or pathway. So Sujata would be discussing some interesting group activity with all of you. But before that, Sujata, I would just request you to be here because you are the one who remains to be felicitated. We have been you have been taking so many lectures for all of us, and I must not miss this opportunity to felicitate you in person. Thank you so much.
Thank you so much.
You're most welcome, and please go ahead with your pathway group activity.
Four groups. Four groups. One can move there. Other group can come here because you might require a table to arrange your cards. And two more groups. You can stay there, or you can, if you don't mind, you can use even the floor if you guys find it convenient. Okay? Okay, just stand there. Okay. So I'll just explain to you, just 2 minutes. Each group will be given a set of cards. Each set will have about 30 cards. Okay. So you just need to arrange the cards in order. For example, card will have first brainstem death, one card will have postmortem, one card will have handing over the body to the family. So steps are written in each card. So you have to, whatever order you think is right, you have to place them in the right order. Clear? That's it. Very simple instructions. 30 cards, you just need to place them in order after discussing with your own team, right? Okay. Here. Each set would have some empty cards. Just keep them along with it in case if you lose, we can always write it. Yeah, this is the second group. Here your card set. Okay, that's a third group. Okay, where's the fourth group? Fourth group. All right. Okay, you'll get exactly 15 minutes. As long as you guys don't put postmortem as first step, I think we should be happy. So please read the steps properly and put them in the correct order.
Only 2 minutes more. Rush. Be fast, organize and अगर इतना टाइम लग रहा है तो फिर कुछ गड़बड़ होगा. It should not take so much time. So time is up. Time is up. Please stop. Where is Sujata? Where is Sujata? So time is up. So everybody please move away from the tables.
Okay, I'm not going to check. You guys are going to check. I will show the right order. But before that, one representative from that group come and check here. One group from here go and check the other group. One of you go to the last group and one from last group come to that group. Is that clear? You guys are checking yourself. I'm not checking. Just take one person come here. Come and check how your other teammate has done. Who has gone from here to there? Did they understand?
First, all of you leave your tables. Please move away. Please move away from the table.
Sit.
Sit down.
Either
Move away from the table, and now we can have one person from that table come here. You are already here from that table? Okay, so one person from that table comes here. Rashi, tum aa jao. Come on. He is there? Come. Nahi, aa jao. So one person from here goes to this table. To check. Chalo. One of you go to that last group, and from the last group, one person comes here.
Okay, anyway, I'm showcasing the
Rest of you go and have your seat.
Can you please
Connect the laptop.
So how was it?
So one person from the last group come here.
Okay, was it confusing? Didn't know which direction to move? Exactly, that's what will happen when you work on the ground as a transplant coordinator. You will have multiple people calling you, asking you, come this, do that. So you just need to have a flow chart for your own, understanding, and better to have a SOP to work around. Okay, so I'm just going to show this flow, However, this is very dynamic depending upon your institution. It's not like nothing is written on stone. So there will be some slight changes. Right. So first, what is important before even we start talking about anything? Case history review. I guess all of you got it right. Pretty much all the group had that as a first card. No? Right. Okay. Second, diagnosis and imaging present. Rule out contraindications involved. So then the message is coming from the treating team, either from an ICU nurse or from an ICU specialist. The message comes to the transplant coordinator stating, see, we have a patient potential brain death. All the contraindications are ruled out. Come and let's discuss. And then simultaneously the optimization, because just now Navdeep said, right, we need to keep maintaining the donor, potential donor, anyway from 24 hours, sometime till 10 days, he said. So donor we can't be just jumping into it at the last moment. So ever since you identified brain death, the focus changes from resuscitating the patient to optimizing the organs, because the complete goal change. We can no longer save the patient. We are completely focusing our efforts towards optimizing the organs for the purpose of donation. So donor optimization, first brainstem death testing, then breaking bad news. Who breaks the bad news? Coordinator? Doctors. So the breaking bad news, always the death of the patient has to be declared to the family by the doctors. The transplant coordinators step in and reassure and give any additional information if required. Okay. So breaking bad news by the doctors, and then inform the state authority stating that whether donation happens, consent happens, all second step. First inform them, hello, I have a potential donor and these are the details. Right? And then fill deceased donor evaluation form. Please check out your manual. It will have, it's not standard one in the sense like whatever we felt important, we had put together. Again, as I said, depending upon your state protocol, hospital protocol, devise your own evaluation form, because each time you can't be going and checking out something on the case record, you know. So it's better if you fill out a form as a protocol. I think yesterday the anesthesia head from, intensive care head from PGMR, she said, right, like they have devised their own protocol, 2-hourly, 4-hourly. Similarly, you have a index sheet and what details to be noted, everything you please make it down so that you can, instead of calling and saying over the phone, you say 60 and that person will hear 16. Why should that problem? You just take a photo of it, post it, and then it goes clearly. So for that purpose, it's better you always have a protocol, write it, take a photo and send it, because oral communications many times, even if we type, instead of 1.6, we will type sometimes 1.6. There's a large difference. So we shouldn't be making all those manual errors. So it's better if we devise a protocol, write it, post it in the groups. And then, meanwhile, wait for second brainstem death testing. As everyone said, legally we are supposed to talk only after the second brainstem death testing about organ donation, because the patient is legally dead only at that time, because second brainstem death timing is the death time, right? However, we do not want to waste that gap of 6 hours, and that's the reason we go and talk to the family, and if possible, we'll take the oral consent. Otherwise, paper-wise, we have to start conversation only after the second brainstem death. It varies from families to families always. And conversation positive, meaning the family says yes. What if they say yes? Again, inform to the state authority. The family had said yes for organ donation. Continue the donor optimization and complete the Form 8. If you had put complete Form 8 donor optimization, that's perfectly fine. Collect the cross-match sample. This is something many a times will end up in problem. Again, depends. See, the patient has to be declared dead. The family has to give consent. Only then any sample is legally allowed. We can't be taking the sample for cross-match even before we get the sample. Consent. Sometimes if something goes out of your way, family will be thinking, oh, this is your intention. So we shouldn't be in that way. Always please try and follow taking the samples after the consenting process. Police intimation form. Remember yesterday Rajinder was saying Police intimation, which will go along with the organ functional status, because police is going to be in touch with the forensic, and forensic has to decide, he needs to know how these organs are first of all functioning. So police intimation and then complete the organ functional status. Then it goes for the forensic, and forensic gives the permission. Then we again inform then the recipient coordinators, because by then the state authority would have allotted. So we have to go and tell them, yes, we also got the police MLC clearances are done. Now we can start the other procedures. Inform the OT, confirm the knife time. Again, it's very important, because if you are a coordinator working with like multiple teams, kidney, your own in-house team, organ is going out, for example, they say like the other day, they transported the heart to Delhi, and the other donor transported the liver to Jaipur. So those teams to be consulted before we fix up the knife time, meaning the retrieval time. Depending upon also the family situation, patients, donors' stability, multiple factors we need to think and then confirm the knife time, which will be convenient to all of them. Shift the OT, heart team. If there is heart donation, then heart team leads. Cross clamp time noted. What is cross clamp time? Somebody was asking yesterday. What was cross clamp time? When? Why it is important? Why we need to note the cross clamp time? Why? What ischemic time starts? Warm ischemic, because they want to try warm ischemic time as short as possible. So that's the reason they always note down the cross clamp time, and then perfusion starts. And then again, remember somebody said, once they retrieve the organ, they'll be in such a hurry to leave the hospital, and they won't sign who took which organ. When you shift the body to the postmortem, the forensic person will write organs are missing, because there were no papers, right? Like how does he know whether the organs were retrieved or not? So that's very important. We always, as donor coordinator, we need to, because people will be in such a hurry, they'll be in their scrubs, everyone will look similar to the other, they'll be wearing their masks, you do not know who's stepping out. So we need to be absolutely, on focus to get these signatures before they leave the OT. Then body is shifted for postmortem to the postmortem. Body sutured and cleaned up. Respect is paid to the donor by the hospital people, and body is handed over to the family. Right? So some clarity now? Yes, no? Okay, this will be passed to you in your WhatsApp group, don't worry, okay? Just steps.
So that brings us to the end of the day.
If you say so.
Okay. Thank you so much. Just one announcement. Tomorrow we have the conference dinner at Hotel JW Marriott, which is located in Sector 35. So all of you are invited there. Please bring your tags. This is one small request. So dinner begins at 7:30 p.m. onwards. Okay? So everybody should be there, and if we find a good place there, we can have a group photograph. So come rocking. Okay? Thank you so much. You have been a wonderful audience, and all the mentors and all the teachers have loved talking to you.
So this is my last day. I won't be there for tomorrow. So wishing you all a very best and happy learning. And all of you take 1 spoon extra of whatever food that you eat on my behalf. Okay? Enjoy your dinner tomorrow. Thank you all.